Welcome you all to a stage which is set with a cricket pitch on one side and a healthcare related backdrop on the other side. I hope my august audience is excited as soon the event is about to begin. A very good morning to one and all. Ladies and gentlemen, I, Dr. Anuradha,
and me, Professor Bijoya Bhattacharjee, welcome you all to this unique international conference of Daycon 2023, organized by Day in observance of World Diabetes Day. This conference scientific update is recognized by International Diabetes Federation by Southeast Asia and intends to enhance knowledge of recent advances in the field of diabetes management for healthcare professionals. An empowered diabetes management team can only play an important role in making India as diabetes care capital of the world.
Now, as the World Cup fever is all around, we all know how exciting a cricket match can be. Just like that, we also know how crucial health is in our lives. So today, we'll explore the similarities and connections between these two worlds. Just like in cricket, where the toss sets the tone for the match, our health choices can determine the outcome of our lives. Let's take a closer look. We are now at the toss, a moment of great anticipation in any cricket match. The team that wins the toss has a strategic advantage. And in healthcare, the choices we make are just as important. Imagine your daily decisions as the toss. Choosing a healthy diet, regular exercise, and preventive healthcare can put you in the driver's seat of your life. So let's get into the most exciting toss session, where I welcome you all to our extremely prestigious Daycon 2023. Let's applause, and with this, I once again welcome you all to the onset of our most awaited unique international conference and request Dr. Sujoy Majumdar, Vice President, Day and Convener, Scientific Committee, Daycon 2023, to please be on stage for the welcome address. Please, sir.
Thank you, Bijoya and Anuradha. And it's my proud privilege to invite all of you to this wonderful session of cricket cum academics. So if you go through the program, you'll find out that we have designed the program keeping in view our World Cup fever going on at the moment. So, and we have got a host of good topics. We have got good bowlers, we have got good batsmen, and at the same time we have got good umpires also as well, some of whom are present here as well. So, without wasting much time, I would invite you to the first session of Power Play, and I would invite also at the same time I would invite the two speakers, Dr. Amit Kumar De, to come to the stage, and also the chairperson, Dr. Biman Mondal and Dr. Tahir Hussain. So the introduction will be given by our compeers for the session today. Without wasting much time, let us start the match on time.
As the game progresses, we come to the power play round, a time when the batting team aims to maximize their runs. Similarly, in healthcare, there's a power play round, the early years of our life. This is the time to invest in our health, regular checkups, vaccinations, and a strong foundation of healthy habits set the stage for a successful and fulfilling life. During the power play, every run counts, and each wicket taken is vital for success. Just as in life, every healthy choice you make during your power play years can greatly impact your overall well-being and longevity. So let's call on stage our eminent power play batsmen, our eminent chairpersons, Dr. Biman Mondal and Dr. Tahir Hussain, with a huge round of applause, please. Let me take the honor of introducing Dr. Mondal and Dr. Hussain in short in front of our august audience. Dr. Mondal, sir, has done his MBBS MD in community medicine. He has done his MPhil from BITS Pilani, and he has done his Masters in Medicine in Family Medicine, CMC Vellore, and has done CCEBDM from Public Health Foundation of India, New Delhi. Moreover, he is having more than 20 years of working as public health activist in different rural sectors of West Bengal. Presently, he is working as senior specialist medical officer, Department of Health and Family Welfare, Government of West Bengal. About Dr. Hussain is a critical care physician at Desan Hospital, Kolkata. He is an ex-medical affairs professional in Abbott Roche BMS, and he is also an executive board member in Diabetes Awareness and You. So over to you, sir.
Yeah. So thank you, Vijay, for your kind introduction. Now, good morning, entire audience and faculty. So today we started in this session where I would like to welcome our three eminent panelists, where we are planning to discuss mostly the role of AI in the diabetes management and subsequently uses of insulin in early segment and followed by the diabetes therapy and women. So for this, all this discussion, we have eminent speakers and faculty. I just, want to discuss the thing to Dr. Biman also.
Yes, our first speaker will be Dr. Amit Kumar De.
Yeah, so Dr. Amit, there are a lot of the things, awards, wings in his cap already, but the one thing that I want to tell about Dr. Amit is like, he's one of the pioneer where we all know that a lot of AI thing is happening across the globe, but how we are utilizing this AI into our clinical practice, that's the thing, that the main learning from Dr. Amit's session today. And presently, he is winners of lot of fellowship, degrees, associations. He's the member of lot of faculties. So with all those things, I just introduce him into the table and for podium. Yeah. So
I think we will be enriched by a very captivating session and inaugurating presentation by Dr. Amit Kumar De. Thank you.
Thank you very much, dear chairpersons, for that humble and kind introduction. A warm good morning to all of you. At the outset, I really congratulate and at the same time thank Mr. Majumdar, Professor Majumdar, and of course Dr. Mary De Cruz for the kind invitation and for setting up this fantastic environment of medical discussion. So I presume that we are playing the power play session, and we have to hit the ball hard. And in diabetes, we say hit the disease hard before it hits you. And I will not take you to the era of Star Trek, although we are starting with a lot of high-tech things, and artificial intelligence is what I'm going to speak to you about in the next 15 to 20 minutes. But I can tell you that AI is the next best thing that can happen to all of us. It's a revolution that is already there. And it's only a matter of time that we are all going to be dealing with AI-powered tools in your pocket and in your clinical practice, which will just enable you, or rather empower you further to hit the disease more hard in the right time and give better clinical outcomes. So with this introduction, let me take you through a bit of understanding of what artificial intelligence is. I do not have any financial disclosure or any conflict of interest with whatever I will be showing you in the next 15 to 20 minutes. And I will be kind of splitting my talk into three sections. In the first section, we'll be speaking about understanding or decoding artificial intelligence. The second section is, of course, the crux of the matter, that where we can use AI in diabetes of metabolic care. And then we kind of try to answer that million-dollar question, that will AI be replacing all of us sitting in this room? So what is artificial intelligence? It's basically the ability of the computers to kind of take data, create the information out of it, and then create an intelligent knowledge. That's what AI is all about. It's understanding, learning, and reasoning to make decisions to solve various problems. AI is the present and the future of healthcare, not just in healthcare, in various other sectors as well. It is rapidly evolving in the medical landscape in the form of personalized treatment. I'll show you some examples. In virtual health assistants, virtual chatbots, advanced medical diagnosis. In medical imaging, it's already profoundly being used. In predictive analysis, that will play a very important role in diabetes care. In drug trials and drug discovery. In optimizing personalized treatment for the patient. In optimizing surgery along with robotics. And of course, integrating it with telemedicine towards remote AI monitoring. So these are the aspects in which artificial intelligence can be used. We are in the era of machine learning, and generative AI has just come into existence. And what we are expecting is we are going to probably by 2030 go into the era of artificial general intelligence, which means that the intelligence of the AI tools will be at par with human. And then, of course, we are probably hoping, or we are probably expecting that someday we will see artificial superintelligence, which is machine consciousness. Let me decode it a little bit better for you. So what is AI? It is mimicking the intelligence or behavioral pattern of humans or any living entity. A subset of AI is machine learning. That is a technique by which a computer can learn from the data, relearn, take the information, and give you a better output. There are various examples of machine learning, which we are not going to go much in details. And a section of the machine learning is deep learning, which is basically connecting the neural networks, just like the neural networks of our brain, and it gives you certain output. If I decode this further, you can see machine learning is kind of divided into supervised learning, unsupervised learning, and reinforced learning. What does these mean? These are terminologies which basically means you're supervising certain labeled data you're giving, and it is giving you certain labeled outputs. When it is unsupervised learning, you're letting the computer algorithm learn and relearn based on the output that it is generating, and a combination of the two will give you something called reinforcement learning. Artificial intelligence, a subset of that is machine learning, a subset of that is deep learning, and a subset of deep learning is generative artificial intelligence. Is something that we are now quite hyped about, ChatGPT. How many of us in this room has heard about ChatGPT? How many of us is using ChatGPT? Anybody? Okay, some. So we have a fair AI literate audience here. And there is something called Midjourney, which can give you images, and also DALL-E and Stable Diffusion is already there. So, in AI algorithms, we started with the era of case-based reasoning, rule-based reasoning. So that's a 1:1 problem solving. From there, we went into the era of machine learning, which is data-driven precision medicine. There's also something that we need to understand, general AI versus narrow AI. So narrow AI means you're creating the algorithm to just take out some specific task. Okay, just for screening of retinopathy. So that is just a specific task, whereas general AI is multimodal. So it can do variety of tasks, something like the use of a generative AI tool like ChatGPT in healthcare. Okay, so these are the different types, and understanding a basic overview of AI, which we should know before we get into the depth of AI. So if you look at the history of AI, the famous Turing test was done in 1950, although that doesn't hold true at the moment in the era of generative AI. John McCarthy was the first person to coin the term artificial intelligence. And then there was a waxing and waning phase in the development of AI. There was two AI winter, one in 1970 and then one in 1990. And then machine learning was developed in the 2000. That was again a big change in the history of AI. And finally, in 2022, a big change happened, that is generative AI. OpenAI was made as an open access, and that brought a huge revolution and a huge hype in the community worldwide. So the question we need to ask ourselves is, why are we speaking about AI in a diabetes conference? So why would we use AI, or why would we contemplate using AI in our practice? I'll give you 6 reasons. 1, it elevates clinical performance. This is something that we are all going to experience over the years. We have come from an era of, rather we are still in an era of evidence-based medicine. We are going to go into an era of data-driven, intelligence-based medicine. So there's going to be a transition phase that we are going to be, and that will definitely improve our clinician performance. That is very, very important. It will escalate discovery of new therapeutics. If you have heard of AlphaFold by Google, that's a fantastic way in which drug discovery can be augmented and newer tools can be brought into existence. And it will just fast forward the clinical trials that we see happening in our current day. It will disrupt the traditional research paradigm. This is very important to understand. If you look at the hierarchy of evidences, the clinical trials, the real-world evidences, the epidemiological studies, perhaps the entire hierarchy will change when you're using data-driven research. Because in the normal research that we do, it's driven from top to down approach. In data-driven research, the approach is going to be bottom-up approach. So the entire way in which research is conducted and research is carried forward, it's going to probably change with the use of AI algorithms. This is going to be very important reason why we should use AI. Precision medicine and population health will definitely create a transition from evidence-based to intelligence-based medicine. And you can see here that this information and knowledge gap, we don't practice what we preach, but this AI tool is going to actually help you out to practice what you preach, because you're going to be driven by continuous dynamic data. So that is going to be a very important change in the way we practice and perceive clinical medicine, perhaps in the days to come. The other reason is something which is very close to me, and I'm very closely working on this, is that it will neutralize human biases. We know something called confirmation bias, right? What we see is what we tend to believe in, and we stop thinking about the other possibilities. And also when you use AI, you are in a risk of having automation bias, because if you're always automated, you will end up losing your cognitive skills. So we have to merge the two, and we have to come somewhere in between. So a neutralization will be required at this point of time, but definitely cognitive human bias can be taken away in clinical practice with the use of AI. And the sixth reason, as I said, evidence-based versus intelligence-based medicine. This is what we are heading into probably in the next 5 to 10 years. It's not very far away, I can assure you that. Few terminologies before we go into the details is generative AI I've already told you about. It's basically a way to create patterns, images, sounds, or text from the input that you give. The science is generative AI. The use of generative AI is done using large language models. And the technique in which all this thing is done is called natural language processing. In generative AI, you need to learn something called prompting. That is the art of giving the input to the ChatGPT algorithm or to any other generative AI model, and that is called prompt engineering. And if you don't give a good prompt, you end up hallucinating the system, and it gives you wrong output. That's called garbage in and garbage out, and that is called AI hallucination. Now let's come to our context of health. So where will these health data come from? It will come from various sources. So from the labs, the genomic data, the imaging, the medical records, the medical wearable devices, and also the various other sources of data like your mobiles and the sensors and your continuous glucose monitors that you wear. All this will kind of keep on giving you this big data. But what is to be done with this big data? The data has to be cleaned and it has to be structured. And with that structured data, you can do a lot of good. You can kind of create a whole new set of algorithm and get a complete different overview of a disease that was probably not picked up earlier, or the pattern was not picked up. So how does it work? You take the inputs in the form of text, image, and biometric data. You analyze them like rule-based reasoning, like machine learning, like deep learning, and then you classify them and predict outcomes, or you generate images and text using generative AI, and it always has a control and a feedback mechanism by which it teaches you. So generative AI is something which I've already told about. I can't cover a lot of it in one section, but it is something that we are going to be using. If you, at least if you've been attending this lecture today, you'll go back and click on openai.com and you will kind of try to see what exactly ChatGPT is. So this is what OpenAI had developed. It had developed a foundation transformer model, and that is now has got multiple developments and upgradation. So this is how the ChatGPT model came into existence. It was initially had a pre-training model, and then there was a fine-tuning which took place. Understanding of the text was there, and then generating human-like text using natural language processing. And finally, the iterative refinements were done. The more inputs you give, the more refined outputs you're going to get. The new feature of the paid ChatGPT, it costs about 2,000 rupees per month as a subscription, and it gives you various plugins which can help you a lot of assisted tools. You can analyze research papers, you can kind of comprehensively review a PDF, and then you have the advanced data analysis which kind of actually helps you in research. I'll show you how I've used analyzing a CGM graph using ADA. And the combination of ChatGPT with Microsoft Bing was giving you the latest output. Whatever input you get, the output will come from the Internet of Things because it is integrated with the Internet. So how do we use AI in diabetes care? So first, let's understand the challenges. Early disease detection is a challenge. Medication adherence, lifestyle changes, monitoring of the blood glucose, cost of care, education gap, psychological impact. These are all the challenges that we know that exists. Can AI bring some solutions? Yes, it can bring, like in disease prediction and risk stratification. In lifestyle guidance in terms of patient self-management app. Insulin pumps already has AI enabled algorithms, and in screening of monitoring and complications, like in diabetes retinopathy we are using, and in clinical decision support system, which I will give you an example. In disease prediction and risk stratification, what we are going to basically see is the data will be captured from the electronic health records and the medical records. A data mining will be done, and then the data is going to be cleaned, and a structured predictive analysis can be done, which can be actually taking you ahead with the output that you're going to get, or with the recommended treatment that you offer to your patients. There are various lifestyle apps, and if you have gone through the Look Ahead trial, that has used machine learning to reanalyze data, and it confirmed that type 2 diabetes patients can benefit from intensive lifestyle intervention, which is basically intervening their behavioral factors and making a statement on their behavioral intervention. Various apps are there, and apps are being built every day, and you can just go on your Play Store or just search up on the Google. You will find so many apps which are there integrated with AI for better lifestyle management in diabetes patients. So again, these wearables are there which basically pick up the data, and that can be your smartwatch or your smartphone or the smart ECG sensors, which are very soon going to come. Even we're going to have some smart socks to detect foot pressure, and that would be very useful in kind of screening for diabetic foot problems in patients much early on in the disease. In a way, what we learned in community medicine, primordial prevention, and that is what you're trying to offer to your patients much earlier than the disease happens. January AI is fascinating. Last 2022, January, this was launched, and what it does is that it takes a CGM graph of 14 days, it feeds the algorithm, and then you don't need to wear the CGM thereafter, but it keeps on giving you outputs and recommendations based on the CGM pattern. So what it is doing, it is recognizing a pattern. Okay, so you wear a CGM for 14 days, but even when you're not wearing the CGM, it's recommending you that, look, if you eat this at this point of time, your sugar may spike up to this. This is based on your CGM pattern. Imagine the power that it will have in improving the behavioral change in the patient in day-to-day diabetes care. Digital twin, you must have heard about some of our senior colleagues working with the digital twin technology, and that is going to be, again, a very important game changer, because it's just going to be mimicking your own self, whether in terms of nutrition, in terms of behavior, in terms of your medication performance or compliance to medicine, and how the medicine is impacting your body. And that is how you're going to get more personalized precision medicine. Automated insulin delivery is already there, and the algorithm which is used here is basically called the Model Predictive Control Algorithm. The MPC algorithm is used. This is very much there in the latest 780G model of the Medtronics. So this is the Minimed 780G, which actually has got the AI algorithm, and the output is far better. I will show you one of my patients. This is one of my patients on a Minimed 780G, and look at the time in range which the patient is getting, 100% time in range, something that we couldn't even imagine. But just because of an algorithm-guided titration and closing the loop, the patient is achieving a TIR of 100%. And Guardian Connect is another one, which again, it's similar to January AI, where you kind of get those low sugar, hypoglycemia and hyperglycemia peak predicts based on the pattern of the glucose, which is picked up by the AI algorithm. Earlier this year, actually, FDA cleared Beta Bionics insulin-only islet pancreas. This was again a big achievement there, because this was the only insulin-only islet AID system is indicated for people with diabetes, type 1 diabetes, aged 6 years and older. And this was again a good, fast forward in the field of diabetes care using AI technology. AI will always get integrated with CGM. It's just a matter of time. These are some research papers which I'm showing you, but it will definitely come in the days you will have a CGM integrated with AI, and as a result, you're going to get outputs giving recommendations to the patient. So it's just not you get a value and you have a self-interpretation, but AI-generated interpretation will also be coming in. And this is probably how the machine learning or the generative AI layers will be using in AI in CGM. This is what I did. I've been using ChatGPT 4.0 for about a few months, and what we did is that we took some CGM graphs and we asked the advanced data analysis to analyze it for me. And look on the right, this is the ADA algorithm which it has created, and it gives a good understanding of the CGM graph. So imagine this kind of an algorithm being created and given to a patient for better understanding of the continuous glucose monitoring graphs. In diabetic retinopathy, AI has been thoroughly established, and this is an area where we have been working on very strongly. It uses deep learning using artificial neural network. So it is basically looking like a 5-minute test, but trust me, a lot goes on beyond that. The first stage is data gathering. So all the data are taken. You take multiple images of the retina and you take it and you collect the data. Then the data is labeled. So you label the data as to this category of images corresponds to grade 1 NPDR, or this looks like a dot hemorrhage or a blot hemorrhage. And that way you categorize the images. And after the labeling is done, it is run through multiple layers of iteration. I think this needs to be plugged into power. And that's a glitch of technology. Look, I mean, it gave a warning we ignored. The power connection is gone. So I'll continue. I think we will not be wasting time. Yeah. So the more the layer of iterations that you see in whenever you're putting these images, the better you're going to get the exploring is the use of generative AI with pattern recognition algorithm in diabetic retinopathy. So what do is basically it imposes a synthetic data on top of the real image data, and that improves the sensitivity and the of that particular pattern. So this is how the output looks like. These are some of the AI-based images which I've captured in my clinic, and this is how there. It's quite it's not working. You need to. So maybe. So going ahead, I'll continue. I guess it's time. So going ahead, what we did was we took a subset of patients. We run as like we looked at the 5,000 community screening, and we were looking at the retinopathy in the community. So it was a community screening we did. We took this fundus camera and we scanned people at large. We obviously of them did not know they had diabetic, and there was a substantial number of people, I'll show you that paper we published, who were actually, and they had evidence of diabetic retinopathy, not sight-threatening, but evidence of diabetic retinopathy like mild to moderate NPDR changes, sort of scans that came out. And we did another study along with this, is that presented that in ATTD in Berlin last year, is that we kind of took we had that analyzed using the AI, and then we had an ophthalmologist compare those images, and we picked up the sensitivity, and the specificity is almost 98% of these AI generated images when it was compared to that as interpreted being. Beyond diabetic retinopathy, there are several aspects. I wish I could show you the images, but once we are back, I'm going to. Beyond diabetic retinopathy, there is also the use of artificial intelligence in diabetic foot disease. Again, it uses the concept of. Now, lately, you have seen there is a paper which showed that 10 seconds of voice can help you in screening. What it is doing? The only way it is doing is basically, it is picking up a pattern from the machine learning algorithms. Senior clinician, earlier days when clinical medicine, we didn't have so much of diagnostics. How did we used to evaluate a patient and come to right? Even clinical medicine today, we are following a pattern. And it is the same kind of a pattern, something that is not visible to do, but the machine is able to do, that it is picking up from your voice that yes, you have a chance of is safe from developing diabetes. In that same way, pattern recognition algorithms can be used in diabetic retinopathy, can be used in diabetic foot disease. In diabetic foot disease, various studies are going on. What it basically does is it takes the thermal imaging of the feet, and then it, okay, we are back. Will it stay? Lose hoche kotao. Okay. So I will just go back where I was. Yeah, this was the paper I was talking about. We published this in ATTD, and we looked at the prevalence, and then we compared the sensitivity and the specificity of the images. And this was the 5,000 patient sampling we did in Chandni Chowk. And look at the prevalence of diabetic retinopathy. It was 13.7%. And that was quite a lot in a community screening. We found that out last year. So this was AI-based smartphone camera, which enables, just takes the thermal imaging, and it gives fantastic recommendation as to how soon the patient will develop a foot ulcer or a neuroischemic ulcer in the foot. And then you have smart insoles. So what does the smart insole do? It kind of picks up your pressure points. If you're walking with more pressure on your heel or on your tip of the toe, it will pick up where your pressure points are, and it will give a predictability as to which portions of your feet have got a more chance of developing a callus or a corn or an ulcer. I mean, imagine this. This is just a preventive, more advanced way of preventing diabetes complications in the days to come. Clinical decision support system is what all of us are looking forward to. Can it really come into our clinical practice? It is there. There is something called DreamEd. You can Google search this, and this has received FDA clearance both for the treatment of type 1 and type 2 diabetes. It is an AI-based clinical decision support system, basically a virtual endocrinologist, and it is an FDA cleared, and it has got, I know the co-founders, and they are doing fantastic research work, and they have even decided to pilot a few work with us, and we are expecting, very soon that this might be available in other countries as well. At the moment, it's available only in the USA. AI comes with a lot of limitations. Do not take AI in face value, right? Some of the limitations will be accuracy concerns, data privacy, patient reliance, miscommunications will be a big problem. Most importantly, doctor reliance and patient reliance. And lack of personal touch will be a big problem. Regulatory challenges will always be there. So proper ethics and regulations will have to be kept in place for potential use and ethical use of AI. But these ethical considerations should not set us back. Data privacy will be a problem. Informed consent needs to be taken. There has to be a transparency between the healthcare provider, the AI provider, and the doctor in the days to come. And all these should not kind of hold us back in adopting a new technology that is there at our hand in the days to come for better clinical outcomes. The last section, and I will complete in the next 2 to 3 minutes. Will AI replace physicians? Now, these are some of my takeaways in the last, couple of years that I've been exploring AI. First, we need to understand that artificial intelligence is no longer a science fiction. It is a reality. AI will help clinicians make more informed decisions using precision technology with the results derived from various analysis. A human touch is always required in clinical practice, and in fact, AI will improve that human touch. It will help you spend time with your patient rather than typing the medical information in the computer or scribbling it down in the pen and paper. Patient counseling will improve, ethical decision making will probably improve, and it will help physicians navigate complex cases in a better way. So AI and physician collaboration is needed, so AI assistance can be used, and a successful collaboration will be possible if we integrate the two together. But what is very important is AI literacy. We need to learn what we are using. We can't use it just on the face value. We need to know it, knowing its limitation, and utilizing it, understanding the potential risks and limitations that it also carries. So healthcare professionals will require adequate training, understanding to leverage the use of AI-based solution, and we already have courses that are now training doctors how to work with AI and appreciate the limitation of technology. Over-reliance will obviously lead to de-skilling of the profession, and that is something that we should all be careful about. It will help us transition from evidence-based medicine to data-driven, precision medicine, intelligent medicine. That is what we are looking forward to. As clinicians, we must be curious and adaptive to learn about AI. We should not close the doors saying that this is here to kind of compete with me and sort of replace me. Rather, we should be curious, learn it, and then we should use it carefully, knowing its risks and limitations. And most important, we should come out from that wow factor. AI is no longer a wow factor. We should get into that how factor. How is it doing it? We should understand the science behind it, because the science of healthcare can only be understood by healthcare professionals. So are we ready for the AI revolution in healthcare? If you're more interested, we run a fortnight podcast. You can just scan this QR code. Our next podcast is going to be A very interesting topic, we'll be exploring artificial intelligence in manuscript writing in papers. And since I'm also with the JMIR Diabetes Journal, I will be privileged to have Dr. Tiffany Long. She's an internist based out of USA, and she's the scientific editorial director of JMIR publication. And we will be exploring how ethically AI can be used in medical writing and even in medical research. I will end with this one quote, which I keep on advocating wherever I speak of AI, is that artificial intelligence will change healthcare. It will definitely change it. But this change has to be with the doctors and not just to the doctors. Thank you.
Robert Redford once famously said that problems can become opportunities if right people come together. I think we had a technical glitch during the presentation of Dr. Amit Kumar that was a problem for us, one challenge, which he very well overcame by continuing his interaction without the PPT. And we appreciate that effort on your part. And in line with our Honorable President's speech, I would like to ask our second opening batsman, Professor Dr. Rakesh Kumar, who needs no further introduction. He is our Assistant Secretary at Diabetes Awareness and You presently. And in addition to being an academician, he is also an entrepreneur, as he is the director of Dr. Kumar's Diabetes and Lifestyle Clinic, which is running very successfully at Durgapur. And he is the in-charge and consultant of the Diabetes Clinic at the IQCT Medical College and Hospital. He is also the research wing head of Day, and a very new, not so past incidents is that he won the Diabetes India 2021 award for best contribution in diabetes care in challenging situation. I welcome Dr. Rakesh Kumar to continue with.
Thank you, chairpersons, for nice introduction. This is a fantastic talk by Dr. Amit. In fact, I'm also using artificial intelligence power retinal scan in my clinic. And we have also conducted ICMR funded project on that. That report was accepted by ICMR. And now we are in the process of publishing those findings for the general public. So my today's talk is around the early insulination among those who are living in the rural areas and almost are coming only in contact with the primary healthcare center. Basically, diabetes is a lifelong disease which requires 24 hours, 365 days care. And no amount of sophisticated healthcare services can accept or overcome this challenge. We need to be, it needs to empower the patient, it needs to empower the primary healthcare setting so that those patients can manage their diabetes on their own with the help of minimum possible sophisticated intervention. Because poor glycemic control may lead to the chronic complications of diabetes mellitus, we all know. I'm not going into the details of all those things. Now coming to this IDF-10 atlas, globally there are around 537 million diabetes patients, and in Southeast Asia around 80 million diabetes patients. 77 million plus diabetes patients are alone living in India. Just recently ICMR published the data. Prevalence of diabetes varies according to the diagnostic threshold. But here these are the data from the National NCD Monitoring Survey conducted by the Ministry of Health and Family Welfare, executed by the ICMR. Results were published just last year. They divided country in 60 clusters. Multi-state sampling was done, and every cluster has 600 patients, 300 from the rural and 300 from the urban. So the population division into urban and rural was equal. So what they found that out of total eligible population of 9,721, around 904 patients had diabetes mellitus, and only 45% of people knew that they are having diabetes. Out of all those diabetes patients, only around 36% patients were taking treatment. And all those who were taking treatment, only around 16% patients had their glycemic status under control. Now coming to all those who were aware, around 45% of patients were aware about their diabetes status. Out of those 45%, only around 78% were taking treatment. Even among those 22% were not taking any treatment from any allopathic doctor or any doctor. And even those who were taking treatment, only around 43% of them had their glycemic status under control. One important finding was also came out that when they further analyzed data, that what is the rural and urban divide among those who are diagnosed cases, who are undiagnosed cases. So it has been seen that those who already knew about their status, around 3/5 of them were from the urban area and 2/5 were from the rural area. But when it came to the undiagnosed cases, the cycle was reversed. Situation was reversed. 3/5 came from the rural area and 2/5 from the urban area. Data findings are actually mimicking idea of data which says that 2/3 of the undiagnosed cases are living in the rural area. This is a very popular graph. We know that the diabetes is a progressive disease. In due course of time, most of the patients who live longer will eventually require insulin in long run. So I'm not going to the details of UKPDS graph. This is one important graph which shows that the clinical inertia on behalf of the doctor, it's not only with the insulin, even those patients who were on the lifestyle intervention, around 40% patients suffered from the clinical inertia of physicians which failed to add another molecule. Now coming to the insulin, almost 21% of patients suffered because of there was no insulin intensification from the physician part. So it's not only always patients and their illiteracy and unawareness, it's also the doctors. Almost 40% of patients suffer because of our problem, our inertia. Benefits of early insulinization, lots of studies there, EDIC trial is there, DCCT trial is there, which shows that early intensive glycemic control not only sustains the good glycemic control in future life, it also reduces the risk of all types of microvascular as well as macrovascular complication in long run. DCCT trial, EDIC trial, which continuation of UKPDS is still going on, and they're also showing that even after normalization of the blood sugar level, loss of intensification, those who had early intensive control maintain glycemic status in the normal range even in latter stage of their life. So why primary healthcare level? More than 2/3 of the diabetes patient, not only diabetes, Indian population living in the rural area. Most of them are working in the local fields. If they travel to the city, they usually lose their 1 or 2 days of wages. This is a very beautiful qualitative study excerpts which shows that when they asked a rural population why you are not going to the hospital, they said, first day I go to the doctor in the district hospital, they write me some blood investigations, then I go to the nurse takes the blood sample, then they ask me to come again tomorrow, and after coming the blood reports, doctor again write me the prescription. So in this way, I lose 2 days of my wages. This is one of the excerpts from the qualitative data which conducted across India. So it's not only the availability of services, it's also the availability of those people who will utilize those services. So primary healthcare setting needs to get empowered because most of the diabetes patients are living in the rural area. Most of the undiagnosed patients are living in the rural area, and most of these patients will present with advanced state of complications like I find around 17.8% of the diabetic retinopathy prevalence in the community-based study done by the help of artificial intelligence, and around 50% of them were not even aware about the status, and it's not mild. 16% of those had moderate NPDR. 1.2% had at least severe NPDR. So these patients will become burden in future even with the already overstressed healthcare system. So primary care health infrastructure must be strengthened. So what are the barriers of insulin initiation in rural area? These physician-related and patient-related barriers are common for everywhere. Most important barrier from the physician side is either clinical inertia, or hypoglycemia risk. 75 to 85% of doctors reported in a survey that they fear of hypoglycemia, so they do not start hypoglycemia insulin in their setting. Second is the clinical inertia, and it is highest at the primary care level, it's close to 43%. Most of the time, doctors do not have time in the primary healthcare setting, public healthcare system. Doctors are overburdened. They don't have any assistant to assist, or they don't have any educators to take their load, and so that they communicate with the patients. Coming to the patient's part, most important part is the social stigma and barriers with the insulin use. What if I use insulin? It is the end of the life. It is punishment. Give me one more month. What will my community think about me? Patients do not usually, 95% of patients do not usually know that insulin will increase their weight or it will increase their weight. But they do think that it will make their blood sugar fall. So hypoglycemia is also a concern for the patient party. Now coming to few other system-related barrier which is specific to the PHC level. Lack of readiness for patient-centered care for diabetes self-management. We all know that the diabetes is a chronic disease and can be best controlled by a patient-centered care which is advocated by the chronic care model. Most of our primary healthcare center, even district hospitals, are not equipped to give patient-centered care because there is lack of trained manpower who can take care of the patient's understanding and improve their understanding. Lack of diabetes clinical audits and prospective registries. We do not maintain any special file for the diabetes patients at the primary healthcare center, even not at the district hospital center. We do maintain under 5 registers, infant registers, pregnant registers, eligible couple registers, even at sub-center level. But we do not maintain any diabetes patient register at our sub-center level, even at the district hospital level. So if there is no data available at all, how will you strategize the resources required? Third is the lack of trained manpower like diabetes educator and diabetes nurse who can take the burden of doctors, who can be in touch with the patients, who can educate them, because unless and until patients gets knowledge, patients gets empowerment, they are not going to manage their diabetes because it is a 24 hours, 365 days job. Insulin availability, storage and affordability. Right now in public health sector system, insulin is available only up to the community health center and district hospital. It's not available below that. Let us suppose a patient is on insulin, they need to travel for 50 to 60 kilometers to just get 1 month of insulin. My diabetes educator who is type 1 is traveling from Durgapur to Calcutta because she is enrolled at the Nurse Medical College to receive insulin. So she travel monthly to get insulin. Why not transfer out like we do with the TB patients? We register patient at one place and then transfer out that patient to the native place so that the local health volunteer ensures the administration of ATD. Why my educator need to travel from Durgapur to a Nurse Medical College just to 3 vials of insulin? Why? So it's not only the availability of insulin, and many may think that there is a lack of storage facility. No, sir. We are having cold chain system till our sub-center now. We are having freeze even at sub-center. Just a simple protocol making at district hospital level, then transfer out to the patient at the sub-center level. Storage. Storage is also a problem in rural area because lack of electricity is a problem. And accessibility to healthcare delivery. Even if the healthcare is available, patients may not be able to use it because of the poor infrastructure. So strategies to minimize common barriers to insulin initiation. Presumed failure of previous treatment. Clinicians should be more empathetic and must be a good listener and must make sure that patient must not see insulin initiation as a punishment for the poor control. Needle phobia. Doctor must show or the educator must show to the patient that the new insulin pen needles are only 4 millimeter and it's virtually practically painless. A good counseling and demonstration will do the job. Cumbersome procedure and complex regimen. There are many insulins which help physicians to start with the simpler form, basal plus regimen, basal plus oral therapy regimen. Premix, there are lots of insulin which can suit the individual lifestyle. Corporate patients who are not able to come to the house at time, cannot take medicine on time, food on time, They have a special class of insulin which can work for the 36 to 40 or 42 hours. So even the insulin type can be customized. Hypoglycemia, it is totally preventable just with the knowledge of hypoglycemia. And not giving hypoglycemia education, awareness education to the patient is a criminal negligence. Hypoglycemia education is must for every diabetes patient, and it is 100% preventable if used correctly. Weight gain with insulin is natural. However, it can be controlled with adequate lifestyle, diet, physical activity, and combining other medicines which can blunt the effect of insulin weight gain due to the insulin, like metformin, SGLT2 inhibitors. Change in social life, use of latest device like insulin pen, it can be carried. Continuous insulin infusion pumps are there to suit their social life if they can afford it. Physician concern regarding guidelines, because one of the most important reasons for the clinical inertia is their lack of the updated knowledge. They don't get enough time to read, they don't get enough opportunity to attend those conferences. Even they get opportunity, they sleep, they don't attend conferences. So there must be a way to update their knowledge. Overburdened physicians, lack of time, this we can't do in a population of 1.4 billion. Even if we employ 4 consultants, still they will have 200 patients to see in 4-hour OPD. So it's a big challenge, can only be dealt if we make our primary healthcare structure strong, so that less and less patient gets referral at the specialist center. So opportunities to overcome the system-related barriers. National Program for the Prevention and Control of Cancer, Diabetes, Cardiovascular Disease and Stroke, operationalized across districts and across all the districts of country. It has a mandate for the diabetes educate training to the nurses, ASHA. It has package of services, not only for the preventive and curative, also for the rehabilitative for the NCD disease. Under the umbrella of Ayushman Bharat, the government of India has already started upgrading 1.5 lakh sub-center to the health and wellness center with additional staffing, which will give full-fledged services to the NCD like diabetes, hypertension and other NCDs. To promote refill adherence, Jan Aushadhi Kendra are currently operational that promotes ubiquitous availability of high quality generic drugs at significantly lower cost compared to branded medicines to all patients. I am little bit skeptical regarding high quality. I think there is no framework to ensure the quality of generic medicine at this point in India. I don't know how they are maintaining quality. So focus on telemedicine and e-pharmacy, involvement of NGOs and self-help groups. Addressing poor adherence from the patient side, knowledge. Unless and until patient know the importance of good glycemic control and punishment of poor glycemic control in future, that is amputation, lack of vision, heart attack, death, and much dreaded complication than death is suffering because of the complication of diabetes mellitus. Diabetes doesn't kill, it drags you to the death. Cancer is better than diabetes. It either gets cured or it kills you within 6 months to a 2 year span. It doesn't drag you. But diabetes drags you to the death, but it doesn't kill you. So, doctor must be a good listener. Patient must be in the driving seat. There must be a mutual agreement between doctors as well as patient and doctor's team, so that there is no adherence adherence questions from the patient side. And it is always a team care, where patient is the main driver of that team. We usually think doctors are the main driver, no. Unless until your patient follows your advice, his or her blood sugar is not going to get under control. Patient will first ask, ki hoiche, what happened? Sugar, kake dekhacho, Dr. Rakesh Kumar, baje doctor, palte dao. So unless and until you have examined your patient, it belongs to patient 100%. After you made a prescription, 50% pain comes to you. So, unless until your patient follows your advice, your reputation will also not increase. It's a marketing done by patient that doctor controlled my blood sugar, makes you famous. So adherence improves your practice also. So little bit extra spending of time and a little bit education on part of diabetes diagnosis, treatment and complication will make it easier for all of us. And if we are not able to give enough time to our patients, there are some people we call it diabetes educators. We can enable the diabetes self-management education, and studies have revealed that DSME alone can reduce your HbA1c by over 1 to 2%. Randomized control trials are there, which proves it, that diabetes self-management education can reduce your blood sugar HbA1c by 1 to 2%. And it is an ongoing process, it's not a one-time process. So role of public health specialist, capacity building, training the primary care physicians, paramedical staffs, awareness campaign among patients and healthcare personnel, research regarding to empower medical fraternity with latest evidences, advocacy backed with robust research data for team care. And in summary, most of the diabetes patients don't have access to the patient care, specialist care, and they are dependent on the primary care physicians. Apart from patient-related barriers and physician-related barriers, system-related barriers plays an important role in suboptimal glycemic control. Clinical inertia is highest at PCP level. Early and intensive insulin use will have long-term benefits in terms of less complication and consequent decreased economic burden and increased quality of life. Primary care facilities in public sector to millions of diabetes, caters to millions of diabetes patients, but are deficient in characteristics, patient-centered care. Team-based DSME for patients in primary care need high-quality training of nurses, multi-purpose workers, and other paramedical staffs like pharmacists and diabetes educators. Team care coupled with DSME is key to success, and patient as a driving force for this team is the ultimate key to success. With this, I end my presentation. Thank you.
Thank you, Dr. Kumar, for your detailed expertise in delivering the quality care in the rural part. And we all know that around 70% of India's population are staying in rural, and he is the man who is creating impact to serve all those peoples. So kudos to your dedication and guidance to all of us who are, practicing a little bit daily routine. So what I can easily correlate all those things on insulin, phobia and everything. While 2 decades back, I myself was started taking insulin in the remote area of Malda. And all these things which was mentioned as a barrier, how he is overcoming these things is very close to, like me. So that's all. Thank you. Thanks again. And audience, if you have any questions, we will skip those question and answer session at the end of the. So with this beautiful session, I want to introduce Dr. Mary D. Cruz, he is the executive board member of Diabetes Awareness and You, and she is also the pioneer on, educating the diabetic educators and building the awareness in the community level. So with all of these, we just welcome Mary ma'am on the dais and take it over. Thank you.
Thank you so much, chairpersons. And I have less time. I'd just like to thank the audience for being here for the first session. I'm going to speak about diabetes and women and where do we stand in 2023. Excellent talks given by Dr. Day and Dr. Kumar. I am here to root for the women in blue. And while we are all excited about the World Cup, we also know that the Asia Cup was won by the Indian team defeating Sri Lanka. So coming to that, again, women in research are not represented. And I will request Dr. Amit, when he gives a talk next, to also talk about the challenges that women face in technology. It is real and probably age-related. And also insulinization. The fear that women have, I think, is far greater than that of men, from what I have observed. But also, when women are pregnant, they are the best patients to initiate insulin, and they take it so well. So I'm just going to talk about the various stages. Now, when we look at men, there is only one way of diagnosing diabetes. It is a 75-gram glucose load. But when it comes to women, at different stage in their lives, particularly during gestational diabetes, we have a different guideline. So there are differences. As women go through childhood, obesity, polycystic ovarian disease is a very common problem. And then as career women, when they work and go out, they have so many responsibilities. They are caregivers, caretakers, and these are all the drivers for diabetes in women. So why are South Asians more prone to diabetes? We do know evolutionally determined poor beta cell function, low lean muscle mass, and also an impaired insulin secretion. So since we talk so much about diabetes, the diagnosis is by blood tests, we know. A fasting more than 126, this hasn't changed, and a 2-hour post-glucose load of 75 gram, more than 200 milligram percent is diabetes. You can also diagnose diabetes on a random test of more than 200 milligram percent on 2 occasions with an HbA1c of more than 6.5%. So why is this happening? Our environment has shifted to promote an obesogenic behavior. You see the increasing sizes of food items in the malls that you go to, the food courts are there. There are buildings that are having multiple restaurants inside. So added sugars, easy food access, the food apps that you can order from, great taste, and ads also make it easy for you to order food. On the contrary, we also have reducing sedentary workplace, desk jobs, sedentary school lives, automobiles, and drive-through conveniences now even here in Calcutta, remote controls which make us, even that little exercise from getting up from your chair and going out is also stopped. So all this leads to a proportion of disease prevalence which is attributable to obesity. And of that, type 2 diabetes attribution is about 57%, followed by gallbladder disease, hypertension, cardiovascular disease, and we all know that these are all linked directly to obesity. So prevalence of obesity in Indian women, you see how much it has risen from 2015 at 20% to now in 2021 to almost a quarter of the population. In India, more than 135 million are actually affected with obesity, and the presence is, of course, expected to triple by 2040. Could this be the space where we can help to prevent diabetes? So we know obesity is a complex chronic disease with abnormal and excessive fat, which impairs health and increases the risk of long-term medical complications and also reducing lifespan. We know new definitions of obesity are coming in with better nomenclature. So ABCD is adiposity-based chronic disease, rather than calling people obese, because people are sensitive to the term obesity. We have a 4M assessment of obesity, and if you look at women particularly, see the mental cognition, the depression, attention deficit, the addiction, psychosis, eating disorders and traumas, particularly related to women. So you will hear of bulimia in women, in college students who are constantly eating as much as they want, and then they are vomiting out to remain thin and maintain their weight. So also mechanical, we see a lot of women with sleep apnea, osteoarthritis, chronic pain, reflux disease, incontinence, intertrigo, and then the metabolic disorder of type 2 diabetes, dyslipidemia, hypertension, gout, fatty liver, PCOD, and malignancy. And then the monetary problems. Many women in India do not work. They are dependent on the families for their financial, not only buying the medicines, and they always request, please could you write me a lower costing medicine? I cannot get so much money to purchase my own medicines. They usually don't like to take any supplements because they want you to give you something that is available in the house. So obesity, of course, I've just touched on this, and the factors that lead to gender disparity in obesity, what I was saying, is because of the disparate socioeconomic status, mismatched sociocultural factors, feeding practices in the postpartum period, and a lot of influence of not only the female relatives in the house, they monitor what you eat, and it usually tends to be high-calorie foods, non-identical threshold of metabolic complications, contrasting biological craving food, distinct hormone-related morbidities, and in India, divergent customs for women who are homebound in some cultures. Across India, you will see different cultures prevailing during marriage ceremonies, during pregnancy, during postpartum period. So the transmission of obesity and adiposity-related disorders from the mother, work done by Dr. Yagnik, lets us know that a pregnant mother particularly one who has obesity and rising sugars during gestational diabetes, could affect the fetus, and the fetus in turns, because of the inflow of the higher levels of glucose during pregnancy through the placenta, tends to increase its insulin, and then there is macrosomia with also hypoglycemia and obesity in the child, later on leading to diabetes even in the offspring. Not only that, the mother who has a GDM also progresses later on in a period of 3 to 5 years to become a type 2 diabetic, because they do not return for their checkups. Gestational diabetes manifests in all trimesters of pregnancy. All women should be screened for gestational diabetes, even if they have no symptoms. Hyperglycemia in pregnancy can be classified in two ways: as diabetes in pregnancy, which could be type 1 or type 2 diabetes detected prior to pregnancy, or it could be type 1 and type 2 detected for the first time in pregnancy. Whereas gestational diabetes is the first time detection of diabetes in a pregnant lady. It is transient usually and disappears after birth, but again, things are changing now. Whom do we screen? In the Indian scenario, we are using the DIPSI screening guidelines, so all pregnant women need to be screened at the first visit with a 75-gram glucose load and a single postprandial glucose at 2 hours. If it is more than 140, it is gestational diabetes and treated as such. If it is more than 120, it is gestational glucose intolerance. If it is detected for the first time at 24 to 28 weeks, if negative, then you repeat it at 32 to 34 weeks. It's a single-step procedure and convenient for Indian patients who come from rural areas. So follow-up of, and we particularly pay attention to the post-delivery care of women. So the government of India has made it mandatory that maternal blood glucose levels return to normal after delivery, and nevertheless, a fasting and PP is done on the 3rd day, and only then is the patient discharged, unlike those who are discharged, normal people, after 48 hours. So follow-up of GDM is very important, and OGTT of 75-gram glucose should be performed either at 6 to 8 weeks, and if found normal, we repeat after 6 months and every year, and this is where we can make a difference in the lives of our patients so that they can prevent diabetes. We have a new term now, that is early GDM, which is earlier diagnosis of gestational diabetes diagnosed before 20 weeks, and that is called eGDM. eGDM, as averse to a conventional GDM, which is detected at 24 to 28 weeks, eGDM is detected in early pregnancy, that is before 20 weeks. The importance of identifying is showing that they have a different clinical and adverse outcomes, more insulin resistant, and they have higher blood pressures, triglycerides, and even neonatal mortality and hypoglycemia. So this was the treatment of booking gestational diabetes mellitus study by Dr. Mohan, multi-center RCT for study of diagnosis and treatment of pregnant women before 20 weeks. Benefits for early diagnosis were even seen as early as 14 weeks and earlier, and it was observed the benefits were greater in those who had higher levels of glycemia. So while we were looking at the prevention of diabetes, the numbers of people aged over 5 years and the percentage of population, as you can see globally, the number of people with overweight by 2030 is going to increase to 3,507 million. By 2030, the numbers with obesity, that is more than 30. In India, in fact, obesity levels are at a lower BMI. That's 1,556 million, and proportion of the population with obesity at more than 30 would be somewhere around 20%, which is what it is currently. So this was some of the feasibility studies and what could be the interventions that we make in people, in women before they become pregnant or during pregnancy. So lifestyle intervention programs for prevention of diabetes among women with poor prior gestational diabetes in South Asia was a formative research study, and it looked at the domains of knowledge and of looking at current practices and interventions for treatment. We also looked at the opportunity for introducing social control and physical environment to be improved in terms of their activity levels. The hierarchy of exercise for women, again, mostly sedentary. They need to be introduced as flexibility enhancement initially, with balance training going on to aerobics, and finally resistance exercises. So prevention of weight gain is an important issue in women. Particularly we see young girls with PCOD or overweight, hypothyroid. So how does prevention of weight gain differ from weight loss? So reversal of weight gain is what we are almost always doing. Finite period of time, we try to lose weight within 4 to 6 months, negative energy balance, eating less, exercising more, fat burning is needed, and usually a reduction in calories. But when we look at prevention of weight gain or regain, it's over a longer period of time, and it could be forever. Energy balance needs to be matched to the expenditure, and bigger changes are needed for prevention of weight regain than prevention of weight gain. So weight gain we can prevent easily, but preventing regain is really difficult. The consensus on medical nutrition therapy for diabetes, a South Asian perspective, says eat by the clock, no skipping of meals, ensure recommended protein intake. Indians are generally deficient in protein intake. Have small frequent meals, oil intake per month for the house to be calculated as 500 ml per person per month, and accordingly buy that much oil for the entire family. And one must have a knowledge of calorie intake, and apps and artificial intelligence could be very well used for this. These are the recommendations for Asians. We know overweight for Asian criteria is 23 to 24.9, pre-obesity is 25, or obesity is 25. So what are the determinants of body weight? It's genes, the environment I spoke about, the biological factors, in utero environment, birth weight, gender, age, and concurrent disease. This is where there is a difference in diabetes in men and women. Again, behavior patterns, dietary preferences, physical inactivity, psychological, cultural, and other diurnal factors that are present. The root cause of obesity we've seen, and again, obesogenic environment. Input and output is not as simple for losing weight. We know that whatever we do, we are unable to lose, or if we lose, we are able to maintain. So we have to give a diet that is possible to sustain for a longer period and maintain it. So over the internet and magazines and physically, you see all kinds of easy ways to burn fat. You have a Barbie, Indian Barbie, that has a 36 figure. And in spite of all digitization, robotics, connected health, artificial intelligence, we are just unable to lose weight. 8 risks and behaviors of poor diet, physical inactivity, smoking, lack of health screening, stress, a poor standard of care and insufficient sleep, very important, and excessive alcohol. Now women are consuming more alcohol, and these are the drivers for 15 chronic conditions, 80% of total cost for all chronic illness across the world. And among them, diabetes, coronary artery disease, CCF, hypertension, back pain, obesity, and cancer head list. So preventing obesity would be a way to start with women, and we can reduce not only their tendency to turn into gestational diabetics, because pre-gestational care is very important, a very good medical history, circadian rhythms, behavioral therapy, food options, and physical activity is the way to go forward. I stressed on this one earlier that type 2 diabetes is a result of putting on the weight. Lifestyle management, of course, is a structured, action-oriented health promotion to reduce health risks and promote healthy behaviors. Particularly in women, these are some of the medical history risk factors that we need to assess. Their obesity, when did it start, how did they address it, what are their mental makeup when they know about obesity, do they like to be called obese, or would they rather prefer an ABCD definition? We look at their diet history, eating patterns. Women tend to eat more when they are depressed, more sweet items when they are depressed rather than when they are happy. When they are happier, they go in for more of nuts and healthy foods. A regular exercise pattern, drug history, very important in women. Are they taking some antipsychotics, antidepressants, steroids, anticonvulsants? And the reproductive history, of course, is extremely important. Circadian rhythms is what we are looking at playing with now in terms of looking at their sleep-wake cycle, that they get adequate sleep of at least 7 to 8 hours. We know that this can reduce their pattern of food intake, because intake is related to your waking hours. The more you stay awake, the more you eat. So remarkable effects of time-restricted eating is present and can be fine-tuned in the circadian clocks. Breakfast is usually the most effective meal to determine the phase of the liver clock in statistics were seen with mice. But late diners or midnight snacks after the starvation period and remarkably after the phase of peripheral clocks. So the first bite of the day is an indicator of your circadian rhythm you start, and light again is the first indicator of your wake up and waking up your circadian rhythms during the day. Women who tend to sleep later at night also tend to eat more at night because there is less secretion of insulin during the evening hours. And the same goes with melatonin, which starts reducing and adversely affects the secretion of insulin. So we're looking at different intermittent fastings, but one of the best ones were the 16-8 fast each day, which is most popular. You have others, warrior diet, alternate day fasting, eat, stop, eat, or 5 days and 2 days you fast for 2 days, eat normally for 5 days. The meta-analysis showed that the largest weight loss was associated with low carb and low fat, and at the end of 6 months and 12 months, at 6 months the greater loss was seen with low fat, but at 12 months, the weight loss was almost equal. So recommend a patient a diet that he'll adhere to in order to lose weight. This I've already said, that melatonin at night also reduces insulin release. Therefore, eating larger meals earlier in the day and avoiding food for a few hours prior to bedtime may have health benefits. These are the nice guidelines for nutrition recommendation in women. And you have pre-gestational BMI if they have 18 to 24. Then you don't need to institute changes, but intrapartum BMI of 18 to 24.9, medical nutrition therapy is the answer, and we do not recommend weight loss during pregnancy. And even if the BMI is more than 25, no weight loss, just adhere to a diet which provides nutrition for both mother and child. I think I should end here because there are other speakers and I won't like to take their time.
So, thank you, ma'am. Thank you for your captivating speech on women and diabetes. And I think we are running a little short on time, but we can take up a few questions with sir's permission over the last 3 presentations that we have had. If anyone from the audience can have any question, keep it very short.
I have a question from Dr. Day. Sir, we all know that everything has a brighter side and a darker side. So having said that, I have 2 questions. First is, what is the legal validation of this intelligence-based medicine at present time? And second thing, what are the threats of using AI when we are talking about using AI in insulin pumps and therapeutic modalities? Because if it malfunctions, it can kill patient instantly. It will not delay the killing of patient if we are using it in insulin pump. Like we have seen a malfunctioning of defibrillator, it can kill patient instantly. So what is your take on this?
I think 2 very valid points. I'll take up the first question to start with. We are talking about the regulations and the ethical guidelines of AI. And this is still, till date, even today, 4th November 2023, till date, this is very much in a gray zone. Now, if you've seen the developments happening around the world, recently Joe Biden had kind of created they have released in the USA, they have released an AI guideline for the various industries, and the HIPAA Act and the GDPR Act is also incorporating AI guidelines to come in. In our country, we are still naive with this, but if you look, the Ministry of Health and Family Welfare have released a booklet of how to use artificial intelligence ethically in healthcare, and I'm pretty certain that with our counterpart of the GDPR or the HIPAA, the AI ethics and the guidelines will be incorporated. What is very important for us to understand here is this particular rules and the ethics of AI will be very, very regional. The rule that will be prevalent in the USA will not be prevalent for India, or it won't be the same in UK, and probably it's different in the other Southeast Asian countries. So regional rules will have to be made, and it has to be defined as per the need gaps of that particular country. The second important thing is I've already said this, and I keep on advocating this, that artificial intelligence is a tool that we should use it as an assistance to augment our output. So over-relying it will always end up in descaling our own cognitive approach to any disease, or especially in the healthcare sector. So we have to use it very, very carefully. The second thing that I want to tell you is these artificial intelligence algorithms, once they're employed, they usually run over a multiple pre-trained and a foundation model. So the error will happen or malfunction will happen only if the input is wrong. So the input is very important. For example, in a case of a insulin pump, if you're entering the wrong carb ratio or entering the wrong carb factor, then the calculation will be wrong and the output will be wrong. If some way the Bluetooth connectivity between the sensor and the pump gets disconnected and the data is not transmitted, which is quite, there's a lot of publications on that as well, then again there's going to be a lag happening, and the output that the machine algorithm will give will be based on a previous CGM data, and that's why the malfunctions will happen. So that's where, even when you're using technology, we have to verify and cross-verify, and we have to be very careful in the inputs that we are giving. But that's very important, that we have to learn and understand the technology. Only then we can do those firefighting operation of taking care of the troubleshoot. You know, we all know how to use technology, but how many of us can say that we can take care of the troubleshoot? If your phone hangs, how many of us can do a troubleshoot? So as doctors, we have to learn how to do the troubleshoot before we start using it in our practice.
Yeah. So thank you, Dr. Dey. I just want to add one thing, like when the internet comes, after a decade of using internet, then in 1992, first guideline came. So here, I mean, ChatGPT and all those AI tools, they are coming just in this year. So I think more we will be using, more problem will be coming, and then it will be easier for us locally or nationally to, publish the guideline for using the AI in the clinical practice. So I think after US today, I think Rishi Sunak, they have already, guideline meeting, they have, today it will be there in the London. So hopefully multiple country, and in next couple of years, hopefully in India also we have some this guideline, but definitely we have to give our input to build those guidelines. Thank you, and yeah.
How obesity is related with sinusitis. In one of your slides, you have mentioned it. That's why I'm asking it.
You know, tendency for respiratory disorders more common, particularly because of snoring. And it is common. When you ask the spouse, they will tell you. You ask the person themselves, they'll always deny that I don't smoke. And that airway obstruction does lead to increased, because the cilia are not moving as efficiently. When you stop, snore, there are periods of stopping. And those cilia are not moving at that time. So there is a greater tendency, yes.
Yeah. So any more query? Because our panelists will be on the floor, so anytime any question rise up, we can take the questions to our panelists. And with this, we are concluding our session here, and definitely three important segments. One is AI in healthcare, one rural health, which denotes like 70% of the population, another one for the 50% like women health. So these three we have completed, and we are concluding this session was power play session, right? So I'm just handing over the session to the organizer. Thank you. Thanks a lot for all the...
May I please request the chairpersons to be on the dais? Sir, request you to please be on the dais. After this excellent interaction session, may I request our respected speakers of the first power play round, Dr. Amit Kumar De, Dr. Rakesh Kumar, and Dr. Mary D. Cruz, to be on the dais and to receive a small token of love and appreciation from Day. And to honor the guests with a small token of love, may I please call upon Ms. Madhumati Madam to be on the dais, please. Ms. Madhumati Madam is going to honor Dr. Amit Kumar De. Can I please have a huge round of applause? Dr. Rakesh Kumar. Dr. Mary D. Cruz, ma'am. Respected chairpersons, Dr. Bhiman Mondal. Respected chairperson, Dr. Tahir Hussain. Thank you so much, respected guests, to be here today. I may now hand over to
So now let's talk about the Yorker, that fast and unexpected delivery that can disrupt a batsman's plans. In healthcare, life can throw us Yorkers too. Unexpected health issues, just as a batsman needs to be prepared, we must be prepared and understand our health, so we can tackle life's Yorkers with resilience. Keeping that in mind, let's welcome on stage our eminent super performers as batsmen come chairpersons, Dr. Moushumi Basu Madam and Dr. Kaushik Mitro Sir on stage. But before they are coming, let me take the honor of introducing them to the audience. Dr. Moushumi Basu is credited with 105 national and international publications with 1054 citations. She has contributed to Indian Association of Preventive and Social Medicine textbook of community medicine. She has been the reviewer, the editorial board member, associate editor, editor-in-chief of 30 peer-reviewed journals. She is also associated with many professional bodies as life member, executive committee member, joint secretary, secretary, treasurer, vice president, convener of high power committee of COVID-19 vaccination, medical education unit, curriculum committee of IPG-MER. She is also the fellow of Foundation for Advancement of International Medical Education and Research, nominated for BMG Award India 2014, BMG Award South Asia 2016, completed MECOR India Level 1 and 2 from American Thoracic Society. She is also selected for Indira Gandhi Gold Medal Award by Global Economic Progress and Research Association and has bagged the prestigious Innovative Education and Scientific Research Foundation Award. So we welcome you, ma'am, on stage. Next, we have Dr. Kaushik Mitro on stage. Firstly, let me discuss about his organizational experiences. He is a Secretary, General Secretary, Indian Public Health Association, Treasurer, IPACON 2023, Member of Editorial Board, IJPH, JCH, National Coordinator, and Lead Quiz Master of Dr. Deoki Nandan Memorial National Public Health Quiz for PG students since 2020. And his works and publication includes, he has 35 publications in national and international index journals. He is also the contributor of chapters in 3 books, including Indian Association of Preventive and Social Medicine textbook of community medicine. He is having a huge experience as paper presenter, conference mentors, chairpersons, and panelists in many prestigious national and international conferences. His other experiences include, he is the vice chairman of State Task Force of NTEP West Bengal, State Trainer of Disaster Management in West Bengal, State Trainer in HIV, Sentinel Surveillance Plus Program, Principal Investigator, Minerva, a project of AIMS, New Delhi. He has been the examiner of MBBS in universities within and outside West Bengal. So let's welcome these 2 chairpersons with a huge round of applause.
Good morning, everybody. thank you, Dave, for inviting me to be the chairperson in this August gathering. So we are starting the session of Yorker. So the first speaker for this session is Dr. Ridish Narayan Chakraborty. Where is he? He is a consultant endocrinologist of Narayana Super Specialty and Multi-Specialty Hospitals, Howrah, R.N. Tagore Institute of Cardiac Sciences, AMRI, Medica, and he has lots of experience in the field of endocrinology. So I welcome Ridish. He is a good friend of mine from my college days, actually. I am honored to have speaker like Ridish where I am chairing. Thank you, Ridish. Please continue your deliberation.
So thank you, everybody, and thank you, Kaushik, for those kind words of introduction. You are just making me reminiscent and nostalgic of 25 years back, what we did at medical college. So my topic would be management of diabetes in elderly. And at the very outset, there is no conflict of interest regarding this topic. And so nothing to declare before your customs. And I always carry some disclaimers with me. The first one will obviously be that medical science is an ever-changing field, and whatever I am saying today is valid for today's date only, क्योंकि कल किसने देखा है. So there is another disclaimer that management of diabetes in elderly will not include individual comorbidities like hypertension, dyslipidemia, where ecosprin has to be used, etc. Only I will fix to management of diabetes in the elderly population. I always carry two thank you slides with me. The first one obviously goes out to the organizers who deemed me fit to talk on this topic, because I am appearing on this podium, on this dais, under this umbrella day for the first time. Now, I will just present two photographs before you and say what is the similarity between these two photographs. So now don't tell me they have very less hairs on their head and they are both edentulous. So that's known to everybody. The most striking feature is obviously the smile. So obviously what we need to understand that the only worthwhile pursuit in life should be happiness. So whatever name, fame, money you run after, the only thing matters at the end of the day is the happiness. And that is obviously for both extremes of age, be it a child or be it an elderly. Now, before we talk on this elderly concept, so we need to define what is elderly. So there are various definitions across the world. So some say it is more than 65, some say it's more than 60, some WHO study in Africa mentioned more than 50 years. So I have to work with a working definition for today. So obviously it will be whoever in this podium is 10 years older than the eldest. So whoever qualifies for it, please don't get angry with me. This is just for context setting. Now, why elderly care is important? So obviously, this is a huge burden that is going to affect us in the coming times as well. Now, age predisposes to diabetes. Just as with senility, every organ tends to fail or tends to malfunction. Similarly, pancreas is no exception. So be it your heart, be it your brain, be it your kidney, be it your nerves. So pancreas also, be it due to amyloid deposition, reactive oxygen metabolites, whatever mechanism you mention, ultimately the organ is susceptible to failure. Now, specific issues with elderly new type 2 diabetes patient, what happens? That if you talk of lean patients, lean elderly, which are more common in our setup rather than the Western where they are more obese. So here they secrete markedly less insulin in response to a glucose load, but have relatively less insulin resistance. That obviously means that the fasting maybe will remain a little bit high or normal, but the PP spike or the surge may be much more. So this is specifically for a lean elderly population. Now if I take you back to the physiology classes that we learned, that there are two phases of insulin response. One is the immediate response when we start eating, that is the first phase insulin response, and second is the delayed one. The problem which happens in elderly is that there is nosediving of the initial response. So the first spike doesn't happen. In addition to that, there are some other changes, that there is loss of pulsatility of insulin secretion and decreased response to the incretin hormones that we have from the gut. So this actually brings a potential role of DPP4 inhibitors and GLP-1 receptor agonists as well, which we'll be subsequently discussing. So summarily what happens in elderly population, the fasting may remain almost in the normal range, but the PP swing will be very much. So the gap between the fasting and PP very much more. You can draw an analogy with isolated systolic hypertension that happens in old age. What happens due to loss of the aorta's Winkesel effect or the elastic recoil? The systolic BP goes up, but the diastolic may remain normal or dips down. So the pulse pressure widens. Similar thing happens with sugar as well. So the gap between the fasting and PP may be very much wide. So many patients actually come only with a fasting sugar and an HbA1c. We ask, okay, PP kora dorkar nahi, or the lab people has said ki kora dorkar nahi. So the patient does not bring a PP report. So some patients may be missed. That is the take-home message from this slide. Now, how accurate is HbA1c? It is an important pillar for diagnosis and monitoring, no doubt, but there are some caveats. So let me trigger a debate at today's forum that should we have a separate HbA1c cutoff for elderly? Maybe. There is some logic behind it. Like we know what is HbA1c? That it is dependent on the amount of ambient plasma glucose. That's okay. If the sugars are high, then the HbA1c will be high. But there's some other factors as well. Like what is the lifespan of the RBC? We actually take it for granted by default that RBC span is 120 days. But it may not be so. In elderly population, this dynamics changes. So RBC lifespan also appears to be reduced by hyperglycemia because RBC is a biconcave structure. If the ambient sugar is very high, it actually imbibes water and the sugar, and ultimately there is early lysis of the RBC. So that can actually create a problem in the HbA1c. And the other side, let me talk about, because there are three mechanisms of removal of RBC from the circulation. One is the kapha cells of the liver, one is the macrophage in the circulation, and one is in the splenic sinusoids. All these three functions actually get derailed with old age. So the RBC lifespan may actually be increased. So this again can bring a confounding factor in the HbA1c. So I have told you both the extremes, that in hyperglycemia there may be early lysis, and when the patient is old due to aged RBCs being more in the circulation, there may be a little bit higher HbA1c value coming up in the report. Actually, the sugars are not so high. So why I initiated this debate? Because it has to be remembered in this context that reference value for HbA1c were established way back in 1986 based on a small population of only 124 non-diabetic individuals with a limited age range of 13 to 39 years. So it did not include aged people at all. These reference values have not been subject to change since then. And although age-dependent differences in HbA1c were reported before, clinical guidelines till date have not incorporated these changes. So maybe it is time to relook at the HbA1c in elderly. Coming to the burden of diabetes, no mention required anymore that we are having the largest number of patients in the world, and maybe we are having a more aged population in the coming decades. So with that, the burden of elderly will also be increasing. So over 1/4 of people over the age of 65 years have diabetes, and 1/2 of older adults have pre-diabetes. That means they don't even know that they're having diabetes. So they will be brought to the fore when some other related problems have the doctor has asked for undergoing sugar tests. So screening has to be done, that is very important. The diagnostic criteria are the same as in younger population, so nothing needs to be mentioned about that. The problem in management is whether you go too tight or too loose. So it is walking a tightrope. The benefits of tight glycemic control should be weighed against the risks and the realities of an individual situation. We should only focus at giving the best quality of life to the patient. Now, why is it so? I got this interesting thing from California Healthcare Foundation. What they said, there were two groups of people, experts. One said that it is better to target the CV risk factors in older people rather than targeting the sugar values. And why they said so? They said because of the reason that one rationale for this is that it takes 8 years for glycemic control to reduce the risk of diabetic retinopathy or renal disease, but only 2 years of treating hypertension and dyslipidemia to reduce the risk of cardiovascular disease. So you have two mutual funds. In one you invest, you are getting 15% return after 2 years, and one mutual fund you are getting about only 7% at 7 years. So which one will you invest in? Obviously you would look at CV risk factors, which will give you more benefit rather than investing in the sugar management in the elderly. So this part has to be remembered. Now a very important part which we usually miss in our clinical scenario because we do not give so much time in assessment is the functional categories of older people with diabetes. So one category is functionally independent, very fine. They are up and about, they can take care of themselves, it's well with them. Second category is functionally dependent. Now this has two subclassifications. One is frail. Shorir খারাপ কিন্তু ব্রেন ঠিক আছে। The other category is opposite. শরীর মোটামুটি চলছে, but there is dementia. So these are two different subcategories of category 2. And category 3 is end of life care. Suppose terminally ill, has cancer, will not have life expectancy more than 6 months. So that's a separate category. So obviously this is a heterogeneous category. And we cannot extrapolate all the data of young population to all these 3 categories. And that is why it is important. Now question is the presentation. How do elderly people present? Obviously they are different. One is they may be asymptomatic in nearly 50% of cases. Second, the osmotic symptoms, the dramatic osmotic symptoms of polyuria, polyphagia may not be seen in these patients. So this has to be remembered. Third is non-specific symptoms such as fatigue and lethargy can be mistakenly attributed to aging. Even family members say, oh, boyosh hoyeche tai eto সমস্যা হচ্ছে. So it may not be so. We may be missing something. And fourthly, neuropathy, visual loss, fall, fractures commonly may be the first presentation. So they may come to the medical people with these presentations initially. Coming to the issues of drug-drug interaction, what causes changes in the human system with age? Now, regarding the drug absorption, there may be some age-related changes. There may be reduced small intestinal motility, especially seen in elderly. The colonic motility may be hampered, and the pharmacodynamics not only affects the therapeutic effects, but also toxic and the adverse effects. So the pharmacodynamics depends on the concentration of the drug at the receptor, the response at the receptor, the post-receptor events. So enhanced sensitivity of drugs may also be there. So all these things have to be kept in mind. And why does this happen? Because of these problems. The uppermost right corner is the most important, that is polypharmacy. A patient comes to me as an endocrinologist, I give him 4 drugs. He goes to my friend cardiologist, 3 drugs are added. He goes to the neurologist for a diabetic neuropathy, 2 drugs are added. So long list of 13 drugs are added. Patient often asks je bhat khabo kokhon, shudhu to oshud khete hocche sara din dhore. So this is a real problem. So polypharmacy is one of the reasons that actually cause a lot of problems in the elderly. Apart from that, there is obviously hepatic renal impairment, increased risk of hypos, concomitant diseases, dependency on others, family members, caregivers, ayah, and etc. So these things also have to be kept in mind. And because of all these reasons, the HbA1c is not a fixed value for the elderly population. If you look at the various guidelines, be it our own RSSDI guidelines, which I have mentioned, or the ADA guidelines recently 2023, you can see so-called healthy subjects can maintain an HbA1c of 7 to 7.5. But if there are complex situations in the patient, maybe HbA1c less than 8 is acceptable. And if the patient is terminally ill, having some problems where you know that the patient will not live for long, maybe HbA1c at all should not be in your mind. Here only good quality of life should be provided. That is to be remembered. Now, screening for complications in older people with diabetes, obviously routine checks with HbA1c, BP, lipids, albumin excretion have to be seen, and also food care that is often missed. And screening for physical and neuropathic complications. I will just mention 2 scores which are important, the Frail and the SARC-F score, because earlier we used to do mini-mental score, which was a little bit complex and is not very possible or prudent or plausible to do it in a busy OPD. So maybe we can do these things. These are easy things, like Frail scale. It is actually an acronym. F stands for fatigued, self-reported. R stands for resistance. A for ambulation, whether unable to walk a block. I stands for illness, whether more than 5 comorbidities and lost weight or not recently, like a standardized value of more than 5 kg in the previous 6 months. And then comes the SARC-F score. This is very important because as we grow old, our lean mass is lost, that means protein part is lost and the fat part is gained. So maybe the total body weight may remain same, but actually we are losing lean mass. So for those, there are 4 questions like strength, whether they can elevate a 5 kg weight, assistance in walking, rising from a chair and going to the bed possible or not, climbing a block of stairs is possible or not, and whether there is history of falls. So this can be a very short assessment you can do in the OPD, which will go a long way in the management of the patient. There are also some mental health assessment scores like mini-Cox scores, etc. I'm not going through the details, but maybe you just can ask the patient to draw in analog clock, what is the time now? 3:10. So how will you draw it on the board? So these small things can go a long way in assessing the mental status. Lastly, coming to the lifestyle modification for optimizing glycemic control, there are various points like physical activity recommendation. The most important thing here, you obviously will not ask the patient to go for some huge aerobic exercises, but maybe simple walking if possible, that osteoarthritis is not binding the patient. Maybe little bit of assisted walking or walking on his own may go a long way. Secondly, weight management strategies. It is often difficult to change the diet in an elderly population. I'll just show some changes, like diet plan change can be tough. So forget the angry young man. If you tell an old person to change the diet, he can really become sometimes very fidgety. So what is the reason for all these things? It is because he has lived with a diet habit for so long. Now suddenly you bring in some change. It is very difficult to change those circumstances. Secondly, difficulty changing the basic diet pattern, that he eats 3 times a day. Now you ask him to eat 5 times a day, 3 major meals, 2 minor meals. This is often not possible. Second, dependence on others for shopping and preparing the food. বাড়ি তিনজনের জন্য একরকম বাজার হবে, ওনার জন্য আলাদা বাজার হবে. Difficult. And fourth is inconsistent appetite. রাত্রিবেলা আজ খেতে ইচ্ছা করলো না, but I have given one medication at night. What to do then? The patient may land up in hypoglycemia. And fifth, financial concerns. Usually in old age, in our place, many people are dependent on their sons, daughters, son-in-laws. So it is very difficult to impose ki amar jonno alada sob byabostha korte hobe. Then coming to issue of hypoglycemia. So hypoglycemia is definitely one dreaded thing which we should all avoid. That it should be our target. Rather than targeting the hyperglycemia, the more important thing should be to avoid the hypoglycemia. There are various reasons like hepatic dysfunction, renal dysfunction, often dementia. Patient is taking the same drug twice, bhule geche, has taken the same drug twice. That can also lead to that problem. Coming to oral anti-diabetics, so there are a lot of drugs. What we need to remember, metformin obviously can be used provided the EGFR criteria allows you. Sulfonylureas, newer generation can be used, but with caution because they can lead to hypoglycemias. Meglitinides still we use in certain population, but I personally tend to not use it. Maybe it can cause post-meal hypoglycemia. Alpha glucosidase inhibitors can be used provided the creatinine has not crossed 1.8 or 2. Pioglitazone is a favorite molecule for me, but many cardiologists, many geriatric specialists do not want because of risk of fractures, etc., weight gain, etc., and cardiac issues, etc. DPP-4 inhibitors is obviously a doctor's darling for elderly patients because not much need to be done. It's weight neutral, renal and cardiac safe. Oral GLP-1 can also be used, but again we have to remember already who is lean, who has lost weight, that may be a problem. SGLT2 inhibitors again can be used because they give so much fringe or collateral benefits, but obviously again the weight loss issues, you have to monitor the EGFR, we have to monitor the genital mycotic infections, etc. Coming to the injectables, very short note because I am short of time. So GLP-1 receptor I have already talked about. Injectables, about insulin, I would say that now we have a spectrum of insulins, right from short acting to fast acting to very long acting. So on one hand we have fast acting aspart from Novo Nordisk, on the other hand we have degludec from the same company. So it's a wide range. Maybe in the next 1 year we will see once weekly insulin from them as well. So premix insulins can be used, but it's a fixed regimen. There is a problem that there can be hypoglycemias. So when you are initiating insulin, 2 things I will want to harp upon. One is when you are using premix insulin, it's a rigid regimen, can cause hypoglycemia. It is like going to a tea vendor and asking for the tea. So whatever liquor, sugar, milk, everything is fixed. But if you stay at a 5-star hotel, you make your own tea. So you can make choices and can make a flexible regimen. Lastly, when you are giving a short-acting insulin, the good thing is that you can give the insulin even after the food is taken. That is one of the advantages. Now, question is, before I close the insulin issue, some very small comments I would want to make, that there are various caregivers in the society who do not actually know the difference between U40, U100. They often jumble up them. And needle reusage is a very big problem. This is taken from 2 of my patients last week. One had insulin allergy on the left side, and the other one, because I was in a busy OPD, I didn't show him. He went on giving in the same place, and this resulted. So obviously these things need to be mentioned, that you have to pinch up how to do it. You have to rotate the injection sites. You can use rotation grids. And if you have any such things like lipoatrophy or lipohypertrophy, I'll just take 1 more minute and close it. Okay, so in those patients, maybe you need to explain to them once more, and the caregiver should also be brought in the loop. And lastly, ডাক্তারের কাছে গেলেই ওষুধ বাড়িয়ে দেওয়া হয়. Something is in the society like this. So sometimes maybe we need to de-escalate, especially in elderly population. You need to make regimens simple. Maybe polypharmacy can be brought down into viable combinations of drugs so that less pill burden can be ensured to the patient. And lastly, I would end by saying that as we conclude, we realized that when you are treating an elderly patient, the patient's perspective will be, young patient will say, I want to hop, jump and run. But an elderly patient wants to just live a decent life with head held high. without being dependent on others. That should be our target. And from a doctor's perspective, when you are treating a young patient, you can change the track, like running in a marathon. Nobody is going to penalize you. But it's a trail for elderly. If you jump too much to the right or left, you can land up in a problem. So walk cautiously. So evolution of expectation will be there. We need to remember the 6 E rubrics: efficacy, ease of use, error-free, extra-glycemic effects, elementary investigations, and elasticity. So take-home message will be: elderly patient is a special population, hypoglycemia is a major concern, altered pharmacokinetics and dynamics have to be kept in mind, and there is no best treatment. You have to individualize. So growing old is inevitable for all of us, but growing up is optional. As Marcus Tullius Cicero had said, that what is old age? He defined it as, it is the crown of our life and our play's last act. আমাদের জীবনের নাটকের শেষ পরিচ্ছেদ. So to care for those who once cared for us is one of the highest honors, and I always present a social message to you whenever I give a PPT presentation. World Diabetes Day is there, so we are going to do a lot of walkathons, TV shows, radio bites, writing in newspapers, Facebook lives, but please treat elderly patients with care and compassion. Thank you.
Thank you, Dr. Ridis, for your timely, specific and to the point presentation. For question answer, after all the speakers will tell, then there is 10 minutes time for question answer session. So, acha. And our next speaker is Dr. Amitabh Sur. ওখানে তো স্যারের নাম দেওয়া আছে, ওখানে স্যারের নাম দেওয়া আছে।
Oh, our next speaker is the moment we are waiting for, is Professor Apurva Mukherjee sir. Actually, we are waiting for this moment to hear from sir. He needs no introduction from all of you. And I know him when I was 10 years old. I know sir. So sir.
Good morning, everybody. Good morning, my beloved colleagues, our respected Professor Ajad Khan from Bangladesh, and all the enthusiasts of the Diabetes Awareness and You organization who have left no stone unturned to make this conference happen. And we are hosting this conference after a lapse of 2 years because of obvious COVID reasons. My topic today is diabetes remission reality check. I do express my thanks and greetings to my chairs, Dr. Kaushik Mitro and Professor Mousumi Basu. It's always very important to dwell with newer things that happen in the field of diabetes over the years. My agenda today is a case discussion, introduction, definition, significance of or implication, the evidences of the trials, case solution, and conclusion and take-home messages. We need to understand that this person, Manoj, 36-year-old corporate executive, having diabetes type 2 for 3 years, is currently on linagliptin 5 milligram and metformin 1,500 milligram daily. He is hypertensive on ramipril 5 milligram and amlodipine 5 milligram daily. And his reports show that the fasting plasma glucose is 155 milligram, postprandial 220 milligram, HbA1c 8.0%. Liver function test and kidney function test are within normal limit. His blood pressure is 120/84 on antihypertensives, not on any routine medication. With weight 86 kg, BMI 26. Both are unacceptably high, and the waist circumference is also high, 96 centimeter. Manoj has rushed to you with his reports, and although he has got an assurance from you that his blood glucose profile will get in range in few days because you are going to modify the anti-diabetic agents, he is insisting for diabetic remission, about which he has come to know from a social media in the advertisement. Now your response to his wish should be, Diabetes mellitus is a lifetime diagnosis, so you should forget about remission. Remission is not possible as you are already having this disease for 3 years. Remission is not possible as you are having comorbidity in the form of hypertension, but remission is possible with intense lifestyle modification and consistent motivation. Now the issue of this talk is to take you through certain recent data associated with diabetes remission achievement in a section of the population suffering from type 2 diabetes who are highly motivated and desirous of intensive lifestyle modification. We do know pathophysiology of type 2 diabetes is heterogeneous with contribution from both genetics and environmental factors, the food, stress, physical activity, and of course there are new data about the endocrine disruption chemicals which are happening over the last decade or so, which has identified some peculiar changes of the chemicals which do give rise to increment of insulin resistance, particularly at the level of the muscles, liver, fat and blood vessels. Now, it is also true the consensus report or definition and interpretation of remission and diabetes has been published. To introduce improvement of glucose levels into normal range can occur in some people living with diabetes either spontaneously or after medical interventions, and in some cases can persist after withdrawal of glucose-lowering pharmacotherapy. Such sustained improvement may now be occurring more often due to newer forms of treatment and newer motivated sect of the young diabetes in particular. Now, to define international expert group convened by American Diabetic Association for nomenclature has proposed remission for the most appropriate descriptive term, and HbA1c of less than 6.5% measured at least 3 months after cessation of glucose-lowering pharmacotherapy as the usual diagnostic criterion. Reason for this terminology is the underlying pathophysiology of type 2 diabetes, including both deficiency of insulin and resistance to insulin action, as well as other abnormalities, is rarely completely normalized by interventions. The changes associated with insulin resistance, particularly at the level of the adipocyte, at the level of the muscle, are very difficult to be ameliorated totally. Remission prerequisites, methods used to measure HbA1c for defining remission must be stringent, quality assurance in place, and assays must be standardized to criteria aligned to international reference value. In settings where HbA1c may be unreliable, measurement of a 24-hour mean glucose concentration by continuous glucose monitoring may be proposed as an alternative, but fasting plasma glucose and 2-hour following a 75-gram glucose load are not preferred for high variability in results. It is diagnosis of remission can only be made after all glucose-lowering agents have been withheld for an interval that is sufficient both to allow waning of the drug effects and to assess the effect of the absence of drugs on HbA1c values. If cardiac or renal comorbidities preclude stopping of any OHA, then remission cannot be diagnosed even though the normal glycemic levels are maintained. You are giving SGLT2 inhibitor with the hope of improvement of the cardiac status, renal status, with a history of heart failure admission or a doubtful history, whatever might be, it cannot be considered as remission. Gestational diabetes, steroid-induced diabetes, stress-induced hyperglycemia are all temporary and they are distinct but related to type 2 diabetes because they do show increased propensity of developing type 2 diabetes on a later date, but hyperglycemia in these situations are caused by increment of insulin resistance and may not persist when the stressor are removed. Now remission, as the epidemiologic implications are concerned, it is achieved by a change of lifestyle, other medical or surgical interventions. We have learned since 1995 that the remission have been achieved by the surgical means in the patient suffering from diabetes with unacceptable obesity. And Portis published in 1995 over 90% of remission of diabetes after Roux-en-Y surgery. And that has been then complemented by the sleeve gastrectomy, the band gastroplasty, and all these procedures. But they come with the very risk of the complications and the cost and the monitoring and the side effects of leakage, malnutrition, electrolyte disturbances, though these are very, very important issues and they are not acceptable for the majority of the population suffering from type 2 diabetes. But when the body weight is exceedingly high, we do dwell with this surgical intervention because of the hope of reduction of the body weight. But the fact that the diabetes remission occurs within hours to days after this sort of surgeries, which shows the fact that it is the dietary intake reduction which happens within a few days and removal of the fat from the vital sites, particularly the liver and other viscera. It is also the different hormonal exercises that happens in the gut in the form of ghrelin, leptin, cholecystokinin, as well as the peptide tyrosine molecule, they do have. And also there are huge hype in the knowledge of gut microbiome changes which happens with this metabolic surgery. Remission can therefore be diagnosed post-operatively and the setting of ongoing lifestyle efforts. Now, epidemiological implications also suggest that even after remission, the classic complication of diabetes, including retinopathy, nephropathy, neuropathy, and enhanced risk of cardiovascular disease, can still occur. So they do have to be checked every 6 months to 1 year interval if they are symptomless. Hence, people in remission from diabetes should be advised to have regular retinal screening, test for renal functions, food evaluation, and a measurement of the blood pressure and weight in addition to the ongoing monitoring of HbA1c. Now, another risk potentially associated with remission, possibility of the abrupt worsening of the microvascular disease like retinopathy, following the rapid reduction of the blood glucose levels after a long period of hyperglycemia, which we do always encounter in some patients coming before you with a very severe hyperglycemia and addressed effectively. Testing to determine long-term maintenance of remission should be done ideally every 3 months, but at least yearly by testing HbA1c, fasting, CGMS, if HbA1c is not appropriate. Now let us see evidence has to say what. This is one of the direct trial, diabetes remission control trial, open level cluster randomized trial in 49 primary care practices in the Scotland and Tyneside region of England, and it was published 2 years back. The inclusion criteria of this trial, eligible participants were aged 20 to 65 years of age, had been diagnosed with type 2 diabetes within a previous 6 years of time, and a BMI of 27 to 45 kg per square meter. Now, exclusion criteria, current insulin use, HbA1c more than 12, weight loss of more than 5 kg within the first 6 months, recent on-record EGFR less than 30 milliliter per minute per 1.73 square meter surface, severe or unstable heart failure, substance abuse, known cancer, myocardial infarction within the previous 6 months, current treatment with anti-obesity drugs, presence of an eating disorder or purging behavior, pregnancy or consideration of pregnancy. Now, the methodology of this trial, participants in the intervention group were asked to follow counterweight plus weight management program with aim of achieving and maintaining at least 15 kg weight loss for maximum number of participants. Weight loss was induced with a total diet replacement phase using a low energy formula diet, 825 to 853 kilocalorie per day, 59% from carbohydrate, 13% from fat, 26% from protein, and 2% fiber for 3 months, followed by structured food reintroduction for 2 to 8 weeks for long-term weight loss maintenance. The outcomes of these trials, co-primary outcomes, reduction in the weight of 15 kg or more, remission of diabetes, defined as HbA1c less than 6.5% after at least 2 months of all oral hypoglycemic agents, when withdrawal from baseline to month 12. Secondary outcomes assessed at 12 months were, of course, quality of life as measured by the EuroQOL 5 dimensions, EQ, 5D, serum lipids, and physical activity. Now, at 12 months, weight loss of 15 kg or more, which was the design goal, was recorded in 24% participants in the intervention group and no participants in the control group. Diabetes remission was recorded in 46% of the participants in the intervention group and 4% of the participants in the control group. Mean body weight fell by 10 kg in the intervention group and by 1 kg in the control group. Similar patterns were recorded with BMI and body weight change as a percentage of baseline weight. So for the results, it can be said that for all 298 participants, 149 in each group, diabetes remission was achieved by a number of participants who did not lose weight at 12 months, and 7% of participants who maintained 0 to 5 kg of weight loss, 34% of the participants with 5 to 10 kg of weight loss, 57% of the participants with 10 to 15 kg of weight loss, and what is staggering, 86% participants who lost 15 kg or more. Now, at baseline, proportion of participants taking no 1 or 2 or more anti-diabetic medications were similar in both the groups. At 12 months, 74% of the participants in the intervention group were taking no anti-diabetic medications. Mean value of HbA1c 6.4%, compared with 18% participants in the control group. Mean HbA1c was 7.2%. Also, mean number of anti-diabetic medications prescribed decreased in the intervention group and increased in the control group. Mean blood pressure at 12 months was similar between the groups, intensive and control group. But the fact is, however, antihypertensive drugs were withdrawn in 48% of the participants who had taken them at baseline in the intervention group, but no participants in the control group. So to discuss direct trial finding confirmed the type 2 diabetes of up to 6 years duration as the inclusion criteria dictated is not necessarily a permanent lifelong condition. Weight loss sufficient to achieve remission can be attained in many individuals by use of an evidence-based structured weight management program delivered in a non-specialty community setting by routine primary care staff. That's the most important part of this particular trial. Unlike those which have been undertaken in the past, are being supervised by the efficient staffs with doctors who are really trained and educated about diabetes. But this was absolutely carried out by the dietitians and the health workers in the primary care setting. Remission was closely related to the degree of weight loss maintained at 12 months, with achievement in 86% of the participants with at least 15 kg of weight loss and 73% of those with a weight loss of 10 kg or more, between 10 to 15 kg. Quality of life improved significantly in the intervention group at 12 months, but was unchanged in the control group. So lesson from the direct trial that this differs importantly, as I was just mentioning, from the most previous ones, that it was done by the real-life conditions delivered by the available local nurses and dietitians rather than specialist staff. Furthermore, no previous registered study has set remission of type 2 diabetes as a primary outcome. So importantly, remission of type 2 diabetes is a practical target for primary care in some subsets of your patients. Randomized control trial is another published recently, is the Chinese medical nutrition therapy is a randomized control trial to assess the effectiveness of intermittent fasting in diabetes remission and potential remission durability. The number of patients in this study was only 72, but the fact is the BMI range was much lower, more alike ours, 19 to 30, as opposed to 27 to 45 that it was taken in the direct trial. Primary outcome, diabetes remission defined as the stable glycated hemoglobin of less than 6.5% for at least 3 months after discontinuing the anti-diabetic medication. Intermittent fasting is an effective tool for diabetes remission. They designed their protocol in the Chinese medical nutrition therapy as periods of calorie restriction alternating with the periods of ab libitum eating, calorie restriction for 10 days, 840 kilocalories for 10 days, then intake of food as per their choice, as per their habit, as per their social norms for 5 days, and each cycle is thus of 15 days. And the Chinese medical nutrition therapy trial showed a 47.2% diabetes remission rate when remission was defined as HbA1c less than 6.5%, measured at least 3 months after cessation of glucose-lowering pharmacotherapy. Diabetes remission rate markedly exceeded the threshold level of 22% remission, which is considered the minimum clinically important difference. Even with more stringent criteria for complete remission, which describes the return to normal measures of glucose metabolism, HbA1c normal, fasting 100 milligram per deciliter of at least 1 year's duration of absence of active pharmacotherapy, and ongoing procedures, 33.3% of the participants in this Chinese medical nutrition trial group achieved complete remission. Now, diabetes remission more likely reported with the shorter diabetes duration, lower baseline HbA1c, who were prescribed fewer anti-diabetic medications as baseline. The exact definition is being practiced in a different way, but the most important thing, lower the age, higher the BMI, lower the duration of diabetes, lower the HbA1c at the time of presentation, and lesser number of anti-diabetic drug usage. So that's very important that you have to take into account. The age is low, the weight is more, BMI is more. The duration of diabetes is 3 years, 4 years, 2 years, 6 years, anything like that. And then you have to also take into account about the medications he is receiving. 65% of the participants who achieved diabetes remission had a diabetes duration of more than 6 years in this particular study. So it is now not said that below 6 years it is possible, above 6 years is not possible, suggesting a possibility of remission for patients with longer duration. What is more important is the motivation on the patient, part of the patient, and desire of the patient, which is sky high, that he wants to reduce the body weight, he wants to reduce the lifestyle risk associated with the body weight. Intermittent fasting more effective if food is culturally and socially acceptable. That was the Chinese medical nutrition therapy. So the case solution for the Manoj, he is living with type 2 diabetes for a short duration of 3 years and is highly motivated for weight loss. So he should be offered structured weight loss program, targeting a weight loss of more than 10 kg in a defined time frame of 12 months for attempting to achieve remission. So that's very important, and take-home message, I might say, remission of type 2 diabetes now can be a practical target in a subset of your patients. Careful patient selection is a prerequisite, as I have just pointed out. Structured program for weight loss, balanced diet, and other lifestyle measures are a definite necessity. Remission is a fine balance between hope and pragmatism. Sorry for being late by 2 minutes. Thank you very much.
Thank you, sir, for your excellent presentation. For me, at least, whatever sir tells, it is the like Ved Bakko. So, for question answer session, it will be later on. Our next speaker is Dr. Amita Bosur.
Dr. Amitabh Shur, he is MD in General Medicine and DM in Endocrinology. He is a senior consultant, Division of Endocrinology and Diabetology in Peerless Hospital and BK Roy Research Center in Kolkata. And he has publications in many international journals and author of multiple books. And obviously, diabetes is, and bone health, hearing loss in diabetes, these are his research interest areas. Over to Dr. Amitabh Shur.
Thank you. First of all, thank you to the organizers for giving me this platform. I am blessed today. My teacher, my mentor is sitting in front of me and has blessed me. So without wasting further time, I will be starting with the presentation. Diabetes and infection, the deadly DO. So all of us do know and do appreciate in our clinical practice that patients who are admitted in our hospital with serious infections, various category, whether urinary tract infection, whether respiratory tract infection, the first thing which comes in the mind of the treating consultant, even if the patient is not known to have diabetes, is check the glucose value of the patient to see whether the patient is having hyperglycemia or not. That is something else, that whether that hyperglycemia is because of diabetes or stress-induced hyperglycemia, but hyperglycemia is something which definitely comes in our mind. And also we have seen in data from several studies from across the world that those who are diabetics are more likely to get admitted in hospital for infection, not just general admission but also ICU admissions. Considering the number of diabetic patients in India, more than 7 crore, so this deserves special attention, this combination of diabetes and infection, and to know some of the infection which are categorically associated with diabetes and also some general associations. So predisposing factors for infection in diabetes are the altered innate immunity, including the dysfunctional polymorphonuclear leukocyte, macrophage dysfunction, defective complement action, cytokine mediated defects. And there are some other secondary factors like presence of vasculopathy, neuropathy, CKD, etc. So as you see, in diabetes particularly, the T lymphocyte and the neutrophil function comes down, leading to the reduction in the capacity of the humoral immunity. Side by side, the antioxidant system also comes down, and there is more of reactive oxygen species in the circulation. This, along with presence of angiopathy, neuropathy, and presence of glycosuria, GI dysmotility, etc., predisposes the patient to develop infection more commonly than is expected. And effect of infection on diabetes can also not be negated because it's a dual-edged sword. Actually, vicious cycle goes on. Infection per se lead to impaired glycemic control, increase in counter-regulatory hormones like steroids, like cortisol hormone, etc., and that lead to more glucose secretion from the liver. Increased cytokine alters the carbohydrate metabolism, and infection is frequently a precipitating factor also for diabetic ketoacidosis. Now, common infection in diabetes are urinary tract infections like cystitis, pyelonephritis, respiratory tract infection like Staph aureus pneumonia, gram-negative pneumonia, lung abscess, tuberculosis, skin and soft tissue infections like surgical wound infections and foot infections, abdominal infections like Salmonella enteritis, Campylobacter jejuni, and there are some other minor eye-related infection, periodontitis. Now, these are the infections which are commonly seen in diabetes. Now, next is infections which are predominantly associated with diabetes. Infections which we when encounter, we will definitely think about presence of underlying diabetes. They are malignant otitis externa, deadly diseases like rhinocerebral mucormycosis, invasive aspergillosis, emphysematous cholecystitis, emphysematous pyelonephritis, emphysematous cystitis, necrotizing fasciitis, Fourier's gangrene, and so on and so forth. So this is a short kind of a case discussion. Mr. M is a 25-year-old building construction worker. He is undergoing treatment for pulmonary tuberculosis with no family history of diabetes. His BMI is 22. His blood pressure is okay, 120/80. Now, does this patient require screening for diabetes, and why? That's the question. So, up to 14% of patients with TB actually have diabetes. Diabetes patients have a relative risk of tuberculosis, particularly pulmonary tuberculosis, of 3.11. So, peculiarities of tuberculosis in diabetic patients are relative paucity of physical sign leading to delayed diagnosis, extensive cacheation and cavitation, minimal pleural involvement, and because of that extensive cacheation, hemoptysis is more common. Insulin remains the drug of choice for controlling blood glucose in individuals with tuberculosis, considering the rapid improvement in the glucose control, helping in correction of cachexia associated with diabetes, which is seen with insulin use. And insulin somehow also helps in healing process. So oral anti-diabetic drugs can be given with caution in stable patient, but they can interact with the anti-tubercular drugs, especially rifampicin, and therefore should be used only for mild hyperglycemias. Particularly, drugs like isoniazid can also precipitate peripheral neuropathy. Tight glycemic control is important even for the success of the tuberculosis treatment. Our second case, Mr. K is 65-year-old. He is taking treatment for type 2 diabetes for past 16 years. He comes to you with complaint of severe left ear pain and ear discharge. On examination, one can make out 7th cranial nerve palsy on the left side. Blood pressure reveals poorly controlled glycemia, and total count is, say 28,000. Pus culture from ear discharge is shown to be positive for Pseudomonas. Now, what is your diagnosis? Again, considering paucity of time, we will not discuss it, and we'll be straight away coming to the answer. So, how will you manage the patient, and what is the prognosis? Now, malignant otitis externa, pseudomonal infection of external acoustic meatus and skull. It is found in elderly patient with diabetes more commonly. It presents with severe pain, ear discharge, features of facial palsy. Treatment is by aggressive debridement and anti-pseudomonal antibiotic. High mortality is seen. This image is not actually very good. Malignant otitis externa can occur in patients with diabetes who are older than 35 years. Not that it cannot happen below that, but it's mostly seen above that. There are some other conditions like perichondritis, temporal bone osteomyelitis, which can get confused with malignant otitis externa. Infection usually start at external auditory canal and spread to the adjacent soft tissue, cartilage and bone. So early diagnosis is very important. Patient typically present with severe ear pain and otorrhea. Fever may be absent. Although patient often have pre-existing otitis externa, progression to invasive disease won't give you much time. It's rapid. Examination of auditory canal may reveal granulation tissue and involvement of cranial nerves. Prompt surgical consultation is mandatory. Surgical debridement is an essential part of treatment. IV anti-pseudomonal antibiotic should be started as soon as possible. For milder cases, we can consider fluoroquinolones, etc. I think we will not go in much details of the treatment part. So again, coming to the case study tree, Mr. A is a 45-year-old male patient. He has had diabetes for last 5 years. He is currently on combination of glimepiride 1 mg plus metformin 500 mg twice daily. He is quite erratic in treatment and doesn't go for regular follow-up. He presented one morning to doctor with headache, fever and anorexia for the last 1 week. He also has developed swelling over his eyes and proptosis that is more prominent in the left side. He has inability to open the left eye since the morning on the day of the visit to doctor. His random glucose shows a glucose value of 450 mg per dl and HbA1c of 11.4%. Now, what is your working diagnosis? How will you manage this patient? What complications are possible if proper treatment is not available? That's the question, that's the case situation. Again, coming to the answer. So, we are basically here dealing with rhinocerebral mucormycosis. It's a deadly disease with up to 80% mortality. So, even if you diagnose it correctly and treatment started in time, then also the survival is around 20%. Infection of nasal cavity and orbit by fungi of Epsteria rhizopus and mucor group found in debilitated patient, usually having poor glucose control. Usual presentation is fever along with facial or ocular pain, extraocular muscle palsy, proptosis, nasal stuffiness. Characteristic black ischium seen over the nasal turbinates. Complications include cavernous venous thrombosis, brain abscess, etc. Treatment is surgical. Antifungals like amphotericin B, etc. can be given. Again, treatment, there are other antifungals. We are not going in that details here. Necrotizing fasciitis and furious gangrene. These are another two groups which can be seen in any patient, but then again diabetics patients are more at risk of it. Common sites are abdomen, perineum and extremities present with pain and other local signs of inflammation. Initially spares skin and muscle. Infection of soft tissue caused by Streptococcus, Staph aureus and anaerobes. There are 3 types, type 1, type 2, type 3, etc. Diagnosis is with culture. Treatment is again surgical help has to be taken, debridement and surgery along with broad spectrum antibiotic. Needless to say, proper glucose control is essential. Furious gangrene, necrotizing fasciitis of the perineum, scrotum and penile region is particularly called Furious gangrene. The organisms are slightly different. E. coli, Bacteroides are predominant organism here. Usually present with scrotal pain with swelling and systemic toxicity, sloughing of scrotal skin leading to kind of shameful exposure, it's said like that. Again, surgical treatment is essential. Unroofing of lesion, debridement, orchidectomy sometimes can be required. Mortality is high. Broad spectrum antibiotics are key along with debridement. Coming to our fourth case, Mr. P is a 46-year-old gentleman. Mrs. P is a 46-year-old lady. She is diabetic on OHS. Now, she complains of fever for last 3 days along with vomiting, abdominal pain and dysuria or burning sensation in the urine. Clinical condition, patient is very toxic. febrile, dehydrated. There is severe tenderness in the left renal angle. So this situation is now seen, I think I have seen it, I'm seeing it little bit more common in the era of SGLT2 inhibitors. No, I don't mean here that SGLT2 inhibitors should be used with much of caution, but then that is happening. So urine examination shows plenty of pus cells and pus cast. Urine for acetone is negative. Glucose control is again bad. Creatinine is 1.4. Total counts is 38,680. What is the working diagnosis? What investigation will confirm the diagnosis? And what is the line of management? We are going through a very basic line of the presentation is very basic actually. We cannot go in details of any particular case. Otherwise, only one case will consume the entire time. So purpose is to have an idea of how to diagnose, nothing else. So emphysematous pyelonephritis, as you can see in the image on your right side, in the arrow mark shows air in the ureter, right side ureter, along with some air in the kidney. The kidneys are swollen on the right side. So necrotizing infection of the renal parenchyma and surrounding tissue is called emphysematous pyelonephritis, almost exclusively found in patients with diabetes. There is a female preponderance. Why? Not very clearly known. Causative agents are E. coli and Klebsiella. In 70 and 30% of cases, 10% can be other things. Gas is formed by fermentation of glucose. Radiological investigation in the form of CT is the investigation of choice to demonstrate gas. Management is again broad spectrum antibiotic, percutaneous drainage of pus. Rarely nephrectomy is also needed. Coming from here to emphysematous cystitis. Emphysematous cystitis, you can see gas in the bladder. Please see below in the image. There is a gas inside the bladder as well as on the bladder wall. It is also a condition which is not very uncommon, but relatively uncommon compared to emphysematous pyelonephritis. It also has high mortality like emphysematous pyelonephritis. Around 10% mortality is seen. Gas in the bladder wall is the characteristic. It presents with hematuria, pneumoturia and abdominal pain. Surgical intervention is again needed here also in 20% of patients at least. Emphysematous cholecystitis is not very common. I have seen one patient when of emphysematous cholecystitis. Maybe surgeons have seen more cases. A rare variant of acute cholecystitis which presents with ischemia of gallbladder wall and infection with gas producing organisms. Gangrene and perforation of gallbladder is common. Clostridium perfringens, E. coli and Bacillus fragilis are the common pathogens. Interestingly, mostly from acalculous cystic duct obstruction followed by cystic artery occlusion, underlying gallstone is seen in only 50% of patients. Again, CT is the imaging of choice. Image gas is documented in the intramural or intraluminal part of the gallbladder as you see in the right side of your screen. Again, infected diabetic foot we will not discuss here. Diabetic foot is a completely separate topic, but then we cannot close it before dealing with mentioning infected diabetic foot. Foot infection are the most common soft tissue infection seen with diabetes. Peripheral neuropathy and vasculopathy are the drivers. Streptococcus, Staph aureus, anaerobes, gram-negative rods, all can be pathogens, either mixture of them or one or two can be the causative pathogen for it. Debridement of necrotic tissue, antibiotics along with glucose control, hypertension, lipid and anemia correction, and most importantly offloading is the mainstay of treatment. Foot ulcers are often the prerequisite for development of osteomyelitis and even sometimes septic arthritis. Now this is again, I have not mentioned here any text here. This is a kind of, this is something which we deal rarely, we see not very uncommonly. Sepsis at the site of insulin injection for people who do not maintain proper hygiene and all. So this is also something which we need to do. A brief discussion on superficial fungal infections. Uncontrolled hyperglycemia lead to impaired immunity and that lead to increased incidences of fungal infection are seen in diabetic patient compared to non-diabetic. Fungal growth are found mainly in the oral cavity along with toe, urine, hair, nail sample, etc. Predominant fungi seen in diabetic patients are Candida, Aspergillus and trichophytes. So fungal infection of skin and adnexal regions such as hair and nail are common. Skipping the epidemiology and all. Okay. So non-Aspergillus mold, zygomycosis and other fungals are responsible for these fungal infections which we see in diabetes. We are more scared of invasive aspergillosis and candidiasis. So type of fungal infection, superficial as well as systemic. Systemic in the form of candidiasis and invasive aspergillosis, and superficial in the form of tinea capitis, crudis, etc., oral candidiasis, candidal vaginitis, etc. These are seen more commonly in diabetic patients. Okay, this is a description. So dermatophyte infections are seen, they can be seen in anyone, but diabetics are more likely to develop them. Tinea capitis, I will just naming it because the session is close, time is less. Tinea pedis, as you can see. Tinea manum in the hand. So we need to give antifungal ointments and all for treatment. Sometimes oral antifungals are also needed. Tinea of the groin, tinea corporis. I am just showing you the images. So causes of fungal infections are again staying in the moist environment, any injury, cut, etc. So risk factor, most important one is of course diabetes, apart from use of steroids, etc. There are several challenges in then we have to come to the antifungal treatment. Antifungal treatments are of several types, topical as well as systemic, and it has to be given according to the choice. Now last part, coming to the vaccines. We must recommend vaccine for our patients who are living with diabetes, at least those of them who are above 50 years of age. I think all type 2 diabetic patients are candidate for vaccines. Pneumococcal vaccines and influenza vaccines should be recommended. Influenza vaccines is given annually, and pneumococcal vaccine is available in the form of pneumococcal conjugate vaccine and PSV23. So that should also be considered for all diabetic patients, and I think the vaccine recommendations are much less than they should be in our routine clinical practice. If we think about how many patients we actually recommend vaccine, it is much less than what we should actually do. So other vaccines like hepatitis B vaccine, herpes zoster vaccines have also come. Tetanus, diphtheria, pertussis vaccine should also be considered. So I will be stopping here. Thank you. The session is open for discussion from my side now.
Thank you, Dr. Sur, for your, especially for within timely, you have finished it. So question answer session will be later on. The last speaker is, for this session is Dr. Somnath Naskar. Somnath is Associate Professor in Community Medicine of IPGMER and also now the Joint Director of WBP SACS. And Somnath is my colleague, my friend and my brother also. So over to Somnath.
Okay. So, thank you, madam. Thank you, chairpersons, the dignitaries on the dais, off the dais. At the outset, I must thank Day for their multifaceted activities and for giving me this opportunity to speak in front of this august audience. So, my topic is diabetes and vaccination. So, after the topic, which is infection and diabetes, so it's pretty easy. Actually, the vaccination should come before the infection, but yes, after one suffers from infection, it's easier to assume, it's easier to know the consequence of the infection and the importance of vaccination. So it has been already discussed, and we all know that diabetes and infection shares a vicious cycle. So diabetes, any person with diabetes are more prone to infection, and once the person is having any kind of infection, it eventually worsens the glycemic control. So, and the cycle goes on. So it's kind of a vicious cycle, and there is even after knowing all these things that it causes infection, mostly in a developing country like India, but still there is a gap. I mean, in having the infection, the vaccination. So we have conducted a study also regarding infection, regarding vaccination status among the diabetic people, and the proportion is pretty low. So we know that there is a gap. We know it has to be bridged but this is missing. Now, vaccination has been tried. The way to improve immunity has been tried from centuries by different processes, maybe by use of different things, maybe snake venoms to increase the immunity, but the most accepted one, the breakthrough research which came, the experiment which came from Dr. Edward Jenner when he inoculated the fluid from the cowpox pustule in an 8-year-old boy, John Phipp. And the boy didn't develop the smallpox, only he developed a mild form of the cowpox, and this made the history. So with this vaccine, we could eradicate the deadly infection smallpox. Now, the term vaccination, it came from a Latin word that is vacca, which means cow. Again, it is, as the first vaccine was from cowpox, so this was from vacca, the term vaccination has been derived. Now, some success stories of vaccination, like smallpox has been eradicated globally. Polio has been eradicated from India, from most of the world except 2 countries like Afghanistan and Pakistan. Infant or childhood immunization is one of the top public health success stories of the 20th century. The vaccine preventable diseases among children like diphtheria, pertussis, tetanus, measles, mumps, rubella, the prevalence have been reduced in children. Now the question is, are vaccinations for kids only? The answer is precisely no. It's for the vulnerable population. So besides children, it's for pregnant women, for elderly people, for us, the healthcare workers, and for individuals with chronic medical conditions like diabetes. So again, it has been discussed that the immunity is initially it's immature. It grows up, it develops along with the growing age. It reaches its peak around adulthood during youth, and eventually it again decline with the progress in the age. And this is called immunosenescence, and there are a number of pathophysiology related to it, starting from the reduction in the number and function of the T cell, B cell, natural killer cell, neutrophils, and the impaired function of the lungs, GI dysmotility, muscle, heart, brain, everything. The pathophysiology has been discussed in the previous session also. It's very common. It's very much related, diabetes and infection. So the there is compromise, the immunity is compromised among diabetes people. Now this is the recommendation by CDC, adult immunization schedule. So we know that most important things are like influenza and pneumonia. So for influenza, it's annual dose. One vaccine should be taken annually. It is either trivalent influenza vaccine or quadrivalent influenza vaccine, usually given during the month of September, may be given pre-monsoon during May, June also. So another important thing is pneumococcal vaccine. There are 2 types of pneumococcal vaccine. One is PCV13, another is PPSV23. These 2 are available in India. PCV13 is given as a single dose for adults, and PPSV23 is usually given as single dose 1 year after the PCV13. But in immunocompromised people may be given after 8 weeks of the PCV13, provided the person is less than 65 years of age, and if the first dose is given before 65 years of age, once the person achieves 65 years of age, then another vaccination of PPSV23 should be given. Another important vaccine is hepatitis B vaccine. That is, the dosage is 3 dosage, usually given 0, 1, and 6 months. It's given intramuscularly because as we know that type 2 diabetic people are exposed to multiple kinds of invasive interventions, and that's why there is increased risk of having hepatitis B also. So another important vaccine is zoster recombinant vaccine. It has to be given as 2 doses once the person is more than 50 years of age. Again, it's given intramuscularly, and the gap between the 2 doses should be 8 weeks. that's 2 months, may be extended up to 6 months. Another important thing is tetanus, diphtheria, and pertussis vaccine, Tdap vaccine or cellular pertussis. And as we know, because initially it was among the children only. The tetanus can happen in any age, but the prevalence has been, there is epidemiological shifting. Because of the vaccination, it is happening in the adult age also, and it's underdiagnosed. Because many a times there is no characteristic hoop for pertussis. So again, it's very much recommended for all adults. For diabetes, it's a must. 1 dose should be given and followed by a booster every 10 years with Tdap or a TD vaccine. So another important vaccine is HPV. So it should be given from 9 years to 26 years, maybe given up to 45 years. If it is from 9 to 14 years, the dosage are 2 at 0 and 6 months. And if it is more than 14 years, 15 to 45 years, the dosage should be, there should be 3 dosage for this. So these are the vaccines which are recommended for diabetes people. So this is the recommendation by CDC also. This is recommended by RSSDI also. So now, even after all these things, most of the things are known to us. Indian adults in general are under-immunized. There are different studies. There one study from AIMS, we did a study. So, and it was seen that the vaccination is less all through. And it's somewhat more for influenza and pneumonia, maybe hepatitis B, but other vaccine are, almost nil. So people are not receiving the vaccines which are recommended, and there are several barriers or several gaps for adult immunization, adult vaccination. So one is lack of surveillance. One is lack of national recommendations, like there are some guidelines, like CDC guidelines are there, RSSDI guidelines are there, but as there are national guideline for children, there is no such consensus guideline for adults. Lack of coordinated adult vaccination program. Again, it's for children is there, but for adult it's not there. Now, treatment taking precedence over prevention. So, in our study also, we have found that people are saying that why on earth we are taking the vaccine while we are not having any symptoms, we are not having any infections like that. So, the awareness is still low, but it's more after COVID infection, people have taken vaccination, but still it's low. Lack of provider recommendation. This is again another important issue. So it's not only among the beneficiaries, it's pretty much prevalent in case of, from the point of view of the provider also. The number may be, the reason may be different, maybe varied reasons, maybe because of cost, sometimes maybe because of lack of awareness or something. Another important issue is cost. Yes, some of the vaccines are really costly, but if we think of the long-term cost, if we think of the cumulative cost, actually it's less. If we think of the out-of-pocket expenditure of severe pneumonia or other infections, if we think of the healthcare infrastructure which have been occupied, so if we think of all these things, we can see that actually the cost is much higher for the country, for the community, or for the individual. But still, at that point of time, as it's costly, it's some kind of barrier, unless the good awareness has been developed. Now, another issue is the lack of recognition of benefits, efficacy, or safety. So, again, most of the awareness is very low, and the safety concern, again, in our study also, we have found that most of the people who are not getting the vaccination, who are not willing to take the vaccination, they said that because of the fear of the side effects. So what kind of side effects will have? So because of that apprehension, people are not, many of the people are not getting the vaccination which is required. So, and this fear and apprehension is age old. So we have seen, this is again, this is a famous picture. by a British satirist, James Gilray, who depicted the fear of side effects. This is the person. You can see in the middle, the person has been depicted as Dr. Edward Jenner. So he's inoculating the vaccine to a person for cowpox, for prevention of smallpox. And you can see that the cows are coming out from different parts of the body, from nose, from eyes, from mouth, from where not. So, such was the apprehension or the fear of side effects, and this type of thing. There were lots of things like that for BCG vaccination, for polio vaccination, for every field. So the fear of side effects or this apprehension is a big gap or barrier for this vaccination. So this is a famous quote from Louis Pasteur. He said that when meditating over a disease, I never think of finding a remedy for it, but instead a means of prevention. So the bottom line is, don't wait, vaccinate, otherwise it will be too late. So thank you all. So I've finished way before the time.
Thank you, Somnath, for your excellent deliberation. Now it's time for question and answers. One of our speakers, Dr. Amitabh Shur, he has led for some exigencies. Other three speakers are here. I would like the audience, if you have any queries, any clarifications from the speakers, you are free to ask questions. Anyone, please? So I think nobody has any questions for anyone. So this session of yoga is closed for now. We may move on to the DRS.
Thank you.
Thank you.
Thank you so very much, sir. It was a wonderful, insightful session for all the audience. But before you finally take your seat, I once again request our honorable speakers, Dr. Ridesh N. Chakraborty, Dr. Somnath Noshkar and Dr. Apurva Kumar Mukherjee to kindly be on stage, and we are to offer a token of appreciation and love from day's end, and also request Dr. Moushumi Basu and Dr. Kaushik Mitra to please be on stage because a small token of appreciation and love from the end of day. And I request Madhumati Di to please be there on stage to do the honor. So I request Dr. Ridesh N. Chakraborty, if you can kindly be here, Dr. Somnath Noshkar, Dr. Apurva Kumar Mukherjee, and also our chairpersons, Dr. Moushumi Basu, Dr. Kaushik Mitra, to please be on stage and receive the token of appreciation from the day. So sir is also here. I'm so sorry. So please, sir, Dr. Amitabh Shur, I also request him to be on stage. So we are honored to get all of you here. Let us keep this moment together with a huge round of applause. So Dr. Ridesh N. Chakraborty, Dr. Somnath Noshkar is to receive the token of appreciation. So Dr. Apurva Shur is here, so I request Madhumati Madam to kindly do the honor. So Dr. Apurva Kumar Mukherjee is also here. We are grateful to sir, and let us acknowledge sir with a token of appreciation. So yes. So Dr. Ridesh N. Chakraborty, Kaushik Mitra sir is being receiving, and we also have Dr. Amitabh Shur sir here. So I request Madam to kindly give the token of appreciation. Thank you so very much. Okay, so sir is here, Ridesh sir is here with us. So Madhumati Madam, thank you so very much. all of you. I request Bijoy Madam to please come forward.
Thank you, respected dignitaries, respected speakers, and respected chairpersons for this extremely insightful session. So now as we move towards the session and the cricket excitement continues. And let's not forget the decision review system or DRS in a cricket, a lifeline to change an umpire's decision. Similarly, in healthcare, your health is in your hands. So if you receive a diagnosis or medical advice, it's like an umpire's decision. It's your right to seek a second opinion, just like a DRS review, to ensure the best outcome for your health. So to get into the bestest possible option, as in the DRS, let's now have the inaugural ceremony. And to begin, let's welcome on stage our umpire cum moderator, Mr. Indrajit Mujumdar, Secretary of Day, with a huge round of applause. And I may now hand it over to Dr. Anuradha Mukherjee. Over to you, ma'am.
So now let's welcome our chief guest, Dr. A.K. Azad Khan, sir, Chair, Southeast Asian region. And I request our Indrajit sir to please continue.
Thank you, Anuradha and Bijoya. Now, inaugural program, Daycon 2023. আমরা ভীষণ খুশি আজকে আমাদের মধ্যে আমাদের চিফ গেস্ট আছেন প্রফেসর একে আজাদ খান স্যার, ন্যাশনাল প্রফেসর, প্রেসিডেন্ট বাংলাদেশ ডায়াবেটিক একাডেমি, ডায়াবেটিস সমিতি এবং চেয়ার ইন্টারন্যাশনাল ডায়াবেটিস ফেডারেশন সাউথ ইস্ট এশিয়া রিজিয়ন। আমি মঞ্চে আসার জন্য অনুরোধ করব প্রথমেই প্রফেসর ডাক্তার অপূর্ব কুমার মুখার্জি, প্রেসিডেন্ট ডে। আমি রিকোয়েস্ট করব ডাক্তার সুজয় মজুমদার, ভাইস প্রেসিডেন্ট ডে, ডাক্তার মেরিডি ক্রুজ, ভাইস প্রেসিডেন্ট ডে, এবং ডাক্তার রাকেশ কুমার, অ্যাসিস্ট্যান্ট সেক্রেটারি as well as the joint organizing secretary of the day, Daycon 2023. And request করব আমাদের চিফ গেস্ট প্রফেসর একে আজাদ খান, প্লিজ স্যারের মতো মানুষকে আমরা পেয়েছি আজকে আমাদের মধ্যে। বাংলাদেশ ডায়াবেটিক সমিতি সম্পর্কে হয়তো আপনারা অনেকেই জানেন, গত প্রায় 70 বছর ধরে তারা কাজ করছেন বাংলাদেশ ডায়াবেটিক সমিতি। স্যার সেই ডায়াবেটিক সমিতির প্রেসিডেন্ট এবং অ্যাজ ওয়েল অ্যাজ আইডিএফ সাউথ ইস্ট এশিয়ার চেয়ার। আমরা স্যারকে আমাদের প্রথম ভালোবাসা দেব। স্যারকে আমাদের ভালোবাসা প্রদান করবেন আমাদের প্রেসিডেন্ট প্রফেসর অপূর্ব কুমার মুখার্জি। এবং আমরা কয়েকদিন আগে 8th ডে ডিআইসি করেছিলাম, তাতে আমরা 2টি বই পাবলিশ করেছিলাম, তার কমপ্লিমেন্টারি কপি স্যারের হাতে তুলে দিচ্ছি আমরা। থ্যাংক ইউ। আমরা একটু সময় নেব আপনাদের ডের জার্নি একটু শেয়ার করবো আপনাদের সকলের সাথে। একটু গ্যাপে চলে আসুন। we have completed our journey, 17 years of journey. This is our National Executive Committee. What we are doing, preventive measures, the school program, the student awareness program. Now we are continuing this because মাঝখানে করোনার জন্য আমরা এটা বন্ধ রেখেছিলাম, আবার আমরা ফুল ফেজে এটা শুরু করেছি, স্টুডেন্ট অ্যাওয়ারনেস প্রোগ্রাম অন এনসিটি। ডায়াবেটিস ক্যাম্প অ্যান্ড সেমিনার অলমোস্ট প্রতিদিন চলে আমাদের। মোবাইল ডায়াবেটিস সেন্টার, এটা 2010 সাল থেকে আমরা চালাচ্ছি এবং এই বছর ওয়ার্ল্ড ডায়াবেটিসের সাথে আমরা নতুন জিনিস অ্যাড করব, সেটা হচ্ছে মোবাইল ডায়াবেটিস ফুড স্ক্রিনিং ক্লিনিক। Curative measure, we have the ambulance service, select patient sponsorship program, and separate T1D support group. Curative measure, we have adopted a village under Sonarpur block for the last almost 2011, since 2011. Diabetes monitor project, monitoring is most important in diabetes. Respect and care of domicile care project for the elderly people. We have 2 courses which are recognized by the Gop College. We have a different research wing. In policy advocacy part, we have launched a slogan, trilingual slogan in 2009. Ultimately in 2030, it was adopted by the government of India. Now is the guideline is 30 বছর বয়স হয়ে গেলে প্রত্যেককে প্রতি বছর ব্লাড সুগার টেস্ট করতে হবে। আমাদের স্লোগান, বয়স হলে 30 বছর ব্লাড সুগার টেস্ট প্রতি বছর, গর্ভবতী হলেন যিনি দেখতেই হবে তার চিনি। ডায়াবেটিস নিয়ে স্ট্যাম্প আমরা পাবলিশ করেছিলাম 2014 সালে। ওয়েস্ট বেঙ্গল অ্যাসেম্বলিতে প্রোগ্রাম করেছিলাম 2012 সালে। মনুমেন্টকে ব্লু লিড করেছিলাম 2009 সালে। এবং ইন্টারন্যাশনাল ডায়াবেটিস এডুকেটার্স ডে লঞ্চ হয়েছিল 2016 সালে। লঞ্চ করেছিলেন দিদেন আইডিএফ প্রেসিডেন্ট প্রফেসর সরিকট স্যার, এবং আমাদের অপূর্ব মুখার্জি স্যারও তখন ছিলেন। আমাদের একটা মুভি আছে ডে, ইউটিউবে অ্যাভেলেবেল, 22 মিনিটের মুভি, একটা ফিকশনাল মুভি অন ডায়াবেটিস। Mr. Day, the brand ambassador of the diabetes awareness, or mascot of diabetes. 2019 launch হয়েছিল প্রেস ক্লাবে। এটা ইনিশিয়েটিভ বাই মিস্টার ডে। মাইলস্টোনস, ইন্দো বাংলাদেশ সাইকেল এক্সপিডিশন, টাইপ 1D ফাউন্ডেশন, বেস্ট ইন্ডিয়ান ডায়াবেটিস এডুকেটার অ্যাওয়ার্ড আমরা ইনস্টিটিউট করেছি 2019 সাল থেকে, যেটা প্রতি বছর চলে। প্যান ইন্ডিয়া একটা কম্পিটিশন। দিস আওয়ার সচেতনতা ভবন, আওয়ার ওন বিল্ডিং। কোভিড-19 আমরা প্রচুর কাজ করেছিলাম। সেই সময় দাঁড়িয়ে আমরা ছিলাম আনলক, মানে স্পেশালি WBCPCR এর সাথে আমরা কোলাবোরেট করে সারা ওয়েস্ট বেঙ্গলের টাইপ 1 দিদের এসেন্সিয়াল থিংস আমরা এদের ডোর স্টেপ পৌঁছেছিলাম। ইনসুলিন, গ্লুকোমিটার স্টিপস, এভরিথিং। কিছু অ্যাচিভমেন্ট, RSSDR অ্যাওয়ার্ড। একটা ইনোভেটিভ কাজ আমরা করেছিলাম 17th ইন্ডিপেন্ডেন্স ডে উপলক্ষে। সারা ভারতবর্ষে থেকে 75 জন T1D পার্টিসিপেট করেছিল একটা ভার্চুয়াল প্রোগ্রামে। We have a virtual T1D school. Presently, it has been accepted by the ITF Southeast Asia as an innovative project. ডায়াবেটিস বোর্ড, এটা গত ওয়ার্ল্ড ডায়াবেটিস ডেতে আমরা সুন্দরবনে লঞ্চ করেছি। সুন্দরবনের ডায়াবেটিস প্রজেক্ট এটা চলে আমাদের 4 বছর ধরে। এই ডায়াবেটিস বোর্ডটার মেইন কাজ হচ্ছে ডায়াবেটিস কমপ্লিকেশন ডিটেক্ট করা। বিভিন্ন আইল্যান্ডে ঘুরে মাসে একদিন হয়। ইনফ্যাক্ট আগামীকালই আমাদের এই প্রজেক্টটা আছে। আমরা সুন্দরবনের বালি দ্বীপে যাব কালকে। আমরা একটা ঘোষণা করেছি 2টো রিসার্চ গ্র্যান্ট, একটা ফর দ্য ডায়াবেটিস এডুকেটার, একটা ফর ডায়েটিশিয়ান অ্যান্ড নিউট্রিশনিস্ট। এবছরের অ্যাপ্লিকেশন ক্লোজ হলো 31 অক্টোবর। ভারতবর্ষ থেকে রেসপন্স পেয়েছি আমরা ভালো। in memory of Ila Mojumdar and in memory of Professor Dr. Ashit Baron Sandal. We have published 2 books, updated guideline for the diabetes educator and dietitians, যেটা আমরা পাবলিশ করেছি। আজকে আমরা তাদের হাতে তুলে দেবো কমপ্লিমেন্টারি কপিজ যারা অথর। এইটা আজকে আমরা করব, আমাদের এই কনফারেন্সটা অর্গানাইজ করছি ইন অবজারভেন্স অফ ওয়ার্ল্ড ডায়াবেটিস ডে। আজকে আমাদের চিফ গেস্ট এবং আমাদের বাকিরা সবাই মিলে আমরা এটা প্লেজ করব, ডান দিকে রাখা আছে ওটা। সেটা হচ্ছে ডায়াবেটিস কেয়ার টু অল and foster a diabetes aware society and add healthy years to life. তো that is from my part. আমি রিকোয়েস্ট করব আমাদের প্রেসিডেন্ট প্রফেসর ডাক্তার অপূর্ব মুখার্জিকে কিছু বলার জন্য।
আমাদের প্রধান অতিথি মাননীয় ডাক্তার আজাদ খান মহাশয়কে আমাদের সকলের তরফ থেকে বিশেষভাবে কৃতজ্ঞতা, প্রণাম, অভিনন্দন ও শুভেচ্ছা জানাই। শুভ বিজয়া প্রীতি এবং আমাদের আন্তরিক ভালোবাসা ওনার জন্য এবং ওনার পরিবারের সকলের জন্য। আপনারা তো জানেন না, প্রফেসর আজাদ খানের পরিবার বিশাল বৃহৎ। পুরো পরিবারটাই হচ্ছে বাংলাদেশ ডায়াবেটিক সমিতি। উনি নিজে হাতে গড়েছেন আরও অনেক উৎসাহী সদস্যদের নিয়ে। আজকে আমাদের এই প্রতিবেশী দেশ বাংলাদেশ একটা স্বাধীন রাষ্ট্র, কিন্তু আমরা বিশেষভাবে আপ্লুত বোধ করি একটাই কারণে, যে ওদের মাতৃভাষা বাংলা, ওদের জাতীয় সঙ্গীত আমার সোনার বাংলা আমি তোমায় ভালোবাসি। শুধু এই জন্য নয়, নিরলস প্রচেষ্টা, বিশেষ করে বাংলাদেশ স্বাধীন হওয়ার 10 বছর পর থেকেই যেভাবে প্রফেসর আজাদ খান মহাশয় করেছেন এবং প্রচুর মানুষকে শিক্ষিত করেছেন অ্যাবাউট ডায়াবেটিস। প্রচুর প্রত্যন্ত জেলায় জেলায়, গ্রামে গ্রামে ওনাদের কর্মসূচি যেভাবে চলতো, আমি সেগুলো খুব সুচারুভাবে ফলো করার চেষ্টা করতাম এবং দেখতাম যে এরকম ডেডিকেশান এবং এরকম সিনসিয়ারিটি থাকলে তবেই এই জায়গায় পৌঁছানো যায়। আপনারা হয়তো জানেন, এখন বাংলাদেশে যারা ডায়াবেটিসে ভুগছেন তাদের শতকরা 90%-রও বেশি বাংলাদেশ ডায়াবেটিস সমিতির যে পাঠ্য বই, তাদের যে নির্দেশনামা, যে বিভিন্ন প্রেসক্রিপশানের যে নথি, সব এক জায়গায় গ্রন্থিত করা, এবং সেটা যার হাতেই পড়ুক না কেন সে কিছু সময়ের মধ্যে সবটা বুঝে নিতে পারবে। এবং অ্যানুয়াল ফুড এক্সামিনেশান, ফুড স্ক্রিনিং, বায়োস্টেশিওমিটার রিডিং, তার পিন প্রিক এস্টিমেশানে কী ছিল, তার রেটিনাল স্ক্যানে কী ছিল, তার ফটোগ্রাফ কবে তোলা হয়েছিল, তার ইসিজিতে কী আছে, তার ডিসলিপিডিমিয়া আছে কি না, কী ওষুধ খাচ্ছে, সমস্ত কিছু এক জায়গায় এই বই আকারে রুগীদের কাছে আছে। আমি এই কথা বলে আমার বিনম্র শ্রদ্ধা জানাই এবং আমাদের উপস্থিত সবাইকে অনুরোধ করছি ওনার প্রতি অভিনন্দন হিসাবে আপনারা আমার বক্তব্যের শেষে অবশ্যই করতালি দেবেন। ডায়াবেটিস অ্যাওয়ারনেস অ্যান্ড ইউ, এইটা একটা আন্দোলন মাত্র, এবং এটা 17 বছর আগে যখন শুরু হয়েছিল সেই দিন থেকে আজ পর্যন্ত ইন্দ্রজিৎ মজুমদার, ও নিজে ইন্টারন্যাশনাল ডায়াবেটিক ফেডারেশনের লাইভ মেম্বার, এবং ওর যে এর প্রতি যে প্যাশন, যে ইমোশন, ও এটার প্রতি নিয়তভাবে দৈনিক ভিত্তিতে ও এটার পেছনে যা করে, তা আমাকে অন্তত, আমার অভিজ্ঞতা অনেক, আমি অনেককে দেখেছি, অনেক কিছু করেছি, কিন্তু ওকে দেখে আমি সত্যি আশ্চর্য হই এবং আপনারা একটু আগে দেখলেন কর্মকাণ্ডগুলোর কথা। এই সব কিছু 17 বছরের মধ্যে কিন্তু অর্জন করেছে এবং তার জন্য ওর একটা গোটা টিম আছে এবং তারাও প্রত্যেকে মানে অত্যন্ত ডেডিকেটেড এবং অত্যন্ত সিনসিয়ার অ্যান্ড অনেস্ট টু দেয়ার পারপাস। আমি এই অনুষ্ঠানের মাধ্যমে ডে সংগঠনের সমস্ত সদস্য, বিশেষ করে যারা ইন্দ্রজিতের কাণ্ডারি হিসেবে এই এক জাহাজ বয়ে নিয়ে যাচ্ছে, তাদের প্রত্যেককে আমার কৃতজ্ঞতা, ধন্যবাদ ও শুভেচ্ছা জানাই। এবং যা কিছু ইন্দ্রজিৎ আপনাদের দেখিয়েছে, এই সব কিছু মাথায় রেখে আমি বলছি ওর ভিশন কিন্তু আরও অনেক কিছু করার। আপনাদের অনেক সময় ও আপনাদের এটা বলবে, সেটা বলবে, আপনাদের অনুরোধ করবে। এই যে সুন্দরবনে মাসে একদিন যাওয়া, এক একটা দ্বীপে যেভাবে ও কর্মকাণ্ডটা চালাচ্ছে, 1 বছর হলো প্রায়। কালকে মাননীয় ডক্টর আজাদ খান মহাশয়ও সুন্দরবন ক্যাম্পে, সুন্দরবন ডায়াবেটিস বোর্ডে সঙ্গী হতে যাচ্ছেন। আপনারাও যদি উদ্যোগী বোধ করেন, আপনারাও যেতে পারেন। সেখানে রুগী দেখা, রুগীকে পরিষেবা দান করা, এগুলো আপনার মানসিক তৃপ্তি দেবে আর নিসর্গ শোভা তো আনন্দ দেবেই। আমি উপস্থিত প্রত্যেকের জন্য আমার আন্তরিক শুভ বিজয় শুভেচ্ছা এবং আপনাদের আমাদের প্রতি ভালোবাসা, ডে অর্গানাইজেশনের শ্রীবৃদ্ধির উপর আপনাদের বিশেষ নজর রাখা এবং দরকারে আমাদের সাহায্য করার জন্য অনুরোধ জানিয়ে আপনাদের প্রত্যেকের এবং প্রত্যেকের পরিবারবর্গকে আমার ব্যক্তিগত স্বাগত শুভেচ্ছা জানিয়ে আমার বক্তব্য শেষ করছি। নমস্কার।
Thank you, sir. I would like to request Dr. Sujay Mujumdar, our Vice President and convener of the Scientific Committee of the Daycon 2023, to say something.
থ্যাংক ইউ ইন্দ্রজিৎ। ডায়াবেটিস অ্যাওয়ারনেস অ্যান্ড ইউ, আপনারা সকলেই শুনলেন যে এটা একটা অর্গানাইজেশন শুরু হয়েছিল প্রধানত স্বেচ্ছাসেবামূলক অর্গানাইজেশন হিসেবে, এবং আমাদের কতগুলো জিনিস যেগুলো ইন্দ্রজিৎ বলেছে, আমাদের প্রচুর পেশেন্টকে, বিশেষ করে গরিব টাইপ 1 ডায়াবেটিস পেশেন্টদের আমরা একটা ফ্রি সার্ভিস প্রোভাইড করি এবং আমাদের রস্টারে বর্তমানে প্রায় 1,500-এরও বেশি টাইপ 1 ডায়াবেটিস পেশেন্ট রয়েছে যাদের আমরা ফ্রি ইনসুলিন, ফ্রি গ্লুকোমিটার স্ট্রিপ প্রোভাইড করি। এটা কিন্তু সারা ভারতবর্ষে, এটা আমরা যেটুকু খোঁজ নিয়ে দেখেছি যে এই কাজটা কিন্তু খুব বেশি অর্গানাইজেশন করে না। কিন্তু যে কোনো একটা অর্গানাইজেশনকে এগোতে গেলে যেটা দরকার সেটা হচ্ছে নলেজ অ্যান্ড এডুকেশন। এডুকেশন ছাড়া আমরা কিন্তু কোথাও এগোতে পারি না। জীবনের প্রতিটি স্টেপে একটা কথা আছে, খুব সম্ভবত স্বামী বিবেকানন্দ বলেছিলেন, যতদিন বাঁচি ততদিন শিখি। এই কথাটা বোধহয় ডায়াবেটিস সম্পর্কে যতটা অ্যাপ্লিকেবল, খুব কম ডিসিপ্লিন সম্পর্কে এতটা অ্যাপ্লিকেবল। কারণ আমার মনে আছে আমরা যখন মেডিকেল কলেজে পড়তাম তখন ডায়াবেটিস চিকিৎসার জন্য 3টি মাত্র ওষুধ পাওয়া যেত। আমি আজ থেকে প্রায় 40 বছর আগের কথা বলছি। কিছু সালফনিউরিয়া, মেটফরমিন এবং ইনসুলিন। 2000 সালের শেষ দিক থেকে, তারপর থেকে একের পর এক গত 20 বছরে যেই পরিমাণ ওষুধ এসছে, ডায়াবেটিস চিকিৎসার পুরো খোলনলচে পাল্টে গেছে। কিন্তু সেই জিনিসগুলো সম্পর্কে আমাদের প্রত্যেকের সজাগ থাকা দরকার। আমরা এক একজন এক একটা ক্যাপাসিটিতে কাজ করি। কেউ সুপার স্পেশালিস্ট হিসেবে বড় হাসপাতালে আছি, কেউ প্রাইমারি কেয়ার ফিজিশিয়ান হিসেবে আছি, কিন্তু এই নলেজটা প্রত্যেকের ক্ষেত্রেই দরকার এবং সেই নলেজ আপডেশনের জন্য আজকের এই কনফারেন্সটা। আপনারা যারা এই সেশনগুলো দেখেছেন, আমরা আশা করব আপনারা প্রত্যেকেই থাকবেন এবং এই প্রত্যেকটা সেশনে দিনের শেষে একটা কিছু টেক হোম মেসেজ নিয়ে আপনারা বাড়িতে যেতে পারবেন। আমরা এটাও ব্যবস্থা করছি, ইন্দ্রজিতের সাথে আমার এটা নিয়ে কথাও হয়েছে, যে এই পুরো প্রোগ্রামটাকে আমরা ভিডিও রেকর্ড করার চেষ্টা করছি এবং এই ভিডিও রেকর্ডটা আমাদের ওয়েবসাইটে বা আমাদের সোশ্যাল মিডিয়াতে আমরা যদি এটাকে সার্কুলেট করতে পারি, যারা আজকে আসতে পারেননি বা আসতে কোনো ইচ্ছা থাকা সত্ত্বেও আসতে পারেননি বা যারা জানেন না, তাদের ক্ষেত্রেও এই মিটিংগুলো একটা এডুকেশনাল সেশন হয়ে থাকবে। আমরা 2খানি বই বের করেছি, আপনারা জানেন বইটা অনেকে আপনাদের যারা ফ্যাকাল্টিতে তাদের দেওয়া হয়েছে, বইটা ইজ অ্যাভেলেবল। এটাও কিন্তু অনেক কষ্ট করে লেখা, খুব শর্ট নোটিসে লেখা, ছোটোখাটো কিছু ভুলভ্রান্তি থাকতে পারে, তার জন্য আমি আগে থেকে ক্ষমা চেয়ে রাখছি আপনাদের কাছে। কিন্তু আমাদের উদ্দেশ্য হচ্ছে সোজা কথা এই নলেজটাকে পার্কুলেট করা, সকলের মধ্যে ছড়িয়ে দেওয়া। কারণ ডায়াবেটিস পেশেন্ট আমাদের সবাইকেই দেখতে হয়। সেক্ষেত্রে এই পার্কুলেশনটা যদি ঠিকভাবে হয়, বেসিক নলেজগুলো যদি ঠিকভাবে ছড়িয়ে পড়ে, তাহলে কিন্তু ডায়াবেটিস চিকিৎসাটা অনেক সহজ হয়ে যাবে। যেই জিনিসটা অত্যন্ত সাফল্যের সঙ্গে প্রফেসর আজাদ খান এবং তার টিম বাংলাদেশ ডায়াবেটিস সমিতি যেটা করতে পেরেছে, যে ওরা যেটা করতে পেরেছে সেটা প্রায় স্বপ্নের মতো। আমি বারডেমের বেশ কয়েকটা জায়গায় আমি গেছি, কয়েকটা সেন্টার আমি ভিজিট করেছি, এবং ওরা যেভাবে জিনিসটাকে করে, প্রতিটি ডিস্ট্রিক্টে দে হ্যাভ গট দেয়ার সেন্টার। ওরা খুব রিসেন্টলি স্যার আমার সাথে শেয়ার করছিলেন, ওরা যেটা শুরু করেছেন, দে হ্যাভ স্টার্টেড ডুইং মেডিসিন। মানে ওই এক একটি সেন্টারে পেশেন্ট আসবে, দের ইজ এ ডক্টর দেয়ার, যে মানে থ্রু ইলেকট্রনিক কানেকশন, সে ধরুন জুম বা কোনো সোশ্যাল মিডিয়া প্ল্যাটফর্মের থ্রু দিয়ে উইল কন্ট্যাক্ট উইথ আ স্পেশালিস্ট অ্যাট দ্য সেন্টার ইন ঢাকা। এবং সেখান থেকে তাদের এই যে ছোটোখাটো প্রবলেমগুলো হচ্ছে, মানে বাংলাদেশ তো আপনারা জানেন আমাদের পশ্চিমবঙ্গের চেয়েও 3 গুণ বড় এলাকা, সুতরাং সব পেশেন্টের পক্ষে সবার পক্ষে ঢাকাতে বা চট্টগ্রামে এসে পেশেন্ট দেখানো সম্ভব হয় না। কিন্তু এই গ্রামের লোকেরাও তারা কিন্তু এই সুযোগটা নিয়ে ভালো ট্রিটমেন্টটা পেতে পারছে। এটা একটা বড় জিনিস, এবং আমাদের এটা একটা আইডল, মানে আইডল বলতে পারেন এই সেন্সে যে এই প্রজেক্টটা আমাদের কাছে একটা আইডল প্রজেক্ট। আমরা চেষ্টা করছি এইটাকে আমাদের সীমিত সংখ্যায় যতটুকু পারা যায় ছড়িয়ে দেওয়ার। এইটুকু বলে আমার বক্তব্য শেষ করলাম। ধন্যবাদ।
থ্যাংক ইউ ডাক্তার মজুমদার। আমি রিকোয়েস্ট করব ডাক্তার মেরিডি ক্রুজ, আমাদের ভাইস প্রেসিডেন্ট এবং ওয়ান অফ দ্য অর্গানাইজিং সেক্রেটারি অফ ডেকন 2023 কিছু বলার জন্য।
Good afternoon and welcome to National Professor Dr. Azad Khan for being our chief guest. I'd just like to say that we saw such an incredible work being done in Bangladesh. We as a country are much bigger, but I don't think that we have been able to do even half of what they are doing. They have reached out to every diabetic in the country, creating awareness, giving them medicines, and there is a protocol for everything. And Dr. Azad Khan is the brainchild behind that. We are trying to incorporate some of those methods here also, at least in West Bengal, so that we can take the similar kind of care to our patients also. Another thing I'm very happy about is to see so many professors and speakers from the Department of Community Medicine. And when we studied, it was preventive and social medicine, and I think that is the department that needs to take all the awareness to the community. With these words, I'll say thank you.
থ্যাংক ইউ দিদি। আমি রিকোয়েস্ট করছি ডক্টর রাকেশ কুমার, আমাদের অ্যাসিস্ট্যান্ট সেক্রেটারি এবং জয়েন্ট অর্গানাইজিং সেক্রেটারি অফ ডেকন, টু সে সামথিং।
Thank you all for being here on this auspicious day. Thank you, Chief Guest sir. To be very frank, আমি কিন্তু এনজিও পারসন নয়। আমি চোখের সামনে দেখেছি অনেক এনজিও হলো, প্রেসিডেন্ট ভাইস প্রেসিডেন্ট টাকা কালেক্ট করলো, ফরেন ট্রিপ করলো, এনজিও চলে গেল। এনজিও 16 বছর ধরে আছে, 17 বছর ধরে কাজ করছি। দাদার সাথে আমি 2014-এ আমার দেখা, বলো লাইফ মেম্বারশিপ নিয়ে নাও রাকেশ, বললাম ঠিক আছে, দিয়ে দিলাম দাদাকে। তো জাস্ট টু রেসপেক্ট হিজ ওয়ার্ডস 5,000 টাকা দিয়ে নিয়ে নিলাম লাইফ মেম্বারশিপ। তারপর এক দুটো ইভেন্ট এমন দেখলাম কি লোকজন অনেক কাজ করে, কেউ খাবার দেয়, কেউ চাদর দেয়, কেউ কাপড় দেয়। এই অর্গানাইজেশন এমন, সে জ্ঞান দিচ্ছে। ডে ইজ প্র্যাকটিক্যালি এম্পাওয়ারিং পেশেন্টস। এক দুটা এমন ইনসিডেন্ট আছে, মানে টাইপ 1 ডায়াবেটিসকে আমরা যারা আন্ডার প্রিভিলেজড ফ্রিতে ইনসুলিন দেব। ফার্মা ফ্রেন্ডস ডোন্ট টেক ইট আদারওয়াইজ। কিছু ফার্মা কোম্পানি কমিটেড টু গিভ আস ইনসুলিন ফ্রি স্যাম্পলস। After all, they are pharma companies. After a certain period of time, they stopped giving us free sample. Believe me, we purchased it from market and delivered it to our needy patients, but we never denied them any their rights. One of the concept was to make type 1 diabetes patient independent, financially independent. We supported type 1 diabetes patient till they become adult and independent. She got married. She got educated as certified, she got certified as a diabetes educator. Now she's employed at one of my diabetes clinic, and she's working as a fantastic diabetes educator. This type of financial model, this type of educational model is not seen anywhere in India. Not seen anywhere in India. One project, we all go, আমরা এখানে বসে আছি অনেক লোক, মনে হয় 70-80% লোক সুন্দরবন গেছে ঘুরতে জন্য। খুব সুন্দর ল্যান্ডস্কেপ, এই বোটের মধ্যে খাওয়া দাওয়া ফুর্তি করা। লাইফ এখনো ওখানে নেচার উপরে ডিপেন্ডেন্ট। আমি আমার এক্সপিরিয়েন্স বলি, 20 মিনিট দেরি করে পৌঁছেছি, লো টাইড হয়ে গেছে, খেয়েও চলছে না, 2.5 ঘন্টা বসেছি। হোটেলে পৌঁছেছি, দেরি হয়ে গেছে, 5 জনে খাবার ছিল, 10 পিস 500, 2 পিস এক্সট্রা চেয়েছি, নাই। কেন অতটাই ওরা রান্না করেছে, আনতে জন্য আবার যেতে হবে 2 ঘন্টা দেরি করে বালি আইল্যান্ড থেকে পড়িয়ে আবার এই গদখালি থেকে আনবে। যারা এসেন্সিয়ালস জন্য এত ডেপ্রাইভড, ইম্যাজিন অ্যান্ড থিঙ্ক অ্যাবাউট দ্য হেলথ সার্ভিসেস। ওখানে আমরা কিন্তু রিচ করছি। Not only giving medicines, মেডিসিন আমরা কত দিতে পারবো, 4টা 5টা 1000 2000 লোকে দিতে পারবো, কিন্তু বেশি মেডিসিন যদি দরকার না হয়, তার জন্য যেটা ইম্পর্টেন্ট জিনিস যেটা আমরা বলি, এভরিথিং অফ ডায়াবেটিস ইজ প্রিভেন্টেবল। ডায়াবেটিস ইটসেলফ ইজ প্রিভেন্টেবল, provided we take the necessary precaution at right time. Even if we have diabetes, each and every complications can be delayed. So we are basically feeding them with knowledge, enough knowledge to delay their complications, reduce the pill burden, reduce the cost, improve the quality of life. আমি কিন্তু আপনাদের সবাইকে রিকোয়েস্ট করব কি join us in educating others. We don't want any money from you. It depends on your personal choice. But join us in empowering others, in spreading knowledge. Knowledge is free of cost, provided you want to share it. Thank you all. I welcome you all again on the behalf of Day family.
Thank you, Dr. Rakesh. Request করব স্যারকে, স্যার আজাদ স্যার কে কিছু বলার জন্য। স্যার
সবাইকে আমার সশ্রদ্ধ সালাম ও নমস্কার। এখানে উপস্থিত আছেন অপূর্বদা, যে দেশ সভাপতি ইন্দ্রজিৎ, এবং আপনার সবাই। আমি আগেই দুটো কথা বলে দিতে চাই যে আমি খুব ভালো বক্তা নই, তো যদিও বক্তৃতা দেওয়া আমার কখনো নেশাও বা পেশাও ছিল না কখনো। এমনকি আমি যখন ছাত্র পড়িয়েছি তখনও আমি চেষ্টা করেছি যে ছাত্ররা নিজেরা পড়ে, আমার কাজ গাইড করা, ঠিক পড়ানো ওভাবে করিনি আমি। সত্যি কথা বলতে গেলে মেডিকেল ছাত্রদের এই সাবকন্টিনেন্টে আন্ডার গ্রাজুয়েট বলা হয়, বস্তুতপক্ষে তারা আন্ডার গ্রাজুয়েট না, কিন্তু দে আর গ্র্যাজুয়েট স্টাডিজ। পৃথিবীতে অনেক জায়গা আছে সেখানে কিন্তু ক্লিনিক্যাল ডাক্তারি পড়তে গেলে আগে গ্র্যাজুয়েট হতে হয়, না হলে ক্লিনিক্যাল ডাক্তারি ওঠাই যায় না। অক্সফোর্ডে তাই, ক্যামব্রিজেও তাই। তো যাই হোক, যে কথাটা আমি বলতে চাচ্ছি সেটা হলো যে আমি নিজেকে অত্যন্ত ভাগ্যবান মনে করি যে আপনারা সবাই আপন মনে করেন সেজন্য। তবে এই কথাটা বলবো যে আমি আপনাদের মধ্যে কখনোই অতিথি নই, প্রধান অতিথি হওয়া তো দূরের কথা, কারণ এখানে আসলে আমি মনে হয় না কোনো অন্য দেশে এসেছি, তা কিন্তু মনে হয় না। এই দেশটা যে ভাগ হয়ে গেল তার জন্য এখানে যারা সামনে আসে তারা তো তাদের সামনে হয় নাই, আমার সামনে হয়েছে। কিন্তু একটা নিশ্চিত করে বলতে পারি আমি যে ভাগের জন্য আমি দায়ী না, অপূর্বদাও দায়ী না, তাই না? কিন্তু আমরা কিন্তু ভাগ হয়ে গেলেও মন থেকে তো একই আছে। সেজন্য অনেক কিছু প্রোগ্রাম আমরা একত্রে নিতে পারি। একত্রে নিয়ে ভাগ হওয়াতে পলিটিক্যাল ইস্যু, সেটা তো, কিন্তু একত্রে নিয়ে আমরা মানুষের কল্যাণ করতে পারি। আমি যেমন একটা উদাহরণ দেখে বলি, এবং আমরা পারি এটা বলছি, যে আপনারা দেখেন এই যে 14ই নভেম্বর ওয়ার্ল্ড ডায়াবেটিস ডে হবে। এই ওয়ার্ল্ড ডায়াবেটিস ডে যে শুরু হলো অফিসিয়ালি, মানে শুরু হয়েছে আমাকে দিয়ে না, কিন্তু অফিসিয়ালি শুরু হয়েছে আমার চিঠি দিয়ে। এই ক্ষুদ্র বান্দার চিঠি দিয়ে কিন্তু শুরু হয়েছে এটা। কারণ তখন ওয়ার্ল্ডের যত মেজর পাওয়ার তারা কেউ এটা করতে রাজি ছিল না। তাদের মধ্যে ধারণা ছিল যে যদি এরকম একটা ইউএন ডে হয় তাহলে ওদের বাজেটকে এফেক্ট করবে, এটা ধারণা ছিল। তো আমি বাংলাদেশ সরকারকে কনভিন্স করতে পারছি যে এটা করলে ভালো হবে, যে অ্যাওয়ারনেস বাড়বে, তো এটা প্রিভেন্টেবল, সুতরাং প্রিভেনশন অ্যাওয়ারনেস বেড়ে যাবে। সবাই পরে কিন্তু অ্যাপ্রিসিয়েট করেছে, এবং ইট ওয়াজ পাস্ট ইউনানিমাসলি। 2006-তে যখন পাস হয়েছে, ইউনানিমাসলি পাস হয়েছে এই ডিসেম্বরে ইউনাইটেড নেশনস জেনারেল অ্যাসেম্বলিতে। এখানে আমি আরেকটি কথা বলতে চাচ্ছি, সেটা হলো যে আমরা তো সবাই এখানে যারা আছি ডাক্তার বা এই পেশার সাথে যুক্ত। তো ডাক্তারি পেশাটা কিন্তু ইসের মতো ডিজাইন না, ব্যবসায়ী অ্যাঙ্গেলের ডিজাইন না। আপনারা দেখবেন সাধারণ বলে যে সে ওকালতি ব্যবসা শুরু করেছে, বলা হয় না? কিন্তু কখনো বলা হয় না ডাক্তারি ব্যবসা শুরু হয়েছে, এই কথা বলা হয় না। কিন্তু কারণ ডাক্তারিটা ব্যবসার সাথে ভাবে ডিজাইন করা না। এবার এটা যদি ব্যবসার সাথে ডিজাইন হবে তখন এটার চার্মই থাকবে না। সুতরাং আমাদের চেষ্টা করতে হবে যে এটা ব্যবসার মতো করে না নেওয়া সেটা। এবং আমি ইন্দ্রজিৎকে ছোট ভাই মনে করি, তো তারা এটা ব্যবসায়ী হিসেবে নেয় সেটা আনন্দদায়ক বিষয়। আরেকটি কথা বলবো যে বর্তমানে যে হেলথ কেয়ার টেকনোলজি যেভাবে যাচ্ছে, তাতে কিন্তু হেলথ কেয়ার অন্তত 95% ডিজিটাল হয়ে যাবে। বস্তুতপক্ষে যে আমরা যে অনেক টার্সিয়ারি কেয়ার হেলথ সেন্টার করছি সে রিডান্ডেন্ট হয়ে যাবে, বুঝলেন না? আমি কলকাতার কথা জানি না, বোধহয় একই রকমই হবে। ঢাকাতে যত প্রাইভেট বড় বড় হসপিটাল আছে, ওখানে যে রুগী ভর্তি করে ওর অন্তত 80% রুগীর ভর্তির প্রয়োজন নাই। ওখানে রুগীদের ভর্তি করা হয় ব্যবসায়ীর কারণে, যে ডাক্তার সাহেবের দরকার ভর্তি করা, বেশি দরকার যারা ওইটাতে ইনভেস্ট করছে ওদের দরকার। তো সেজন্য এখন কিন্তু কম্প্রিহেন্সিভ ডিজিটাল কেয়ার আমরা একত্র হয়ে করতে পারি। আমি এটা বলতেছি স্বার্থপরতার থেকেও বলতেছি, আমাদের দেশে মানে বাংলাদেশে কিন্তু এখানকার ডাক্তারদের প্রতি অনেক শ্রদ্ধা আছে। তার একটা কারণ হলো বাংলাদেশের ডাক্তাররা হার্ড প্রেসড মানে যত রুগী আছে ওই তুলনায় স্পেশালিস্ট অনেক কম, তো ওরা সময় দিতে পারে না বা আর্টও শেখে নেয়। তার ফলে ওই আমাদের দেশে রুগীরা আসে বলে ঢাকা যায় বলে যে ওখানে গেলে ডাক্তার সাহেব অনেক সময় দিয়েছে, আর বাংলাদেশে তো সময় কথাই শোনে না, কথা তো সত্যি। কিন্তু তো সেজন্য আমি একটা অ্যাপিল রাখতেছি যে আমরা কম্প্রিহেন্সিভ ডিজিটাল হেলথ কেয়ার করছি, তাতে যদি আপনারা ফ্যাকাল্টি হিসেবে থাকেন তাহলে আমাদের উপকার তো হবেই, এখানকার লোকের উপকার হবে মনে করি। এই কম্প্রিহেন্সিভ ডিজিটাল কেয়ার সম্বন্ধে আমি একটু বলতে চাই 1-2 মিনিট। সেটা হলো নিশ্চয়ই পশ্চিমবঙ্গের ইস্যুটা সত্যি যে ডিস্ট্যান্ট প্লেসে, রিমোট প্লেসে ডাক্তার নেওয়াটা কঠিন। ডাক্তার নেওয়াটা কঠিন, ডাক্তারদের দোষ নয়, কিন্তু এটা ডাক্তার যে ওখানে যাবে থাকবে, তো আমাদের তো সোসাইটি এরকম হয় না যে সবখানে এডুকেশন এরকম আসে, তো এখন ডাক্তার গেল, ইয়ং ডাক্তার গেল, সে যদি ওখানেই থাকে তার ছেলেপেলে মানুষ করবে কী করে, তাই না? সেজন্য কেউ যেতে চায় না। কিন্তু এখন ফ্যাক্ট হচ্ছে যাওয়ার প্রয়োজন নেই, ডাক্তারের অ্যাডভাইসটা নিয়ে যাওয়া যায়, এবং হ্যান্ডেল ডিভাইস যেগুলো তৈরি হয়ে গেছে তার ফলে ডাক্তার যে রুগীকে স্পর্শ করে নেয় সেটা মোর দ্যান ওভারকাম করে ফেলতে পারে। যাই হোক, আমি মনে করি যে এরকম অনেকগুলো ইস্যু আছে যেগুলোতে আমরা কম্বাইন করে ফেলতে পারি, করলে পরে সবার উপকার হয়ে যাবে। আর এক্সাম্পল তো একটা থাকেই, এই যেটা বললাম আমরা যে ইউএন ডে ফর ডায়াবেটিস হয়েছে, এমনকি আমাদের দেশে আমরা যখন এই ডায়াবেটিস ডে করতাম, প্রথমত আইডিএফ করতো, যে তার আগের থেকে করতাম আমরা, আর আগের থেকে বাংলাদেশ ডায়াবেটিস সমিতি করত, কিন্তু তখন করতে বেগ পাইতে হতো, সরকার থেকে তো ওইটা ঠিক মানে ইনভলভ করা কঠিন ছিল। তো এখন তার সরকারের ডিউটি হয়ে গেছে, বিকজ ইউএন ডে ওয়াজ প্রপোজ বাই বাংলাদেশ গভর্নমেন্ট, সেই জন্য হয়ে গেছে। সুতরাং পার্সু করলে কিন্তু করা যায়। যেমন আরেকটা কথা বলছি যে টাইপ 1 ডায়াবেটিস বা ইনসুলিন নিডিং ডায়াবেটিস বলছে, তো টাইপ 1রা তো ইনসুলিন তাদের জন্য বাঁচার জন্য অপরিহার্য, তো বাঁচার জন্য অপরিহার্য হলে তো এটা হিউম্যান রাইট ইস্যু। তো এটা বাংলাদেশ তো আর পশ্চিমবঙ্গ বোধহয় ইকোনমিক্যালি একই রকম, বেশি তফাৎ না। তো আমরা তো যাই বলি এটা ধনী তো না আমরা, কিন্তু সেখানে কিন্তু আমরা এটা সম্ভব হয়েছে যে বাংলাদেশ গভর্নমেন্ট পাবলিকলি অ্যানাউন্স করেছে যে সব ডায়াবেটিক ইনসুলিন নিডিং ডায়াবেটিককে ইনসুলিনটা ফ্রি দেবে এবং দিতে শুরু করেছে। সেটা এখানে অ্যাচিভ করাটা কিন্তু সোজাই আছে, পারা উচিত অ্যাচিভ করাটা। তারপরে যে প্রিভেনশন, এখানে প্রিভেনশন মধ্যে একটা কথা বলছি আমি, দুইটা কথা বলি। আপনারা যতই আমরা বলি না কেন, ডায়াবেটিস সম্পূর্ণ প্রিভেন্ট করা সম্ভব হবে না, হওয়ার কথা না। কারণ দেখবেন যে ডায়াবেটিসে একটা জেনেটিক কম্পোনেন্ট আছে, তো জিনটা তো ডিফেক্টিভ জিন, তাই না? আমি কিন্তু ফিলোসফিক্যাল কথা বলছি। তো ডিফেক্টিভ জিন তো এলিমিনেট আউট হয়ে যাওয়ার কথা। তো ডায়াবেটিক যদি পলিজেনেটিক, তো তাও এই হয়ে যাবে না, আপনি এলিমিনেট আউট হবে না, কারণ ডায়াবেটিক জিনে সার্ভাইভাল অ্যাডভান্টেজ থাকতে পারে। যেমন আমরা যখন হান্টার গ্যাদারার ছিলাম, তখন তো কতক্ষণ আমি হান্টিং করতে পারতাম, দ্যাট হ্যাজ ইমপ্লিকেশন অন সার্ভাইভাল। যদি মাইনর ডোজে ডায়াবেটিক জিন থাকে, মেবি দ্যাট ইউ ক্যান ডু লং টাইম হান্টিং, কারণ সুগার ফল করতে চায় না তো, বুঝলেন না? সুতরাং এটা একটা থিওরিটিক্যাল বলছি। তো জিনটা সমস্ত এলিমেন্ট আউট হবে না, সব চেষ্টা সত্ত্বেও কিছু লোকের ডায়াবেটিস হবেই, কিন্তু আমরা জানি যে হলেও যদি সম্পূর্ণ কন্ট্রোল রাখলে সে সুস্থ থাকতে পারে, যদিও ব্যয়বহুল। তো সোসাইটি এটাকে কনসিডার করে টাইপ 1 বিশেষ করে, তাদের তো মানে যারা টাইপ 1 হলো ওরা তো নিজেরা রেসপন্সিবল না তার জন্য, তার প্যারেন্টও রেসপন্সিবল। তাহলে সোসাইটির রেসপন্সিবিলিটি তো তাদের সার্ভাইভাল ইস্যু যেহেতু করা, সেটা কনভিন্স করলে হবে। আমরা কম্বাইন তো করতেই পারি প্রিভেনশন। আমরা বাংলাদেশে একটা প্রিভেনশন প্রোগ্রাম করছি, এটা আমি এখন বলতে পারি, ইমামদের দিয়া, মানে রিলিজিয়াস লিডারদের দিয়ে, ইমামদের দিয়া, তারপরে পুরোহিতদের দিয়া, এবং বুদ্ধিস্ট মহাথেরোদের দিয়া, এবং খ্রিশ্চান ভিকারদের দিয়া করছি। যেহেতু বাংলাদেশের মুসলমান অনেক বেশি, ইমামদেরটা যে করেছি এবারে ইম্প্যাক্ট স্টাডি করেছি, এখনও আমরা অ্যানালিসিস কমপ্লিট করিনি, তো দেখা যায় বিগ এফেক্ট হয়ে যায় এবং খুব সস্তায় হয়ে যায়, বিগ এফেক্ট হয়ে। শুধু এরকম কম্বাইন্ড প্রোগ্রাম করতে পারি। যেমন যে অনেক দিন থেকে আমি ফলো করছি যে এদের যে আমাদের যে এডুকেশন প্রোগ্রাম আছে, যে এটা আমি মনে করি আমরা যেটা করি তার চাইতে অনেক বেটার, মোর কালচারালি রেসপন্সিভ, ভেরি বেটার। তো আমার মনে আমি একটু বেশি লম্বা বক্তৃতা দিয়েছি। আমি আবার বলছি যে আমি নিজেকে ভাগ্যবান মনে করি যে এত লোক আমাকে আপন মনে করে। আমি সত্যি বলছি এই কথাটা, যে দিনের শেষে আমি চিন্তা করি কি আমি কি এত ভালোবাসা পাওয়ার যোগ্য। যাই হোক, কিন্তু পেয়েছি, সেজন্য আমি ভাগ্যবান মনে করি। এবং আমি মনে করি লেট আস নট লুক ব্যাক টু দি পাস্ট, যার জন্য আমরা দায়ী না, কিন্তু এই সিচুয়েশনে আমরা কি করতে পারি, আমরা একত্র হইয়া বহু প্রোগ্রাম করতে পারি। ধন্যবাদ।
থ্যাংক ইউ স্যার। স্যার আমরা প্রদীপ জ্বালাবো এখন একটু। স্যার আপনাকে একটু ট্রাভেল নিতে হবে। স্যার প্রদীপ জ্বালাবো, আমরা একটু প্রদীপ জ্বালাবো। প্লিজ সবাই জয়েন করুন।
वक्रतुण्ड महाकाय सूर्यकोटि समप्रभ निर्विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा। नमो नमः श्रीसिद्धिविनायक नमो नमः अष्टविनायक नमो नमः गणपति बप्पा मोरया मंगलमूर्ति मोरया। ओम गणपतये नमो नमः श्रीसिद्धिविनायक नमो नमः अष्टविनायक नमो नमः गणपति बप्पा मोरया मंगलमूर्ति मोरया। ओम गणपति नमो नमः श्री सिद्धि विनायक नमो नमः अष्टविनायक नमो नमः गणपति बप्पा मोरया मंगलमूर्ति मोरया। ओम गणपति नमो नमः श्री सिद्धि विनायक नमो नमः अष्टविनायक नमो नमः गणपति बप्पा मोरया मंगलमूर्ति मोरया। सुखकर्ता दुःखहर्ता वार्ता विघ्नाची पूर्वी प्रेम कृपा जयाची सर्वांगी सुंदर उटिशेंदुराची कंठी जळके माळ मुक्ता फळांची। जय देव जय देव जय देव जय देव जय मंगलमूर्ती दर्शन मात्रे मान कामना पूर्ती। जय देव जय देव जय देव जय देव जय मंगलमूर्ती दर्शन मात्रे मान कामना पूर्ती। जय देव जय देव खचित फारा दुज गौरी कुमरा चंदनाची ओटी कुम।
ডাক্তার রাকেশ কুমার, প্লিজ আমরা সবাই ছবি তুলবো কিন্তু লাস্টে, সেজন্য প্লিজ সবাইকে দাঁড়িয়ে থাকতে অনুরোধ করছি একটু। ডাক্তার শুভজ্যোতি ঘোষ, ডাক্তার সোমনাথ নস্কর, এটা প্রত্যেকে কন্ট্রিবিউট করেছেন চ্যাপ্টার। ডাক্তার ষষ্ঠী নারায়ণ চক্রবর্তী। প্লিজ আপনারা প্রত্যেকেই মঞ্চে থাকবেন, আমরা একটা গ্রুপ ছবি তুলব। মিস্টার সৌমেন্দু ঘোষ, বিজয়া ভট্টাচার্য, ডক্টর শ্যামশ্রী চৌধুরী, অর্পিতা দেব ঘোষ, মালবিকা দত্ত, গার্গী দাস, ডক্টর অনুরাধা মুখার্জি, মিস্টার অর্ণব চ্যাটার্জি, সুদেশনা মৈত্র নাগ, বিজয়া দাস, অপর্ণা সোমানি, এবং আমাদের ডিআইসি সময় যারা ফ্যাকাল্টি কলকাতা থেকে ছিলেন তাদের মধ্যে ডাক্তার রমা দাস, মিস্টার অরিত্য খান এবং মিস কোয়েল পাল চৌধুরী। আমরা একটা গ্রুপ ছবি নেব। আমাদের ফটোগ্রাফার আমাদের একটু যদি গাইড করে কিভাবে দাঁড়ালে সবাই আসবে। আমার হাতে বই দিয়ে একটা, আমি তো বই দিলাম না। এই ছবি তুলতে হবে, ছবি 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 ছবি। ফটোগ্রাফার কোথায় গেল? ফটোগ্রাফার আমরা একটা প্লেজ রেখেছি ওয়ার্ল্ড ডায়াবেটিস ডে উপলক্ষে। আমি আজাদ খান স্যার সই করছেন এখন, তারপরে সবাই সই করব। আমি রিকোয়েস্ট করব প্রত্যেক ডেলিগেটকেই এটা সই করতে। আমরা এরপরই লাঞ্চের পরে এটা বাইরে রাখা থাকবে। প্রত্যেককে প্লিজ রিকোয়েস্ট করব এই প্লেজে সাইন করার জন্য। আমাদের লাঞ্চ রেডি, আপনারা লাঞ্চে যেতে পারেন। শুরু করব। গুড আফটারনুন, আমরা পোস্ট লাঞ্চ সেশন শুরু করব। Now we have the googly segment. So I would like to request, please show that CV. Like to invite our two chairperson of this session, Professor Dr. Apurvakar Mukherjee, President Day, and we have another chairperson this session, Dr. Rakesh Kumar, our Assistant Secretary of Day. So we are starting our post-launch session, the googly segment. Hey, microphone কোথায়? উপরে দিতে হবে তো microphone.
Good afternoon, everybody. I, along with my co-chair, Dr. Rakesh Kumar, invite you all for this post-lunch googly session. And to start, none other than Professor Nilanjan Sengupta will take the podium. Let me introduce Dr. Nilanjan, Professor Nilanjan Sengupta to you all. He is a brilliant academician, a student with checkered career all through his life. He is now heading the endocrinology department of NRS Medical College, Kolkata. And he is going to talk on an exciting topic, gut-brain axis in diabetes. Professor Sengupta, please.
Thank you, sir. At the outset, I thank Day, Dr. Sujoy Majumdar and Dr. Mr. Indrajit for inviting me to this annual conference of Day. And as has been pointed out by the respected chairperson, I will be discussing about the gut-brain axis in diabetes this afternoon. This would be my agenda over the next 20 minutes or so. Now, this gut-brain axis is actually a bidirectional neurohormonal signaling pathway involving the gastrointestinal tract and the central nervous system, which plays an essential role in feeding appetite and satiety, glucose homeostasis, as well as gut motility. The gut-brain axis biology is deranged in many metabolic and gastrointestinal disorders like type 2 diabetes and obesity and other functional disorders of the gastrointestinal system, and this biology has been exploited for effective management of such diseases too. Now, what are the primary components of this gut-brain axis? We have the enteroendocrine cells, the enteric nervous system, that is the mesenteric plexus and myenteric plexus, the role of the gut microbiota, the vagus nerve carries the afferents and the efferents, the nodose ganglia, and the nucleus tractus solitarius. The enteroendocrine cells are specialized transepithelial cells present throughout the gastrointestinal tract but more distally. Despite constituting around 1% of the intestinal epithelial cells, they may be considered to constitute the largest endocrine organ of the body. They have a typical bottleneck shape with the apical membrane is in direct contact with the intestinal lumen, and the basolateral membrane is in close proximity to the blood vessels and the neurons of the enteric nervous system. They sense the luminal milieu, help in mechanotransduction, release gut peptides, and thereby influence metabolic homeostasis. Receptors are present both on the apical and the basolateral membranes. Glucose is sensed by sodium glucose transporter 1. Lipids are sensed by the fatty acid receptors GPR40 and GPR120. There's also the calcium sensing receptors, and they secrete a lot of peptides. To name some of the more important ones, L cells of ileum and colon secrete GLP-1, peptide YY, oxyntomodulin, and GLP-2. K cells of duodenum secrete gastric inhibitory peptide, now rechristened as glucose-dependent insulinotropic peptide. I cells of duodenum and jejunum secrete cholecystokinin. G cells of stomach secrete ghrelin. M cells of duodenum motilin. S cells of duodenum and jejunum secretin, and N cells of duodenum and jejunum neurotensin. These are some of the important anorexigenic and orexogenic peptides secreted from the gastrointestinal tract, of which a new one is nesfatin, which is secreted from the stomach, and insulin-like peptide 5 is another orexogenic peptide being elaborated from the colonic cells. Now the enteric nervous system. There are around 200 to 400 million neurons and the enteric glial cells in Meissner's and myenteric plexuses. Their main role is in mechanoreception, but these enteric neurons also express GLP-1 receptors. So when we manipulate the GLP physiology, actually that manipulation takes place also via this enteric nervous system. Vagal afferents innervate the enteric nervous system, and this system can relay local intestinal signal mechanisms to the central nervous system. The role of gut microbiomes is increasingly being understood in gut-brain signaling procedures. Metabolites produced by the microorganisms like bacterial lipopolysaccharides, bile acids modulate the cells in the intestine. They convey the long-term dietary status and epithelial integrity to the brain, and microbiota dysbiosis has been observed in certain disease conditions like obesity and diabetes. This is actually a blow-up of what I said. The gut microbiota are present in the lumen. They elaborate certain bacterial products like lipopolysaccharides and bile acids. Respective receptors and transporters are present on the enteroendocrine cells, and following this ligand interaction, there is signal transduction, and the signals being carried by the enteric nervous system through the vagus to the center. So if there are problems in the gut-brain axis in cardiometabolic diseases, attempts have been made to harness this gut-brain axis to treat metabolic disorders. And we have two distinct strategies which manipulate the gut-brain axis. Number one is the incretin-based therapies, because we know, broadly speaking, type 2 diabetes can be looked upon as a state of GLP-1 deficiency with GIP resistance, and also the bariatric procedures which involve the gut-brain axis. So this, we all know the physiological effects of incretins upon ingestion of food. GLP-1 is secreted from the L cells. This in turn actually stimulates glucose-dependent insulin secretion, suppresses hyperglucagonemia, delays gastric emptying, leads to a reduction in food intake, improves insulin sensitivity, and in long-term animal models, decrease beta cell apoptosis and improve beta cell neogenesis. Now, as I was alluding to, bariatric surgery also involves this axis. Now, as for example, following sleeve gastrectomy or a gastric bypass procedure, the initial salutary effects on weight loss that is seen is not only because of the mechanical reasons, but also because of neurohormonal reasons, because there is decrease in secretion of ghrelin from the stomach, which is an oroxygenic peptide. But over the few years, some percentage of patients actually tend to again put back weight after a bariatric procedure. And this loss of efficacy of bariatric procedure after a few years again can be explained by way of this incretin axis, whereby there is a rebound increase in ghrelin secretion. Various anti-obesity agents, many of them have failed though, like amphetamine, fen-phen combination, lorcaserin, sibutramine, rimonabant, in one way or the other try to manipulate the gut-brain axis. Now is the era actually of the incretin analogs. We have lixisenatide, exenatide, liraglutide, dulaglutide, and the latest kids on the block, semaglutide. Oral semaglutide is available for management of hyperglycemia of diabetes. Even injectable semaglutide is showing promise as an anti-obesity agent even in persons without diabetes. Now, what about the future directions? I've already alluded to oral semaglutide. We are awaiting the availability of injectable semaglutide in the Indian market. Tirzepatide, yet to be launched in India. It is a novel dual agonist of GLP-1 and GIP receptors. It has been approved for use of, approved for tackling hyperglycemia of type 2 diabetes, but in this very important study, tirzepatide effected a mean weight loss of around 21% with 15 milligram weekly dose given subcutaneously over a 72-week period. So it promises to be a very effective anti-obesity agent apart from controlling hyperglycemia. Oxyntomodulin has pharmacological activity against GLP-1 and glucagon receptors. Another triple agonist of GIP, GLP-1 and glucagon, that is retatrutide, promises to be a robust anti-obesity molecule, is largely in phase 2 studies. Other dual glucagon and GLP-1 agonists are being developed to treat both diabetes and obesity, and various other target receptors like the calcium sensing receptor, GPR40, TGR5, etc., being targeted, including SGLT1 and PEPT1, and all these theoretically can elicit secretion of GLP-1. So it's the manipulation of the GLP or the enteroinsular axis. Correction of gastrointestinal dysbiosis also has been attempted. In animal studies, fecal microbiota transplant has been successful. Of course, we haven't got that far with human beings, but use of probiotics like bifidobacterium and lactobacillus on a medium to long-term basis can at least have the theoretical potential of altering many metabolic abnormalities of diabetes and obesity. And various anti-diabetic pharmacotherapy, apart from their core mechanism of action, they have their beneficial effects on the metabolic milieu through a positive influence on gut dysbiosis. Among them, there have been umpteen studies with metformin, pioglitazone, and some of the DPP-4 inhibitors, as well as certain herbal agents, have been shown to alter the gut dysbiosis in metabolic diseases. To conclude, therefore, the gut-brain axis is a vast and complex system with widespread metabolic functions, very little of which we know today. The pathophysiology of type 2 diabetes has now gone beyond the traditional beta cell defect and insulin resistance, and we now understand the role of the ominous octet and even beyond, and role of this gut-brain axis. Targeting therapies, the therapies targeting the incretin system and the gut-brain axis have the potential for fulfilling many unmet needs in the management of type 2 diabetes and may open up new vistas of treatment for sustained management of body weight, that is the weight management strategies. Thus, the essentially pancreatic beta cell centric management of type 2 diabetes in near future will give way to various therapeutic potentialities targeting this gut-brain axis. Thank you for your patience. If you have any questions, I will be happy to take this at this point of time because I may have to leave a little bit early.
Thank you, Professor Sengupta, for your brilliant talk. I think this is a topic where many things are being unveiled and people are understanding the unique role of gut-brain axis and the modulation of the different hormonal varieties which are prevailing in the gut, and including analogues, particularly GLP-1, GIP, and even glucagon. As he has shown in one of his slides, the triple analogues are now being launched in US. Tirzepatide is already available and it is growing very rapidly because of the coexistent obesity in very many of type 2 diabetics in the Western world. Any questions or comments from any of the people here? So I request you to please ask any question or to put forward any comment over this topic, gut-brain axis and diabetes.
Thank you.
So if there is no question, yes, madam, please.
I think so.
Very good afternoon, sir. Thank you for the insightful session. So basically, I'm Professor Bijoya, and I'm also a consultant dietitian specializing in irritable bowel syndrome and diabetes. So what I want to know from this gut-brain axis that IBS, I have done a couple of review papers wherein I've seen that the people who are having irritable bowel syndrome are also having diabetic neuropathy. Is it some way related to the neurons or
yeah,
so?
Conceptually, this irritable bowel syndrome or bacterial overgrowth is multifactorial, and one of the added mechanisms is diabetic neuropathy that will add to this bacterial overgrowth and irritable bowel syndrome if that bacterial overgrowth is a part of it. But the gastrointestinal dysbiosis that I have alluded to, actually, since my brief was the cardiometabolic part, I didn't elaborate on the GI part. In many of the functional bowel disorders, the gut-brain axis has a role. That's the role of anxiety, chronic anxiety, depression. You have two types of IBS, IBS-C and IBS-D, or even the mixed type. There, of course, the local nervous system has an important role to play with the role of the central nervous system, as well as a now understood very important role of gastrointestinal dysbiosis. And the gastroenterologists and even we nutritionists, every one of us, the treating team, try to achieve as much as eubiosis is concerned, not only for metabolic health, but also for gastrointestinal health.
Thank you, sir.
Thank you.
Thank you, Professor Sengupta, for your brilliant talk.
Thank you, sir. We would like to hand over our token of gratitude to you, sir. Thank you for your time. Thank you, sir.
Now I would like to invite our speaker, Dr. Arindam Ray, for next talk, endocrinopathy causing diabetes. He is DM Endocrinology, FACE, and presently attached with the Sagargupta Medical College, Assistant Professor in the Department of General Medicine. Sir, over to you. Please come up.
Hello. Okay. So good afternoon, everybody here present, and thanks the day for giving me the opportunity to talk on this favorite topic, and thanks the chairperson sir for kind introduction. So my talk on this endocrinopathy causing diabetes, because we all see a lot of diabetic patients in our day-to-day OPD practice, but truly speaking, the type 2 diabetes, okay, I can understand that majority of the patients are type 2 diabetic, but definitely in between all these type 2 diabetic patients, there are certain patients, they actually have some other problem inside, maybe some other endocrinopathies inside, and that can actually impair the diabetes status of the patient. So many a times we see that patients are not actually get control with the usual form of treatment, either the very increasing dose of insulin or the OADs, but actually we actually fail. What is the reason behind, or why the patients are not responding to this glycemic control of the patient? So we have to do a good clinical eye of the patient, and we have to look for the different causes of diabetes apart from type 2 diabetes that can cause the dysglycemia. So taking one of a patient is a 45-year female who is diabetic for 4 years with poorly controlled diabetes with metformin 2 gram, DAPA-10, vildagliptin 100 with insulin requirements more than 100 units per day with the HbA1c of 10.5%. On repeated questioning and examination, what we find, the patient is actually didn't achieve the glycemic control, increased sweating of the patient, hyperhidrosis, hypertension. There is no menses since last 1 year almost, and the patient have the poor joint pains. So this is the clinical picture of the patient. We can see the lips and the facial structure that shows the acromegaloid and macroglossia is there. So this is the IGF-1, which is definitely high in this patient. That is 445 nanogram per ml, and we have done the post-glucose growth hormone for confirmation, and that shows there is increased somatropin levels. Again, the thyroid function is normal and cortisol is normal, and we can see the pituitary that shows a pituitary macroadenoma. So we have done the transphenoidal surgery, and the patient is symptomatically better after the surgery, and post-operative days the IGF-1 is normal, and the patient is well controlled with only 2 grams of metformin per day. So she was having acromegaly, which was there for 4 years, apart from diabetes, and the early detection of this acromegaly that reduced the morbidity at the same time the mortality. So definitely the endocrinopathy that is associated with diabetes are very important. Either they are precipitated or they are worsened by these endocrine disorders. So definitely there is a balance between this insulin and the counter-regulatory hormones of the insulin, like the glucagon, growth hormone, cortisol, and the epinephrine that actually makes the sense of the diabetes states of the patient. So if you're concerned about the different glandular disorders, the pituitary, the acromegaly, or either the growth hormone excess or the growth hormone deficiency, the Cushing syndrome, that is the cortisol excess, adrenal gland disorders like adrenal Cushing, pituitary, the pheochromocytoma, or the primary hyperaldosteronism. From thyroid point of view, hyperthyroidism shows some dysglycemia. At the same time, some neuroendocrine tumors like glucagonoma, somatostatinoma, VIPoma, though they are very rare, but that can have some diabetes in background. So if you can have the 2 in 1 slide, the diabetes as a consequence of endocrinopathy, and endocrinopathy that affects the glycemic control. So acromegaly, Cushing's, pheochromocytoma, neuroendocrine tumors, and primary hyperaldosteronism, these are the diabetes that can happen because of the endocrinopathy issues. Where the endocrinopathy which affects the glycemic control, and thyroid dysfunction, either the gross hypothyroid or hyperthyroid, that can have the hypoglycemic or hyperglycemia consecutively, and adrenal insufficiency can precipitate hypoglycemia, whereas the vitamin D deficiency is also related to insulin resistance and diabetes. So now there are also different autoimmune and genetic polyglandular syndromes. At the same time, those are associated with type 1 diabetes, but definitely the insulin resistance is associated with type 2 diabetes, also the polycystic ovarian disease, premature baldness and obesity, and there's a syndromes is associated with diabetes and other gland involvement like Turner syndrome, Klinefelter syndrome, and Down syndrome. So acromegaly, this is definitely, we can know about the prevalence. This is a growth hormone hypersecretion, and mostly this is a growth hormone secreting pituitary adenoma, whereas the overt diabetes we can see in almost 20 to 50% of the patients, and impaired glucose tolerance that is also in almost 15 to 45% of the patients. I'm not going in details of the clinical features of acromegaly, we all know, but definitely some issues like cardiovascular issues, that is the dilated cardiomyopathy causing cardiomegaly and cardiac failure. These are the salient features that can also, you can get a hint that the patient may have the acromegaly. And apart from that, the osteoarthritis and obstructive sleep apnea. So these are the symptoms that can the patient have, which do not have maybe the acromegaloid feature, obviously. So why there is diabetes in acromegaly? Because the insulin resistance by the excess growth hormone, and there is also increased hepatic gluconeogenesis, decreased muscle glucose uptake, and increased free fatty acid. So this leads to the hyperglycemia and the diabetes. So if you see about the diagnosis, definitely the IGF-1 is a prelim test that we have to do, but for confirmation we can do a post glucose tolerance growth hormone level, and definitely if the level is more than 0.4, we can diagnose the patient have acromegaly. The treatment is surgical resection. Again, the radiotherapy and medical management for non-resectable cases can be there, and octreotide is one of the alternative in medical management. Again, coming to the growth hormone deficiency. So growth hormone deficiency is another state where we can have the dysglycemia diabetes because loss of trophic effect of the growth hormone on the beta cell. At the same time, there is disproportionate body mass, so that can give the both of insulin resistance, and that will lead to, again, the diabetes status. On the top of that, if the patient is receiving growth hormone, that can lead to, at the same time, the hyperglycemia. Coming to the Cushing syndrome, because Cushing syndrome is another very important factor, and that is mostly hidden in our patient. So exogenous Cushing is more important than of the endogenous Cushing in our clinical practice, because endogenous Cushing is really, very rare disease. But again, the glucose tolerance is almost the same type of 30 to 60%, where the frank diabetes we can see almost in the 20 to 30% of the patients. So this is nothing but exogenous, endogenous, and endogenous can be of two types, that is ACTH dependent, there is a pituitary Cushing, or the ACTH independent, that can be because of the adrenal or the extraadrenal. Coming to the clinical features, I'm again not going in details of the clinical features, but definitely that is the discriminating features. These are very important. That is the easy bruisability, the facial plethora, proximal myopathy, and the abdominal cutaneous striae. So this is very important, and the pink, purple, white striae, that is very important. That has to be differentiated with the pregnancy striae. Coming to in children, the short stature is very important of this, the Cushing syndrome. So this is one of my patients who have the facial plethora, at the same time the hyperpigmentation in the knuckles that gives the clue of ACTH dependent Cushing in the patient with a background of poorly controlled type 2 diabetes. Coming to the glucocorticoid axis, I mean, again, not going in details of this, but definitely, again, the pancreatic beta cell, the depletion that goes to decreased beta cell secretion, increased gluconeogenesis, and decreased uptake that leads to the hyperglycemia. So we can go for some, the test for the confirmation, like we can go for the one night ONDST, that is overnight dexamethasone suppression test, or we can do a late night salivary cortisol, or the midnight cortisol, serum cortisol, or urine-free cortisol. And for ACTH dependent or independent, we can go directly for the ACTH assay, or by the series stimulation, or the inferior petrosal sinus sampling when there is a diagnostic dilemma. So this is in our patient who have macroadenoma detected. So we have resected it, and the patient actually got the result with a better control of diabetes with a very minimal dose of metformin. Coming to the exogenous Cushing, that is another very important issue, as I have showed that even with this 1 or 2 dose of glucocorticoid, the patient can have the poor control of diabetes that we used to see in any of the pregnant patients who were actually receiving the glucocorticoid for 1 or 2 days for the lung maturation of the baby. Otherwise, the patient can have a short-acting, long-acting glucocorticoid for the longer days, and that can have the impact on the diabetes status of the patient. Coming to the thyroid hormone, is a very complex thyroid hormone with the relation with the blood glucose, but thyroid hormone actually can increase the glucose absorption. So the prandial glucose increment is there in diabetes. At the same time, the hepatic gluconeogenesis and glycogenolysis that is increased. At the same time, there is increased beta cell function and increased peripheral tissue glucose utilization is there. So a result of which side the balance will be there, that will decide whether the patient have the hypoglycemia or the hyperglycemia. When the hyperthyroidism is concerned, definitely the hyperglycemia is a major concern because there is definitely increased glucose absorption in intestine. At the same time, the hepatic gluconeogenesis that is increased. At the same time, the beta cell apoptosis that leads to the hyperglycemia. Coming to the glucose intolerance, which is of various degree in about 50% of the patients, and thyrotoxicosis in some of the patients in literature can precipitate the diabetic ketoacidosis. Coming to primary hyperparathyroidism, which actually the patient can have the raised calcium, the history of fracture, renal stones, or the myopathy in the background of type 2 diabetes, and here increased intracellular calcium that limits the glucose uptake, inducing the insulin resistance. And the treatment here with the primary hyperparathyroidism, the resection of the parathyroidadenoma that can have the improvement in the glycemic control. Coming to primary aldosteronism, where again the decreased insulin secretion, at the same time there is the insulin sensitivity that is important. So when there is decreased insulin sensitivity with that of the decreased insulin secretion, that leads to the diabetes, where the resection of the primary pathology that improve the insulin secretion and improve the insulin sensitivity, so lead to better glycemic control. So here up to 50% of the patients can have the dysglycemia and defect in insulin release, particularly because of the hypokalemia. So that may be the issue with the insulin secretory defect in primary hyperaldosteronism. I'm not going in detail of the confirmatory test, but we can do the saline loading test of fludrocortisone suppression, oral salt loading for the diagnosis of this aldosteronism. Now coming to what are the patients that we have to screen for hyperaldosteronism, definitely the first thing is the resistant hypertension, young hypertension, particularly less than 20 years of age, and particularly who do not have the family history of hypertension, that is a secondary hypertension. We have a severe hypertension, at the same time hypertension with hypokalemia. We can do the plasma aldosterone concentration on plasma renin activity and the ratio of more than 20 that can give a clue for the diagnosis of primary aldosteronism. And the treatment is definitely the resection of the proven adenoma, again the aldosterone antagonist that can give the result of this, the treatment of the aldosteronism. Coming to pheochromocytoma, again catecholamine secreting tumors of the adrenal cortex, and they have actually the 1/4 of the genetic etiology. 10% rule is there for the bilateral, and diabetes we can see in almost 15% of the patients, where the impaired glucose tolerance in almost 35% of the patients. We can do the plasma metanephrine, normetanephrine, 24-hour urinary metanephrine, normetanephrine, CT abdomen or MRI and MIBG scan for details diagnosis of this pheochromocytoma. Surgical resection after the proper blood pressure and in the pulse rate control with the alpha followed by beta blocker is the treatment in pheochromocytoma. Coming to the glucagonoma, these are very rare. These are the alpha cell pancreatic tumor, which actually have the diabetes, stomatitis, and chronic diarrhea. Diabetes can be seen in 75% of the patients, and the patients also have the anemia, thrombosis, and neuropsychiatric problem that can give the clue the patient can have glucagonoma. And there's choice definitely surgery, but when it's metastasis, there's 50% metastasis happens at the liver. So this is the classical, the terminological, the sign of this glucagonoma, that is the necrolytic migratory erythema. Coming to the somatostatinoma, again this is a delta cell of the pancreas giving this tumor,
which actually the combination of diabetes, steatorrhea, and gallstone associated with the duodenal mass. But this actually, responds to very small dose of insulin. Hyperglycemia results from inhibitory action of the somatostatin on the insulin. Surgical resection is a primary treatment, but when it's metastasized, we can go for the other palliative form of treatment, including octreotide. Coming to the PCOD, definitely the insulin resistant, beta cell dysfunction is definitely a theory behind. 40% of the patients with PCOD have the impaired glucose tolerance, actually progress to diabetes in 10% of the patients. We have a lot of obese PCOD patients who are very easy to manage with this lifestyle modification, but lean PCOD patients, which almost happens in 50% of the PCOD, is very difficult, because of the lifestyle modification is very difficult to understand in this kind of patients. Yearly screening for dysglycemia is very important. Metformin we can suggest in PCOD when the patient actually develops impaired glucose tolerance. Again, the lifestyle therapy with the diet, exercise is the mainstay of management in PCOD with the diabetes. So to points that we have to remember, okay, at home from today, that all the type 1 diabetes patients should be screened for other associated endocrinopathies. The other autoimmune endocrinopathy should be screened for type 1 diabetes as per the perspective guideline. Regular screening of type 2 diabetes should also be considered in other diseases like polycystic ovary, the syndromes of insulin resistance. Patients on hormone replacement like growth hormone therapy, steroid for any cause should have the monitoring of the blood glucose levels. And diabetes is also associated with syndromes like Turner, Klinefelter, and Down. So we have to open our eyes, we have to check the dysmorphic features, the difficult in controlling the diabetes, high insulin or medication requirement when there is electrolyte imbalance, particularly the hypokalemia, disproportionate the complications, at the same time the presence of goiter or thyrotoxic features. So always look for an additional endocrine disorder in diabetes. So thank you for your patience hearing, and special thanks to my Department of Medicine at College of Medicine, Sagar Datta Hospital, Department of Endocrinology, NRS Medical College, Dr. Shomi Goswami, my teachers, Professor Nilanjan Sengupta sir is present here, and my patients. So happy Diwali in advance.
Talks. So now to speak on the recent updates on the heart failure in diabetes, I would like to invite Dr. Sunit Banerjee. Dr. Sunit Banerjee is currently associated with the Kolkata Heart Lung Center, and he has multiple publications, and he holds multiple posts previously also in the various organizations. So without wasting much time, I would like to hand over the mic to the Dr. Sunit Banerjee. Sir, please.
Thank you, Diabetes Awareness, and you, especially Dr. Sujay Mujumdar, Professor Mukherjee, Professor Kumar. So I have been asked to talk on this subject, heart failure in diabetes, where we stand in 2023. Now, when I am going to deliver this talk, definitely I will be less speaking on anti-diabetic therapy, because the stalwarts are present in front of me. They can treat better the diabetes than me. I will concentrate more on the heart failure. But in last 1 decade, several molecules has come to address this. Glucose lowering is safe for the heart, and second thing, there is accidental finding that some glucose lowering therapy may be beneficial to the heart. So my talk will be on 4 aspects. Why a diabetic patient gets heart failure. The second is how you diagnose heart failure. Is it a basic? No, it is actually a very crucial, important task for the clinician. Then what is the evidence in the real world scenario, a registry, small registry, which suggests the true incidence, prevalence, and the associations of diabetic heart failure population. Third, and fourth is the present recommendation. So my time is 25 minutes, 20 minutes. I think we'll be able to do it. Now, this is a slide which has been taken from European Society of Cardiology. I don't think we should remember it. We have to remember only one thing, that diabetes as a risk factor for cardiovascular disease is an important one. And the low CV risk is something which is rarely seen in clinical picture. Just somebody who has come with no risk factor, just a high HbA1c or fasting or PP blood sugar level, no hypertension, no dyslipidemia, no family history, no smoking, physically active, non-obesity. And I think it is a myth in 2023 in the practice what we see, that a very low cardiovascular risk of development in patient with diabetes. So there is nothing like that. Rather, we need to understand that why a patient with diabetes develops heart failure. Although this is a statement from European Society of Cardiology, but the statement is not right. Risk factor, non-cardiac or cardiac. These are not the risk factor. These are the associations rather. So a patient may have diabetes and coexisting ischemic heart disease, previous myocardial infarction, silent or diagnosed. Hypertension may or may not be controlled adequately. Valvular heart disease, be it rheumatic or degenerative. Arrhythmias, very important arrhythmias are atrial fibrillation, tachycardia, induced cardiomyopathy, and sometimes you get heart failure because you have a right ventricular pacemaker for a long time. Then non-cardiac risk factor. The more you age, we have the propensity of development of heart failure, coexisting chronic kidney disease, obesity, and the duration of diabetes is important, and alcohol and smoking. So these are other areas which are causes of heart failure in diabetics. One is the stress diabetes, that is Takotsubo cardiomyopathy. We have seen a patient who has gestational diabetes followed by a peripartum cardiomyopathy. So these are not very common in clinical practice. Now, why the heart behaves differently in patient with diabetes with heart failure? So this will be addressed by our keynote speaker, as I came to know. So I am not going to give my ignorance too much on these things. But the most important thing is, if you have a toxicity on the individual cell with glucose and lipids both, you actually get a non-functional mitochondrium, and that's the reason you get a heart failure. In general, a patient with a heart failure, the cardiomyocytes wanted more of a glucose utilization than free fatty acid utilization. But if the patient doesn't have a heart failure, normal heart, and you get a myocardial infarction or a stress, you actually utilize more free fatty acid utilization, and that is good actually to salvage the muscle. But here in patient with heart failure, you are already on the top of your free fatty acid utilization, so more glucotoxicity actually improves, lowers the mitochondrial tolerance to the damage. Now, this is a real evidence, world evidence from multiple countries, a registry which is called Discover Study, where United Kingdom has been excluded their study because they found they have a very low prevalence of heart failure, what the registries are showing. Similarly, in USSR, they have found they have a high prevalence of alcoholic cardiomyopathy, so they have excluded these two countries from the trial, and from other European and American and some Japanese country, Japan, they have taken this registry. So it's not a trial on diabetes and heart failure. They have just longitudinally observed these patients over a period of 4 years, what is happening. And what they have able to found that there are very unique association between heart failure and something. So absolute standardized differences, if more than 10%, is significant. So a diabetic patient who is male and older and have higher body mass index, prevalence of hypertension, coronary artery disease, prior stroke, atrial fibrillation, CKD, they are more going to have heart failure. Patients who are taking metformin have less heart failure. Other anti-diabetic medicines, no effect. Patients who are on diuretic ACE inhibitor or beta blocker therapy are having less heart failure. So what we understand from this thing? We understand from this thing, these observations, is that patient with diabetes, just the diabetes is not the sole thing. They come with multiple other baggages, dyslipidemia, hypertension, obesity. So all these things makes the things complex, and you need to understand each component and each individual patients when you diagnose heart failure. Now coming to the most important thing is how you diagnose heart failure. And the most important thing, what has been written in the first line, is the symptom and or signs of heart failure. That is important. Along with that, you need to have echocardiographic evidence and another blood test which is called N-terminal brain natriuretic PET type or NT-proBNP. So what is NT-proBNP? Is it something like assessing in CRP in patient with the infection? If you find the CRP is going up, the infection is up, and the CRP going down, the infection is down. Partly it is true, but not. Why it is so? Because NT-proBNP can be elevated in patient with a renal dysfunction, acute MI, or sepsis. NT-proBNP is less elevated in patient with obesity. So in obese patient, if you have slightest elevation of NT-proBNP, you need to be very careful that you are not missing a diagnosis of heart failure. And then this ejection fraction concept come. But if we think the heart is a student, final year MBBS, who is going to pass. So if you think that he is 60% marks and above, he is a good student, it's not like that. He can also be a bad person. He may be good in his study, but he may have girlfriend, he may have addiction, he may have other attractions. So that's exactly the concept of heart failure with preserved ejection fraction, where they have lot of obesity, kidney disease, obstructive sleep apnea, atrial fibrillation, chronic obstructive pulmonary disease. That means problem outside the heart. On the contrary, if you have a heart failure with a low ejection fraction, who is barely got a pass marks or failed with a marks less than 40%, you need to give them multiple tuition. And the fourth important teacher for this poor student is ACE inhibitor, ARB or ARNI, beta blocker, SGLT2 inhibitor, and MRA. And all this teacher cannot be given to a weak student simultaneously. You have to give them one by one. Before that, don't go by echo Doppler and NT-proBNP. Keep your eyes open. You can find in clinical practice who has come with this sort of edema with a history of past bypass surgery and consumption of calcium channel blocker, but this time this edema is not because of venous insufficiency or calcium channel blocker induced, but his NT-proBNP is high. And another patient who has a nocturnuria despite a successful prosthetic surgery has atrial tachycardia, and you can see the positive hepatojugular reflux, and it is not a great deal to find out, just you need to be very vigilant in observing these issues. This patient has a apex which is down and out on the almost anterior axillary line, and this is the heart size. And not all the patient will have heart failure with dilated heart. This is a normal size heart, mild pulmonary venous hypertension presented in the emergency with SOB, ventricular tachycardia. After cardioversion, we found that this patient has an inferior wall MI. So, lot of things you can do. Coming to the last few areas, anti-diabetic medicine in heart failure. So, this is a very important slide which says the utility of SGLT2 inhibitor, and those who have a high risk of diabetes, who have chronic kidney disease, chronic heart failure with preserved ejection fraction or reduced ejection fraction. In all the spectrum, these drugs, the SGLT2 or inhibitor of various categories, are beneficial. The most evidence comes from empagliflozin and dapagliflozin, and there is only one trial which has not been shown to be statistically significant trial, but this is a SGLT1 inhibitor, sotagliflozin, which actually is good for patient with worsening heart failure. That means patient who are on maximum treatment of anti-heart failure medication, but still they are developing recurrent worsening. And this is also the glucose lowering agent which has been tested in clinical practice. The green means SGLT2 inhibitor is important for all patients with diabetes and heart failure, and if you are not giving it, it means it's a blunder in 2023. Then GLP-1 receptor analog is been YOLO mark, that is class 2A indication. You must give it, and probably it will take class 1 in near future. Two anti-diabetics which are non-sulfonylurea has been tested CVOT benefit, and these are lina and sitagliptin. Metformin and insulin glargine anticoagulant can be used, and you are not supposed to use pioglitazone and saxagliptin. And this is exactly what I said. If you have a lower ejection fraction, you need to give this 4 medicine, and you remember that this is a poor performing chap who needs a good coaching. But the problem is with a person who has a high marks, the more high marks and less is the therapeutic option apart from diuretic. So what you give diuretic for fluid retention, although it is not having a survival benefit, but it is going to decrease hospitalization and quality of life improvement in patients who have a heart failure with marginally reduced ejection fraction. These medicines you can give depending upon the coexisting condition. A patient who has pure heart failure with preserved ejection fraction, like hypertrophic cardiomyopathy, amyloidosis, sarcoidosis, and many more of such, or heart failure along with chronic kidney disease, you need to address this medicine. Now, this we have already said that beta blocker SGLT2 inhibitor, ARNI and MRA to be given, but they have to be given sequentially because many people cannot tolerate. Last 2 molecules which will be discussed in this forum, I am not going to say in detail, is finderanol, which is actually useful in patient with diabetes who has proteinuria to prevent recurrent heart failure hospitalization, and semaglutide injectable has been tested and which has been shown to decrease heart failure with preserved ejection fraction hospitalization in patient with obesity. And here what has been shown that patient, despite losing the body weight, there is a significant decrease in NT-proBNP. So probably it will be more beneficial in clinical practice. So take home message, number one, patient with diabetes and pre-diabetes are increased risk of developing heart failure. Patient with diabetes have a reduced ejection fraction more often, you have to see in clinical practice. Coexisting DM and heart failure has a adverse clinical outcome. You need to follow the guideline directed medical therapy. Metformin is not out. It can be given up to the stage of creatinine clearance of more than 30. Lactic acidosis is a myth, and patient to be observed for heart failure with diabetes, whether they were developing two arrhythmia. One is atrial fibrillation, where the chances of cardioembolic stroke increases, and if you have a low ejection fraction and widening QRS, you need to give this medicine, which intentionally paces three chamber of the heart, that is atria, right ventricle and left ventricle to the coronary sinus, and that's the standing of heart failure in 2023 from cardiologist's perspective in a diabetic individual. Thank you.
Thank you, Dr. Banerjee, for your insightful talk. I would request you to please take your seat. We will take questions after the last final talk of this session. So for next talk, I would like to invite our respected Dr. Tirthankar Chaudhary, sir, who needs no introduction still. He is presently attached with the Apollo Gallagher's Hospital as a consultant endocrinologist. Sir, please.
Good afternoon, and I thank the organizers for inviting me to this program. And it's my pleasure that I thank especially Sujoy Majumdar, who I think may be here. And the presentation that I'm going to do is a presentation that was accepted for oral presentation in International Congress of Endocrinology, ICE 2021 in Buenos Aires in Argentina. And then successively, the extension of the study was accepted for presentation in IDF in Lisbon in 2022. I am using most of their slides that I presented then, so all of them has got that heading of ICE 2021. So the topic today is one of the concepts that we keep hearing in our practice is by many consultants is that sulfonylurea is something that is not that is the last, just cost is the issue, and then you can use it. But when you go to the practice, you will find almost every prescription has sulfonylurea. I mean, modern sulfonylurea is prescribed in that. So it is well understood now that there is no such thing as it squeezes beta cell. That's a dinosaur era concept about the older sulfonylurea. So I wanted to study the effectiveness and durability of extended release gliclazide in our practice. So this is, of course, doesn't need here. I work in this hospital, and this is the Apollo Hospital. And I start off with the concept of why modern sulfonylureas are different from the previous. If you look at the sulfonylurea receptor, this is not a straightforward, simple thing. It has got many subunits, including EPAC, and it is very near and associated to the K-ATP channels in the beta cell. Now, when the sulfonylureas bind to this receptor, they bind differently, and therefore the outcome is different. And that's why the modern one, like gliclazide, which bypasses EPAC, or for that matter, glimepiride, which attaches to sarcolemma K-ATP but does not affect the mitochondrial K-ATP, you find the difference and the benefit and less hypoglycemia. Now there are some, this is the one I was talking about, glimepiride. The modern SUs are different. And you know, the Carolina study, our concept has also changed, that is beyond gliclazide, even glimepiride is performing as good in our practice. And it is one of the most widely written. So I will start off with the myths that's with sulfonylurea. Hypoglycemia, weight gain, beta cell exhaustion, durability of glycemic control, and cardiovascular profile. My attempt would be to argue and bring evidence to the concept that these are an outlandish thought today. And that may be the reason why we are writing so much of modern sulfonylurea in our practice. I start with the guidelines because you will find that sulfonylurea is at the fag end written for cost. I believe this is an oversimplification of a molecule which is one of the most potent anti-hyperglycemic agent after insulin. So you are using a molecule which is most potent anti-hyperglycemic agent after insulin, and you put them just under cost is oversimplification. Now let me tell you a few words why I think so. Look at the efficacy of the molecule. If you look at the efficacy of the molecule, it is only next to insulin. You can, I don't know if you can see the chart very clearly. So if you look at sulfonylurea efficacy, it is only next to the insulin. So if the efficacy is in discussion, then that's the reason why I'm not trying to say that I'm violating standard of care. You will be using the anti-diabetic drugs as per standard of care. But what I'm trying to say, when the efficacy is in question, then it is sulfonylurea. Next is weight neutrality. A lot of talk has gone about weight with sulfonylurea. I think this is the newer generation. Look at the studies we have got. If you look at the UK PDS, weight gain during the first 3 years, and then they stabilized after 3 to 4 years in UK PDS. If you look at ACCORD, it is the intensive group that had the weight gain, not the comparator group that much. If you look at VADT, the same the patients were on ROSI and PIO, TZDs, and that group gained weight. Most important is the advanced study, which showed that, you know, the advanced study had almost 6,000 patients for so many years, so 8 years plus minus 6.5. And 90% of the advanced patients were on gliclazide. 40% were on insulin. And what did they study in 5 to 6 years' time? That there was no weight change. Therefore, the weight gain is not due to the molecule, it's the compensating overeating you do, or the lack of education that goes with a particular drug. Therefore, advanced study is one of the most important study to refer to about the weight gain. And if you look about the no significant weight difference again in this study, you can see that strict glycemic control can be maintained with SU plus MET in real life setting. So it's a real life evidence. Rudy Holman, he's, as you know, is a very, very important fellow in diabetes. No solid evidence of beta cell exhaustion. The other thing is, in many meetings I've heard people saying, it squeezes the pancreas, you've got nothing else to give. But I think it's an outlandish concept. The modern sulfonylureas does nothing, therefore durability is an issue. As long back as UK PDS, they says that this is a myth. So you would say, can we do, have we got a better evidence? So what they did is they put pancreatic cell line and exposed them with the different sulfonylurea. So you have got a pancreatic cell line, and then you put different sulfonylureas. And what did you find? If you look at apoptosis and reactive oxygen species due to different sulfonylureas, then you see the gliclazide is probably better or as good as comparator placebo. Therefore, this proves that this molecule does not cause an apoptosis or reactive oxygen species production. So beta cell exhaustion, advanced is a very good example when 90% patients were on gliclazide, and this study was on 11,000 patients over, and this study lasted for, as you know, that average duration of diabetes was over 8 years plus minus 6 years. And this study for the 5-6 years went on, and you can see here that at the end of the study, you had 40% of insulin, means 60% with 90% patients on gliclazide did not have a durability issue. So if you again look at the clinical evidence of mortality and CV mortality and all cause, then again you see gliclazide is performing better than others. So much so that now modern sulfonylurea gliclazide has entered Braunwald's textbook. They have looked at all the evidence and they conclude that gliclazide is CV neutral. So it does not have an effect of the heart. Now, if you cause somebody hypoglycemia and that leads to a problem, that's a different issue altogether. But that can happen with insulin. The gold standard of diabetes management is insulin. And who causes maximum hypoglycemia is insulin. That doesn't say that you should not use it. If you look at the, this is another meta-analysis of randomized clinical trial for cardiovascular study. You know the Danish had a very big cohort they looked into, and again they conclude the same thing, that the entire meta-analysis says that use of SU is not associated with any significant difference of MI with respect to comparator. So therefore we are now more or less sure, and we have dealt with the efficacy, we have weight and the cardiovascular safety. Now looking at these, I thought that we need to do in our cohort of patient a study. So modern sulfonylureas, including extended glycoside, I tried to study in my cohort of patients. Those are the patients that were continuously following with us. These are the patients who were continuously on glycoside. And the main object was to see durability. By the word durability, I mean from the point of diagnosis and starting of glycoside to the point of initiation of insulin. How long do they, are we squeezing the pancreas? Are we getting problem? And then secondarily, we looked at, of course, efficacy, we looked at weight change and hypoglycemia. So we had 300 patients in our pool. The 300 patients are continuously on glycoside, and the average HbA1c at the end was 7.1, which is near target of 7% by 80. And 159 male, 141 female. We evaluated in a longitudinal follow-up. The study was conducted in 2018, and we looked at our data. And we did a descriptive statistics on this patient, and educational and lifestyle advice was given. What was the result? The mean age of our population was 55 years. The cohort had average age of 55. The mean HbA1c was 7.1, which is fairly good. 82% patient reached a target of 7%, and the average was 7.1. What we found out, if you look, we took the patients who are already 5 years of diabetic, and they are continuously on glycoside. And what we found is that if you take the patient between 10 to 15 years of duration of diabetes, we had only 12 to 14% patient going into insulin, provided you are using, as per standard of care, other drugs that we use in diabetes. The education goes, hypoglycemia, diet, everything else. Therefore, if somebody was squeezing the pancreas, if modern sulfonylurea was bad, then by this time all of them should have gone, or 90% should have gone into insulin. So this extended release care, and I'll give you the exact data, 1% only had confirmed hypoglycemia, but that also did not need a third-party help. We also didn't see much of the weight change. I know this is a busy slide, but this is the detailed data. We had, if you look at the demography, the men, women, BMI, we had 50% of patients whose BMI was less than 25%. If you look at the number of patients in terms of BMI, we had 2 patients over 40. And do you know that if you look at the weight factor, even those BMIs over 30, studies have shown some reduction in their weight rather than gain. If you look at the duration of diabetes wise, 5 to 9, 10 to 14, this is the number of patients we had in each group. And then we looked at the insulin requirement. So if you look at 0 to 14 years, we had 16%. So I tried to break it up that how many people are going into insulin on the standard care plus glycoside. So this is a pictorial. So we had 16.3%, 49 out of 300 is due course required insulin. So, and they were within 15 years of diagnosis of diabetes, and they were on. Therefore, if you have got so many patients, which includes about 84% of patients, not needing insulin and having an HbA1c 7.1%, then I think we should cease to criticize modern sulfonylurea. And this is a pictorial presentation, or you can see the BMI, and you can see the duration of diabetes, and the number of patients we took on them. What I did in the IDF, we tried to extend this study in a different cohort of patients in a different time frame. We looked at, again, 40 patients and tried to see that whether that was a chance finding, because that was coming very close to the advanced study reports. But here also we found that durability was the main aspect we want to study. Again, I stated that durability is the time of onset of insulin on the top of standard care on glycoside. And what we found is almost similar. We had around 14.2% patient needing between 10 to 15 years of diabetes. So what I'm trying to say, if you are using standard of care and a modern sulfonylurea in your patient, which if you go tomorrow into your clinic, every doctor's prescription will probably have 90%, 99% of a sulfonylurea. So therefore, this is not something we are doing wrong. And if you look at the best of the studies, including MPARD to advance, everywhere the modern sulfonylureas have been used. And so this is a very, very effective molecule in terms of our practice. And we observed a sustained glucose lowering attributed to glycoside-based approach demonstrated by majority of patients, which enabled to postpone insulin initiation, which is of course a very big issue in our practice. Overall, the patient achieved a good glycemic control, nearly 7%. Our findings, of course, these are continuously following up patient. Our findings support sustained glycemic durability without much weight change and hypoglycemia. And to sum up, treatment of patient with type 2 diabetes is always individualized. So do not, this is a study that to tell you that how modern sulfonylureas are an efficacious anti-hyperglycemic drug. And then of course, SU not to be considered as one. All the sulfonylureas, as I told you, differ because of their binding onto the sulfonylurea receptor subunit. Modern SUs are effective, and if you're still not convinced, then cost is still an issue. Thank you very much.
Thank you, sir, for a wonderful study and its presentation. Now this session is open for the discussion. Is there any question from the audience for Dr. Sunik Banerjee, Dr. Ray, and Tirthankar, sir? Any question from audience side for the three respected speakers? And I have one question too.
Yeah,
sir. Sir, your insulination rate is very less, that too at a very highly placed tertiary healthcare center. So this is itself a very important finding, because other tertiary health at other tertiary healthcare centers, insulination rate is more than also closer to 50%. So is this same with the all sulfonylurea or only with the glycolazide?
Let me tell you first of all, if you see the reason for insulinization, many times I find that people start insulin because we have a very bias that we should do early usage of insulin. I believe what is important is glycemic control. If you are able to get the blood sugar under control without violating the standard of care, you need to introduce an SGLT2 inhibitor. You need to give, of course, other incretin-based therapy. Now, if you are using, and most of the time, you find a half-hearted usage of sulfonylurea, giving 1-2 milligram of glimepiride or giving us 60 and saying that, no, you need to go on insulin. Now, that is, of course, an experience and your understanding of the individualization of the patient. So, if you are following them up from the beginning, now, if somebody comes to you with, say, HbA1c 10%, and you have got no lifestyle, much advice, and he's on, you know that you need to go to insulin. So it, of course, depends on center to center, practice habit of the clinician. There is no wrong about it. Ultimately, that we should prevent complication and we should get the glycemic control. If you are convinced that I want to use a basal insulin early on, and I don't want to go beyond that, well and fine. But what I am trying to say is that many of the patients, you can actually use the maximum usage of glimepiride or glycoside and use the drugs which are standard of practice and get the diet and things, and you can keep them under control. And that is, I am not saying even the advanced studies showed me. In my cohort also it is shown. So there will be some hypoglycemia is another topic that comes. You know, it's a CYP variation of they are more susceptible to hypoglycemia. Not that all of the patients are similarly. So some people may have an experience with more hypoglycemia than others. So my thought is that try to get the blood sugar under control with the, then another problem is the patient don't follow you up regularly. They go off, eat whatever they want, they don't follow drugs, come up with a very high sugar, and then you start insulin, and your cohort shows very high insulinization. It depends upon the patients who are following up regularly. 10 years, 12 years, I can assure you, if you use, then huge number of patients will be under control if you are convinced and use modern sulfonylureas in full dose. That's what my thoughts are.
No, what will be the maximum dose of glycoside in your clinical practice?
I use XR 60 twice daily or maximum 120. And glimepiride I go up to 4, don't want to go
Right.
beyond that.
I think about the insulin, what I feel it's all depend upon the patient's compliance also
Yes,
to a certain extent and starting the therapy at the beginning. Thank you.
There are so many patients with whom, they come, I can see that they are on minimal doses of, say, glimepiride 1 milligram. They are on DPP-4 and SGLT2 inhibitor. And duration of diabetes is the first thing that comes to my mind. If it is less than 10 years, I know more or less that the vast majority will be able to get under OHA. And I remove the insulin and they are so happy and they bring another 10 patients just because I stopped insulin. I'm here, Dr. Mukherjee has something to say.
No, I have a question for Sunip. How do you adjust the dose of loop diuretics when you start a patient on SGLT2 inhibitor?
Yeah, that's a good one. I think first of all we need to de-escalate the loop diuretic. Now it's all by a clinical judgment, not anything else. And a person who is requiring around 20 milligram of torsemide once a day, in my clinical practice this patient is not been adequately treated with ARNI, beta blocker or SGLT2 inhibitor. That is important. But this transition is very important, that in hospital something and out hospital something, because most of our patients who are in this good climate, cool environment, the moment they go out, they lose like anything. So probably after we have started giving SGLT2 inhibitor in all comers with heart failure, irrespective of diabetes, we have tried to cut down the diuretic to minimum. And when I have a doubt that this patient is not going to tolerate, I started with torsemide because that is the concept that it actually doesn't interfere with the food, its absorption. But I still believe that furosemide in these cases, on empty stomach, 40 or 20 milligram twice a day, we need to give it twice a day, is useful when you try to de-escalate the loop diuretic. But the one most important thing is that what we see inside the hospital is not outside the hospital same. That is very important.
Any other question from any audience? We have few minutes left, so we can take 1 or 2 questions. Okay, thank you.
Thank you very much.
For our next session will be on the Professor P.P. Mitra oration. Yes.
Thank you, respected speakers, for this wonderful, insightful sessions that we have heard just now. And I can definitely say that yes, these topics that has been discussed upon has opened a different avenue and is going to help us to see or to think or to diagnose diabetes from a different perspective. I may now request our respected chairperson, Dr. Rakesh Kumar, to please be on dais along with our respected speakers of this googly round, that is Dr. Arindam Ray, Dr. Tirthankar Chaudhuri. No, I'm inviting them to please honor them with a small token of love from the day. May I please request the speakers of googly round so to please be here, Dr. Arindam Ray, Dr. Tirthankar Chaudhuri, Dr. Apurva Kumar Mukherjee, Madhumati Madam is doing the honor. Thank you, respected speakers, respected chairperson. Now, as we move towards the next round, that is strategic timeout, that is Professor P.P. Mitra oration. Although Professor P.P. Mitra do not need any introduction amongst the stalwarts of the diabetes, but still, as there are many people, even the dietetics fraternity is also there, so I think it is good for us to introduce him. Professor Pranoy Proshun Mitra was one of the greatest teachers of diabetes in Eastern India. He was one of the first proponents of original research in the field of diabetology while working in the School of Tropical Medicine, Kolkata. His research on diabetes in India won national and international recognition, including those from Royal Society of Medicine and Johns Hopkins. His special area of interest was juvenile diabetes. He started his teaching career in Bardhaman Medical College and ultimately retired as professor and head Department of Medicine, Medical College, Calcutta. As one of the pioneers in the diabetes management in Eastern India, he played a seminal role in public awareness of the society about diabetes and was instrumental in nurturing a healthy interest about diabetes amongst his students, many of whom are famous specialists in the field of diabetes in India. Entire Day family and Daycon organizing team is paying its highest tribute to its legendary physician in form of Professor P.P. Mitra oration. And to chair the session, I may call upon our respected chairperson, Dr. Mary Cruz, D. Cruz ma'am. May I please request you to be here on the dais? Dr. Professor Sujay Kumar sir, may I please request you to be in the dais? And to speak on the session, we have Dr. Shotinath Mukhopadhyay. So, respected chairpersons, you are requested to please initiate the session. Thank you.
It's really our proud privilege to welcome a noted medical teacher, scientist, and one of the most knowledgeable senior dadas that I've ever seen, Professor Shotinath Mukhopadhyay, for this honorary Professor P.P. Mitra oration. In fact, both of us were his students at one point of time, and it's really my proud privilege to invite Professor Mukhopadhyay to give this talk. First of all, I'll invite our dear friend, Dr. Rakesh, to kindly read out the citation.
The Executive Committee and the member of Diabetes Awareness and U, Kolkata, and the Organizing Committee of Daycon 2023 have great pleasure and feel honored in awarding this citation to Dr. Satinath Mukhopadhyay, who is MD, DM, FRCP London, FMS India. He is former professor and head of the Department of Endocrinology and Metabolism, IPGMER, Kolkata. On this day of 4th November 2023 at Kolkata, this citation and gold medal awarded for his dedicated service in medical education and research in the field of diabetes, endocrinology, and disorders of metabolism, and in recognition of his individual achievements and contributions to medical sciences and humanity, and having delivered the Professor P.P. Mitra oration, the pioneer of diabetes management in Eastern India. Sir, congratulations. Sir.
I'm also having to fill up this role of garlanding. I'm using the word garlanding Professor Mukhopadhyay with this medallion in the absence of Professor Apurva Mukhopadhyay because he had to leave.
Thank you, chairpersons, I also thank Dr. Suja Mujumdar in particular for having me for this prestigious oration. And as Suja has rightly pointed out, both of us were Professor P.P. Mitra's student. In fact, when I was doing my MD, he got transferred from School of Tropical Medicine to head the Department of Medicine at Kolkata Medical College. The reason you did not see a big picture of Professor P.P. Mitro was because of his extremely low profile. He was a sincere scientist. He was a remarkable teacher, but he was social shy. So you don't really get to see too many photographs of him around. And the organizers really struggled to find a high resolution photo to put up here. But I did not know that. Had I known, I could have shared some of his photos with me that I continue to cherish even today. Yeah, I promise. Now, now coming to the topic of this oration. In fact, this is the talk which I delivered recently at the US Endocrine Society. And those of you who are not present here, because this is a strategic timeout, so maybe you are outside enjoying your cup of coffee, so you can log into the US Endo Society website, and the talk will be there for you to enjoy for the next 1 year, starting from October 4th. So the basic idea is to understand how lipids induce insulin resistance and how we can improve lipid control through lifestyle intervention and medication to reduce diabetes and its complications. I have no disclosures related to this presentation. Way back in 1923, Elliot P. Jocelyn, who was the founder of Jocelyn Clinic in Boston, observed that from an excess of fat, diabetes begins, and from an excess of fat, diabetics die. So you can see that the connection between lipids and diabetes is not recent. Now, do all obese people develop insulin resistance and diabetes? No, they don't. And this slide tells you why. You can be a fit fat person, or you can be an unfit fat person. So whether you are a fit fat person depends on the response of your white adipose tissue to a surfeit of fat-rich nutrients. So healthy white adipose tissue responds to an excess of lipid intake through adipocyte hyperplasia. As the adipocytes undergo hyperplasia, there is a parallel increase in vascularity. So these adipocytes, the young adipocytes, are metabolically efficient, they're adequately vascularized, so they do not suffer from hypoxia, and they can pick up and store lipids efficiently. So individuals harboring those healthy adipocytes, they do not develop insulin resistance to a great extent, even when they are significantly overweight or obese. But then what happens if you harbor unhealthy white adipose tissue? Well, the unhealthy white adipose tissue, in response to an intake of lipid-rich diet, undergoes hypertrophy and not hyperplasia. So if you look at the size of the individual adipocytes, you can appreciate
that they are large adipocytes, so they are hypertrophic in nature. They are initially loaded with fat, which pushes the nucleus to the periphery of the cell, and such large adipocytes necessarily undergo hypoxia, as vascularity does not keep pace with the rate at which the adipocytes undergo hypertrophy. So in the hypertrophic adipose tissue, you have a hypoxia because of inadequate vascularity. When you have hypoxia, you have oxidative stress, and which leads to an inflammatory response, and you have pro-inflammatory polarization of macrophages and increase in the natural killer cells, which eventually cause adipocyte apoptosis, fibrosis, and death. And that's how harboring unhealthy adipose tissue leads to insulin resistance. If you have created a favorable environment for those adipocytes by undergoing a sedentary lifestyle. So adipose tissue remains the seat of chronic low-grade inflammation and obesity that fuels insulin resistance. And since adiposity leads to metabolic syndrome through inflammatory pathways, so metaflammation has come up as a new area in the study of metabolic disorders. This cartoon tells us how hypertrophic adipocytes elaborate an adipokine known as chimerin, which attracts a group of white cells known as plasmacytodendritic cells that enter the adipose tissue, and then they express the receptor for age. You may be familiar with advanced glycated end products which bind to their own receptors called RAGE, and you have age-RAGE interaction, and that leads to an inflammatory response. So our group was the first to show that plasmacytodendritic cells, upon induction into the adipose tissue, they express a RAGE. So this is the first report of receptor for age being expressed on the dendritic cells. When that happens, then chimerin, after binding to its circulating protein, it goes on to bind to its own receptor, and the RAGE binds to extracellular nucleic acids that are released from damaged adipocytes. So there is a two-pronged attack on the plasmacytodendritic cells, one from the chimerin and one from this age-RAGE interaction, which leads to production of type 1 interferon. This type 1 interferon actually causes pro-inflammatory polarization of M2 macrophages, and once you have plenty of pro-inflammatory macrophages, they elaborate a lot of pro-inflammatory cytokines, which by various mechanisms, which I will walk you through in a moment from now, causes insulin resistance. So that's the paper which discusses how adipose tissue recruitment and activation of plasmacytodendritic cells fuel metaflammation. Now this paper has also led to various investigators now looking at the impact of regulating chimerin level to see whether that improves insulin resistance, and there are now studies showing insulin and metformin reducing chimerin levels and improving insulin sensitivity. You know, adiponectin is a good hormone. Insulin sensitive individuals have a lot of adiponectin in the circulation, and this paper talks about an inverse relationship between chimerin and adiponectin. And if you knock down the chimerin gene in animal models, the adiponectin level goes up, and there is amelioration of adipose tissue insulin resistance. Now switching gear from here, let's take a look at what happens in the liver if you have insulin resistance. So I have walked you through on the hypertrophic unhealthy adipocytes. Now let's take a look at what happens in the liver in presence of insulin resistance. So fatty liver is a common occurrence, as you are all familiar with. Now when you load hepatocytes with fat, multiple hepatokines are released from those inflamed hepatocytes. One of the major hepatokine is phetuin A, which has been our interest over the last 1.5 decades. So phetuin A is a hepatic secretory protein. Its gene is located, as you can see, on 3q27. Very interestingly, adiponectin, which is an antagonist to phetuin A, its gene is also located on the same chromosome, about some 8 kilobase apart. What they are doing together, two opposing genes on the same chromosome, is not yet known. Phetuin A gene and protein expression in the liver cells increases during insulin resistance and type 2 diabetes. So this is a clinical study where actually we documented that people having pre-diabetes and also having a high phetuin A level actually progressed rapidly to type 2 diabetes. And those having phetuin A in the lower quartile, even if they had pre-diabetes, they did not progress to type 2 diabetes over a follow-up of 3 years. Now, this cartoon talks about, this is a zoomed in view of a hepatocyte. So when you stimulate a hepatocyte with excess of glucose and excess of free fatty acids, there is significant expression of phetuin A gene. Now phetuin A coming out of the hepatocyte binds to circulating free fatty acids, which act as its binding protein. So there is formation of a phetuin A free fatty acid dimer, which then goes on to bind to toll-like receptor 4, which are present on the surface of adipocytes and immune cells. And when that binding happens, there is downstream expression of genes of pro-inflammatory cytokines, which eventually cause insulin resistance. So this is one major mechanism by which phetuin A causes insulin resistance. Another equally important mechanism by which phetuin A causes insulin resistance is by directly inhibiting insulin receptor phosphorylation. So we have multiple papers now to show that insulin actually inhibits insulin receptor phosphorylation. Phetuin A inhibits insulin receptor phosphorylation and thereby inhibits the metabolic action of insulin. So here you can see these are DB mice which actually lack leptin receptor, and they become massively obese, just like our patients of metabolic syndrome. And here you have high fat fed lab animals. They also become massively obese, and these are their wild type control littermates. So you can see they are 3 times bigger than their control littermates. Now, when you induce such severe obesity in lab animals, there is an increase in the secretion of phetuin A, and you can see here that the higher the free fatty acid level, the greater is the phetuin A level, and when that happens, there is downstream expression of TLR4, which causes inflammation and insulin resistance through NF-kappa B. So all these proteins are increased when you have high phetuin A and high FFA, and so that's the paper which talks in detail about these mechanisms. Now, here we'll focus only on 2 important functions of adipose tissue. One is lipid intake and another is glucose intake, right? So here you have human adipocytes. These red dots actually are lipid droplets. So when you put human adipocytes into the nutrient media and you use a stain known as oil red O, so the lipid droplets are stained red, and here you can see this adipocyte is functioning normally. It is efficiently picking up lipid from the media. The moment you add phetuin A, you see the lipid uptake by that adipocyte is completely abrogated. Now we all know that rosiglitazone is a powerful inducer of lipid uptake by adipocytes. So this is a rosiglitazone treated adipocyte, and you can see the red dots indicating significant lipid uptake. The moment you add Phe2NA, what happens? Again, even in presence of rosiglitazone, lipid uptake by the adipocyte is completely abrogated. So, which tells us that Phe2NA coming out of the liver is a powerful inhibitor of lipid uptake by the adipocyte. And when that happens, the inflamed adipocyte secretes pro-inflammatory cytokines, like I said before, high levels of interleukin 6, TNF alpha, and IL-1 beta. Now, in the resting condition, the glucose transporters are all located inside the cytoplasm within cytoplasmic vesicles. The moment you add insulin, they translocate onto the cell membrane, and now they are in a position to take up glucose and bring it into the cell, right? So translocation of GLUT4 is one mechanism by which insulin induces glucose uptake by target tissues. Now here you can see in presence of Phe2NA, even insulin is not able to cause peripheral translocation of glucose transporters. So insulin-mediated glucose uptake is significantly inhibited in presence of Phe2NA. So to cut a long story short, free fatty acids coming out of circulation, they stimulate the production of Phe2NA. From the liver, you have dimerization. FFA Phe2NA dimer binds to toll-like receptor 4, which are present on the surface of adipocytes and immune cells. Then you have copious output of pro-inflammatory cytokines that cause insulin resistance. So that's the Nature Medicine paper where we discussed this mechanism, novel mechanism, for the first time. This paper has more than 900 citations since its publication in 2012 and remains the highest cited paper in the field of biomedical science from India year on year since its publication till date. So then here in adipocyte, macrophage culture, we show that Phe2NA causes macrophage polarization. Here at the bottom, you only see the pro-inflammatory macrophages. They have amoeboid movement. So on the top, you have anti-inflammatory M2 macrophages. You add Phe2NA, they acquire amoeboid movement and come to the bottom through the membrane here in the Boyden's chamber. So this is a proof that Phe2NA causes macrophage polarization and inflammation. Oh, the time is up? No, sorry. Again, this paper tells us that adipose tissue also produces Phe2NA when undergoing inflammation, and it causes macrophage polarization. So now, how do the pro-inflammatory cytokines cause insulin resistance? Through major pathways. One is this. You have a group of proteins known as inflammasome. So pro-inflammatory cytokines cause increased caspase activity through inflammasome activation. This caspase breaks down SART1. SART1, you know, is an insulin sensitizer. Many foods are rich in SART1. And you also, in the Western world, you will see over-the-counter SART1 pills or capsules available, and you can just buy them and to try and improve your insulin sensitivity. So SART1 is cleaved through these cytokines, and so you have insulin resistance. That's one pathway. The second pathway here is that Phe2NA increases this Wnt3A signal, which downregulates PPAR gamma. I hope you're all familiar with PPAR gamma and adiponectin. So when they go down, you have reduced expression of MPK. MPK is the target through which metformin works. So this shows the clinical relevance of the work. So MPK goes down, and both AMPK and SART1, they are responsible for maintenance of mitochondrial health. So this is the PGC1 alpha, which is the mitochondrial target, which is upregulated by AMPK and SART1. So when the levels are down, You have low PGC1 alpha, which interferes with mitochondrial biogenesis and bioenergetic functions, and you have mitochondrial ATP yield goes down. So you have dysfunctional mitochondria, which is the powerhouse of the cell. So the cellular activity becomes less efficient, and those cells undergo oxidative stress and eventually lead to insulin resistance. So these are the papers that talk about the Wnt gamma pathway, and that's the SART1 and AMPK relationship. Very recently, we have also been able to show that phetuine A is also expressed in the pancreatic beta cells, and this is mediated by DPP4 actually. So in type 2 diabetes, you have increased DPP4 activity not only in the circulation but also in the pancreatic beta cells. When that happens, and this is induced by phetuine A, you have low insulin secretion from pancreatic beta cells. And in another recently released paper, we have been shown that through this complex molecular pathway, actually phetuine A causes inhibitory phosphorylation of PPAR gamma. So this shows why phetuine A causes such severe insulin resistance, because PPAR gamma actually regulates adiponectin. It's the major regulator. If you have low PPAR gamma, you have low adiponectin, and you have insulin resistance. So these are the papers discussing those mechanisms. DPP4 expression in pancreatic beta cells. This is the inhibitory phosphorylation of PPAR gamma causing insulin resistance, and that's the molecular pathway. So this cartoon actually summarizes the mechanisms which I have already alluded to. Then now these hepatokines, myokines, and adipokines, they're all coming up in a big way to understand insulin resistance, and also for drug development. Taken together, they are known as organokines. So how organokines induce inflammation and insulin resistance. This is the recent review from our group, which we have published in the Journal of Indian Institute of Science, Bangalore, and this entire volume is dedicated to the understanding of metabolic disease. Now, how therapeutic approaches can mitigate insulin resistance by targeting phetuine A. You are all familiar with the salicylate, low-dose methotrexate, interleukin-1 receptor antagonists. They all improve insulin sensitivity, and some of these molecules are actually in clinical trial. Here you have AMPK being upregulated by metformin, salicylate, and methotrexate. So these are the drugs which actually target the inflammatory pathway, and they reduce phetuine A, upregulate adiponectin, and cause improve insulin sensitivity. Of the commonly used anti-diabetic medications, we have sufficient data now to show that insulin, metformin, thiazolidinediones, here GLP-1 and SGLT2 inhibitors, they all improve insulin sensitivity, and that is beyond their anti-hyperglycemic action. So anti-inflammatory effect here. It's a letter in the New England Journal of Medicine. This is the GLP-1 and stroke benefit. And again, the mechanism, if you see, this is the neuroprotection, essentially depends on an anti-inflammatory pathway. Pioglitazone significantly reduces serum phetuine A levels. Exercise also reduces serum phetuine A levels. So this is the paper. Here you can see hepatic insulin resistance reducing with lowering of levels of phetuine A. And here you can see with reducing levels of phetuine A, there is an increase in adiponectin level. So given that overfeeding has been shown to increase phetuine A and impair systemic insulin sensitivity, our data highlight lower phetuine A as an important mechanism whereby exercise reduces type 2 diabetes. So that's the underlying mechanism by which exercise helps. I think I'll skip this. We are working on this molecule known as paroxyphenadate, which actually lowers phetuine A level and improves insulin sensitivity. So we have multiple papers on this, but in the interest of time, I will skip these slides. So phetuine A actually reduces macrophage polarization. It causes adipocyte hyperplasia. Then it improves mitochondrial function. We have measured multiple parameters. Here you can see SART1 is increased, then your AMPK is increased, TNF alpha going down. This pathway is now regulated with this molecule which is known as DMP, dimethyl peroxyphenadate. You can see mitochondrial ATP density increasing, there's a fatty acid oxidation improving, ATP production increasing with this molecule. It's an orally bioavailable molecule. One single dose gives you 24 hours coverage. And let's take a look at the glucose data. You can see hyperglycemic mice upon treatment with DMP, and then you can see how nicely the sugar comes down to normal. There is no hypoglycemia. Insulin requirement goes down, as you can see, so the insulin tolerance space. The HOMA IR improving with this molecule DMP. So here again it is showing insulinomimetic activity of DMP in terms of insulin receptor phosphorylation. So that's the paper where we have analyzed the toxicity of this molecule. Those are the publications. So to conclude, Phetuin A acts as an adapter protein between free fatty acid and TLR4 to promote adipose tissue inflammation and insulin resistance. Phetuin A knockout mice are protected from lipid-induced insulin resistance, no matter how obese they are. So FFA Phetuin A dimer upon binding to TLR4 stimulates the production of pro-inflammatory cytokines through phosphorylation of NF-kappa B. Exercise, metformin, anti-diabetic medications, they have significant anti-inflammatory effects which are in addition to their potential anti-hyperglycemic effects, and that's how they mitigate lipid-induced insulin resistance. Salicylate, low-dose methotrexate, IL-1 receptor antagonists, and non-toxic vanadium compounds such as DMP offer promising anti-inflammatory approaches to mitigate lipid-induced insulin resistance and type 2 diabetes. So I think I'll end this presentation here, and thank you for listening.
Thank you, Professor Mukhopadhyay, for an excellent deliberation. It was really an eye-opening session for many of us. So obviously, we have been familiar with this, your work on Phetuin for quite some time. And just for the information of everyone, Professor Mukhopadhyay's work on Phetuin was published in Nature. So, and he's one of the few medical scientists from India who have got the work published in Nature. So it's a matter of great pride for all of us.
Thank you,
Shrodinanda, for an excellent deliberation. As you know, this is an oration, so there will be no question answer session on this.
No questions, but I want query.
You can ask it after the session is over.
Okay, right,
Thank you.
Thank you so much, Dr. Shrodinath Mukhopadhyay, sir, for this excellent delivery and interpretation. Okay, so now we are going to the next round of our Daycon, that is reverse sweep. And for that, we have our respected chairperson, Dr. Himanshu Chaudhary. May I please request you, sir, to be here on the dais? Thank you, sir. And we have two speakers for this session, Dr. Shashti N. Chakraborty and Dr. Shubhajyoti Ghosh. May I please request Dr. Himanshu Chaudhary, sir, to please carry forward.
First of all, congratulations Professor Shrodinath Mukhopadhyay, sir, for his Professor P.P. Mitra oration. With permission from our chairperson, sir, I'll be talking about place of vildagliptin in clinical practice. Before I say a single word, I want to thank the organizers of Daycon, and the portfolios of Day for letting me opportunity to speak in this platform. This is the table of content which I'll speak for the couple of minutes, upcoming minutes. There is a very interesting slide that has been published in recent journal. It showed that there is increased DP4 enzymatic activity in non-obese Indian patients suffering from type 2 diabetes. So circulating plasma DP4 levels positively correlate with waist-hip ratio, total intra-abdominal adipose tissue, and liver span, fasting insulin level, low density lipoprotein cholesterol level, triceps skin fold, and total intra-abdominal abdominal adipose tissue volume. Why I am speaking this all of a sudden? I have to go to the basic. So whenever we take food, there is GLP, incretin hormone releases from our GI tract. And there is our DP4 enzyme that makes an equilibrium. And if your body has excess DP4 enzyme, endogenous incretin availability may be compromised. So if you add DP4 enzyme inhibitor, it might have a better glycemic control in country like us. And this paper is probably the reflection of whatever I have said earlier. The Kolkata bound physician of this sir has published this paper, this review article, showed that there is a robust HbA1c control with DP4 enzyme inhibition, particularly for Asian against non-Asian. So what we think that DP4 inhibitor is a modest HbA1c reductor. It can be a good HbA1c reductor in Indian context. With this is a statement that DP4 inhibitors might increase your endogenous incretin level more. This should be supported with real world, evidence. With this, the vildagliptin is one of the pioneer DP4 inhibitor that showed in reality that there is more GLP-1 availability with DP4 enzyme inhibition. So considering vildagliptin is one of the pioneer gliptin, I have tried to frame to speak in this way. Matter of durability, any harmful effect on weight gain or risk of hypoglycemia, its safety concern regarding cardiorenal and liver, whether we can reduce pill burden with once daily preparation. So talking about different trials we have with vildagliptin, we have initial trial with few people, 53. We have age trial with more than 40,000, 45,000 people, and recently published trial, verified trial, more than 2,000 people, showed that vildagliptin is effective and safe in initial combination therapy for early and aggressive glycemic control to prevent macro and microvascular complication in drug-naive patient with type 2 diabetes mellitus. If you think about durability, this article showed that an early combination treatment strategy significantly reduced the relative risk of time to initial treatment failure by 49% versus initial monotherapy. There is fourfold advantage of vildagliptin: better time in range, better A1C reduction, less hypoglycemic events, and it can be a better DP4 inhibitor. Time in range is matter of debate in most of the scientific session, conferences, national, international, because we are moving forward from the concept of A1C to A1C and quality of life. So if you think about quality of life, time in range is one of the important parameter apart from other one. So a recent trial showed that patients on vildagliptin spent an additional 13%, that is close to 3 hours in the target range, 70 to 180 milligram per DL, when compared to sitagliptin. Not only that, vildagliptin demonstrated low hypoglycemia risks. I guess it will be applicable about other gliptins also. Now, CV safety of vildagliptin, there is no hardcore CVT trial for vildagliptin, but if you think hierarchy of scientific evidences, metadata is always lies in the top of hierarchy. Here you have metadata of 17,000 people that showed cardiovascular and heart failure safety of vildagliptin. There is no associated with an increased risk of adjudicated MACE, 3-point MACE relative to comparators, did not find a significant increased risk of heart failure in vildagliptin treated patient. We have TICOS trial for sitagliptin, which did not show any increased risks of major adverse cardiovascular event. We have SAVER-TIMI for saxagliptin. It did not show increase or decrease the rate of ischemic event, though the rate of hospitalization for heart failure was increased as per the trial. We have EXAMINE trial for algliptin, did not increase the rates of major adverse cardiovascular events. And we have metadata for vildagliptin, which did not show any increased risks of MACE. So with this, we can conclude that based on all published CV outcome trials except SAXA, all other gliptins can be considered CV safe or neutral. Though DPP-4 inhibitors have some class effects, vildagliptin works through enzyme substrate blocking. What is the benefit of that pharmacokinetics? It can elevate levels of intact incretin hormone that is maintained for a longer time frame, less glycemic variability, more time in range, and potent blood glucose lowering. As an important trial may vary, but is it important trial for reference only that there is clinically significant reduction in A1C was seen in this particular trial that was favoring vildagliptin against its other counterparts, other gliptins. Talking about renal safety, no ORI for CKD1 and 2, but dose reduction is necessary for moderate to severe end-stage renal disease. And in case of renal, end-stage renal disease, the molecule has not been studied yet, or there is very limited data. So matter of concern is there is wealth of clinical evidence with a vast pool of patient data on vildagliptin. You can go through this slide. It will build up your confidence while prescribing vildagliptin. Important point on recent US FDA guidance on CVOT, they have laid some criteria like this, and vildagliptin is meeting most of them. This one and this one. So long-term cardiovascular outcome trials with DP4 inhibitors, I already spoken. TICOS for sitagliptin, SAVER-TIMI for SAXA, EXAMINE for ALLO, and Carolina for LINA. Vildagliptin still don't have any hardcore CVD trial, but it has its metadata, whatever I told in some few earlier slides, which showed there is no associated with increased risk of MACE. Vildagliptin and Vivid, again, it showed no significant difference in risks of heart failure in hospitalization with vildagliptin in diabetic patient with systolic chronic heart failure. A study was done in aim to assess whether vildagliptin, either as a monotherapy or as a fixed dose combination with metformin, was associated with an increased risk of CV adverse event compared with other non-insulin anti-diabetic in real world setting. So this is a list of analysis which showed that vildagliptin had a good safety profile without increased risks of CHF or hospitalization due to heart failure. Vildagliptin is not associated with an increased CV risk, including the risk of CHF compared with other NAID in real world condition. And that is the article I was talking about. The metadata of 17,000 is the original article, recently published. The aim of that study was to find out, to report the cardiovascular safety profile and heart failure risks of vildagliptin, and it found that the result found that no indication of increased risk, including risk of heart failure with vildagliptin compared with its comparator. Another trial, you can have lots and lots of trial. I'll not speak in details of those trial. Clinical safety trial and tolerability of vilgliptin, insight from randomized trial, observational studies, and post-marketing surveillance. What was the result? DP4 inhibitors have been extensively evaluated for their CV safety, and the cumulative evidence has demonstrated CV safety with respect to major adverse CV events. These are some study findings which showed data for more than 12 lakh patients show the robustness of those studies. Again, you can have many more studies. It will be very difficult to cover it off all those studies in this single presentation. Now question is, okay, we are okay with vildagliptin twice daily combination. Can we have newer therapies on vildagliptin in diabetes management? Can we have better compliance, better adherence in patient management, better economical concern without compromising safety and efficacy with vildagliptin? Yes. Nowadays, we have vildagliptin 100 milligram SR, which assures control all long day. It is bioequivalent to vildagliptin 50 BD, 24 hours control with 90% DP4 inhibition, once daily dosing for patient convenience, and it is economical too. This is how the pharma companies are making those vildagliptin SR possible. Now some studies is finding that the DP4 inhibition in various bioavailability studies is comparable 90% or more against the reference product, that is vildagliptin 50 milligram BID. A recent study has been published by our Kolkata bound physicians, including Nilanjan sir, that BID and vildagliptin 100 milligram SR showed that weight neutrality is not a concern. The same thing, safety parameter, no change in liver enzymes, safe in parameters of changes in liver enzyme and serum bilirubin. A1C reduction was very close, 6.6 versus 6.5. Fasting blood glucose 116 versus 117, and PPG 162 versus 157. So we can conclude that it's very close between vildagliptin 50 BID versus vildagliptin 100 OD SR. And recent study published, presented in the RSSDI retreat 2023. It was a prospective single center study, open labeled. Vildagliptin 100 SR was added on to the patient after a week of metformin monotherapy. Primary endpoint were change in time in range, proportion of patients achieving time in range, and difference in HbA1c estimated from the CGMS, estimated HbA1c from the CGMS. The result was like this. Proportion of patient in time in range after 2 weeks, it was 52%, and change in HbA1c was also favoring vildagliptin OD. So that's all take home message from this presentation. DPP inhibitors works better in Asian people, including India. Vildagliptin has plethora of clinical evidence to prove its efficacy and safety, assurance of earlier and better glycemic control, benefits of durability, low hypoglycemia risks, no body weight gain is there, offers more opportunities to address individual patient-based need and care. It improves patient adherence to treatment. There is some ifs and buts with vildagliptin, with renal and kind of liver safety. We don't have any clear consensus, but hopefully a new consensus will develop. Until unless we have to believe the consensus statement published in the year 2017 by our, again, Kolkata bound physician K.K. Ganguly sir. Thank you. Over to Chairperson sir.
Thank you, Dr. Chakraborty, for your excellent presentation, which was thoroughly and through backed by studies. Kindly take your seat. We'll have the question and answer session at the end of this session. Now I invite Dr. Shubhojyoti Ghosh to kindly take the dais for his talk on pre-diabetes. Dr. Shubhajyoti Ghosh is currently.
Good evening, everyone. So, at the onset, I would like to thank the organization Day for giving me an opportunity to speak. And with the due permission of Chairperson, sir, so the topic which was assigned to me was pre-diabetes, the unexplored burden in India. The topic seems to be very much holistic and very much simple, and I would like to present in the simplest way. If you look into the data, it's been saying that 11% of Indian population is diabetic, whereas 15.3% of they are like pre-diabetic, which has been already been stated in a newspaper, The Hindus. Now, if you look into about the prevalence of IGT and IFG, if we look into the Southeast Asian region, we see that there is a rising trend from 4.5% to 5.7% in case of IGT. In case of IFG, it's also like again from 9.4% to 9.6%. And this is about the age-adjusted prevalence, which have been shown that the prevalence has been increasing in from 2021 to 2040, which has been projected about the increase of both IGT and IFG. But the thing is that it's been increasing in both middle and low income countries also. So what we can say that the pre-diabetes state is not associated with only the high income countries. Even the low or middle income countries have been not spared of that. And this is a graph showing about the rising trend of both IGT and IFG. So, since it's been rising trend, so what we can say is that whatever comes first, coming even cast their shadows before. So that is what we call that this rising trend is an alarming for us. And the pre-diabetes is the early stage where all the things of preventions can be set up. So what is pre-diabetes? ADA defined pre-diabetes as a condition in which the blood glucose level are elevated above the normal range, but do not satisfy the criteria for diagnosis of diabetes. Hence, because of that, in 1979, after a long, large epidemiological studies, they have derived that such as the retinopathy and nephropathy are associated with if there is raise in blood sugar of more like 2-hour OGTT values, and they have also found that the same pattern have been seen in a patient who have OGTT raised but not at the level of diabetes. Hence, they have coined the term of IGT, impaired glucose tolerance. Thereby then comes in 1997 about the term called IFG, that's impaired fasting glucose. And that has been introduced. It has been introduced because the reason to avoid the need for doing an OGTT to diagnose IGT. The criteria have been put very much simple as the fasting sugar, it should be more than 110 to, or it should be below than 126. But which has later been again redefined in 2003 that they have said that the fasting should be more than 100 to 126. And this redefinition have been done just to increase the sensitivity for the diagnosis, because the sooner we diagnose a state of pre-diabetes, we can really put some halt in their pathogenesis. This is the diagnostic criteria of pre-diabetes. Like for ADA 2010, they are saying the fasting should be more than 100 and less than 126. For 2-hour OGTT, it should be more than 140 to less than 200, and A1C should be more than 5.7 to less than 6.5. Now, what is about IFG? Like impaired fasting glucose, it means the patient is having hepatic insulin resistance. And what is about IGT? IGT means the patient is having skeletal muscle insulin resistance. So this is about what happens in being in diabetes, like the body lacks insulin or is unable to use insulin effectively, both at the pancreas and also at like muscles and fat cells also. They cannot effectively use the insulin, hence the blood sugars which are there in the blood is on higher side. So again comes and state like it can be an isolated IFG, which means that you have reduced beta insulin sensitivity. They will have a stationary beta cell or chronically low beta cell mass. It have an altered GLP-1 secretions and inappropriately elevated glucagon secretions. So what are the risk factors? Like lack of physical activity, poor nutrition. In poor nutrition, with the westernizations of our food, we find that too many calories are there in our daily fast foods, then very high fats, low fibers, Along with that, our BMI. We have to really take care of BMIs and about the waist circumferences. The other risk factors, it can be like family history of type 2 diabetes, the non-Caucasians background, age over 40, but rather I would like to say like for Indians, it should be age about 35 need to be screened. Complications, complications for diabetes is like cardiovascular diseases in case of heart attack, stroke, blindness, kidney diseases, amputations, erectile dysfunctions. Now coming back to the risk factors for diabetes and pre-diabetes, if you look into about the pre-diabetes, we have that the age, family history of diabetes, abdominal obesity, hypertension, and these are like the risk factors. The good news is that diabetes can be prevented in many people. For that, we need to have changed the lifestyle. Why I'm saying about that? Because the natural history, if you look into about pre-diabetes, like from IGT, any person who have a IGT, there is 32% of chances that he can step back to the normalcy of or called euglycemia, and 34% of the patient may develop diabetes in the process of the time. Similarly, if any patient is having both IFG or IGT, there is 18% chances that the patient may go back to the normalcy. And these are the pathological defects which we have in prediabetes. That's number one is loss of beta cell volume, defect in insulin action and secretions, endothelial dysfunctions, atrial stiffness, increased lipolysis, reduced incretin levels, increased hepatic glucose production, impaired glucagon level, and dysregulated cytokines. And because of all these things, we have this recognized macrovascular complications in case of prediabetes also, not in case of diabetes. I'm saying about in case of prediabetes, like they will have pro-inflammatory cytokines, endothelial dysfunction. Hence, there will be chances of strokes, peripheral vascular diseases, MI, congestive heart failure. And if you look into about microvascular complications, if you look the prevalence about microalbuminuria, they have found that in compared to normoglycemia, there is 14% increased chances of microalbuminuria in case of the patient who are having IGT, and 18% who have IFG or impaired fasting glucose. So what we can say is that all these microvascular complications, they are really sets in prior the patient is having diabetes. So what we used to say that any patient who is diagnosed with type 2 diabetes, he should undergo the total prophylactic screening of entire microvascular complications. So again, is that we can prevent it. And the management principles, what they are saying is that lifestyle modifications, and metformin is only approved. I will go into details about this. First of all, just look into about the nutritional status which have been presented in a study. They say that as per IDF, the prevalence of type 2 diabetes has increased by 21%. The nutritional therapy has been conventionally recommended for the people with pre-diabetes to delay or halt the progressions. Why? Because we can do it like low calorie, low GI foods, whole grain, plant-based, nuts and proteins, diet supplementation, diet and exercise. Now we are saying about reduction of calories. So how to supplement that? For that, we need to help the patients to give with proteins. So as per the STUD study, they are saying that the protein consumption in the patient with type 2 diabetes is 12% pan-India. Whereas we need, and in case of like balanced diet, the recommended protein consumption is on higher side, need to be taken on higher side. So hence, this is such a small way how we can meet protein intake. Like for example, for breakfast, we can say that to take a curd, paneer, all these things in case of breakfast, in the evening also, because with lunch and dinner, we used to take protein, but the thing is that we skip in breakfast and in evening. So this is a small way how we can help to take our increase the protein intake. This is an CGMS data which has been done in case of pre-diabetic patients with low carbohydrate diet. They found that there is reduction variability with low carbohydrate diet in case of pre-diabetic patients also. Now about the role of high fiber diet, they find that in case of if you give high fiber diet to the patient, there is reduction of fasting blood glucose. This is such just a simple plate technique which we need to really give to our patients all the time. Now we say about alteration in food parts, how to do it, how to reduce the glycemic index. We can add legumes and high fiber vegetables to the polished grain or lower GI. We can use the coarse grain instead of refined flour for the food preparations. We can incorporate condiments such as cinnamon, ginger into the meal, as they have shown to lower glucose level. We can include the protein sources like dairy, fish, lean meats, and better we can choose like parboiled rice or basmati rice instead of processed white rice. So this is again how to improving the quality of protein in the diet. We can mix dal with rice because they have a supplementary mechanism of action. We can have like khichidis, we can have rajma chawal, we can have idli dosas. All these things, like traditionally whatever they are with us was already been supplemented with from generation, so that, but with the modernizations we have really forgot about that, and we are taking with the processed, lot of processed food which need to be changed. And these are a lot of studies which have been done in case of pre-diabetes. They have already said that with lifestyle modification, it can be prevented. Now, balancing everything is important with your nutrition, with your regular physical activity. We say about a diet, so how to take a nutritious diet. We can cut back on total amount of fat you eat. Try to eat more fibers each day. Eat fruits or vegetables. Try to eat small meals at the regular time. Balance your calories with your energy needs. Now, balancing with the calories with the energy needs, the good part in pre-diabetic, if you really go them and negative calorie diet, that will really halt their diabetes by chance of being diabetes. So that's how it's been done. There's a small calculation which I'll be showing later on. And for physical activity, we all know about brisk walking, bicycling, and this need to be done. With brisk walking, one more theory is coming up these days. They are saying that 30 minutes of brisk walking is not enough for you. At least you need to increase to the 45 minutes, because the initial 20 minutes of walking needs to warm up your body, and which doesn't lead to the reduction of calories. So, so we should have pedometer. These days we have a smartwatch, smartwatch or smartphones, which we can use as a pedometer, because we need to aim at should be like 10,000 steps per day for our patients, because the benefit of exercise is it lowers blood glucose, blood pressure, cholesterol, it strengthens heart, lung, and circulatory system, it promotes weight loss, and improves the quality of sleep. It decreases stress, increases enthusiasm, that it improves the way you feel about yourself. That's what important thing. Now I was saying about weight loss, which is important thing to prevent you to become a diabetes from pre-diabetes. It's like calorie counting. You have to burn 3,500 calories to lose 1 pound of fat. And how you can do it? You have to set a very realistic goal that to lose 1 to 2 pounds a week. And then the loss would be 7% of total body weight in case of 6 months. If you lose weight much speedier way, there's higher chance of rebound phenomenon to gain weight back. And you have to use your waist measurement to track abdominal fat loss. And this is what I was saying about, if you look, there is a factor called activity factor. Suppose a patient who BMI is on higher side, and we know that we need to have a desired weight for that patient. Suppose the desired weight for the patient is 165 pounds. If I'm saying that, then depending on his activity, like sedentary, active, very active, they have for male and female, they have activity factors which need to be multiplied, and then you will get the total calorie required for that person. After you get total calorie required for that person, what we can do? We can give minus 500 calorie deficit diet. So the total calorie came out to be 1480 in case of this patient, and if the patient will take that for 7 days minus 500, the patient will lose 3,500 calorie, and by doing exercise for 5 days, he can lose 1,000 calorie extra. Total calorie which has been lost in a week is 4,500 calorie, which means 1.3 pound a week, and for a month he will be losing about 5.2 pounds a month. And the period of 6 months, the patient will have a reduction of weight, and the patient will revert back to the euglycemia then from being pre-diabetic. So this is the game plan. We can always say that prevention can be at primordial, then primary, secondary, but I'm just because the topic was very much simple, so I tried to give a very simple and realistic clinical type how you can really apply to your studies. So the game plan is that keep a diary, eat whatever you're eating, write down, and try to have minus 500 calorie less, and add more fibers to your diet. And then you have to monitor your success. Even if you haven't lost all the weight you want, monitor your other success also, because that will motivate you. Now, putting it all together, set a reasonable goal for yourself, start eating more nutritious meal, then start exercising, monitor your success, and be patient, don't give up. Hence, with that, the take-home message will be like a pre-diabetes carries an increased risk in cardiovascular diseases. It has got significant physiological, metabolical, biochemical features, and which are dysregulated pre-diabetes. Extensive RCTs have been demonstrated that lifestyle modification can decrease the rate of progression from pre-diabetes to diabetes. Early detection intervention is vitally important for prevention of pre-diabetes and progression to the diabetes. Even though metformin is only approved drug for pre-diabetes, which have been approved, but I will rather say that lifestyle modification is the main part to incorporate in the life so that we can really halt pre-diabetes at that same stage or halt, return back to the euglycemia. Thank you.
Thank you, Dr. Ghosh, for your excellent and practically oriented presentation. Indeed, pre-diabetes is a very important condition in today's lifestyles. The ICMS study says that we have currently at present about 136 million of pre-diabetics in India. Sir, kindly take your seat. The session is now open for questions and answers. We invite questions from the audience if there is any. Our speakers will answer them. Any questions on the previous session from the audience? If there is no question, we close the session right now.
Thank you, respected chairpersons, for steering the session, and thank you, respected speakers, for this articulate lectures. I may now request our respected speakers to be on the dais to accept the small token of love from Day. And I would also like to request to call upon Madhumiti Madam to hand over the token of love to our chairperson and to our respected speakers. May I please call upon Dr. Shashti and Chakraborty and Dr. Shubhajyoti Ghosh to be on the dais, sir. We would now like to share the small token of love with our chairperson, Dr. Himanshu Chaudhary. Dr. Himanshu Chaudhary, sir. Yeah. Next, we are moving to Dr. Shubhajyoti Ghosh. Sorry, it is done. Then now may I now request our chairperson to please hand over the token of love to Dr. Shashti and Chakraborty. Madhumati Madam, may I please request you to please hand over the token of love to our chairperson, Dr. Himanshu Chaudhary, sir. Thank you so very much, respected dignitaries. Now we are. Now there is a tea break before we move on to our next round.
Ex-head of the Department of Endocrinology and Metabolism, SSKM Hospital. And sir, need no introductions. Sir, over to you for the next panel.
We have our exciting session ahead, and actually the session is over to all the panelists, and we are fortunate to have big names in different big institutes of this city. Let us be enriched by Professor Demalo Shanal. I mean, each one of them will have multiple descriptions for them, but I'll keep it short. So maybe Professor of Endocrinology at KPC Medical College, and we have Dr. Shubhi Roy, big name from Apollo Hospital. We have Dr. Kollan Gangopadhyay, again Dr. Kollan Gangopadhyay and Dr. Sujoy Mujumdar, both from Peerless Hospitals. So We have all the people from whom you can ask any and every question related to the issue at hand. We all know that diabetic kidney disease is a major problem. We are fortunate that we have important pharmacological agents today to help us in our journey. We had the ACE inhibitors, then the ARBs, and now we have the SGLT2 inhibitors. Today we shall examine the role of non-steroidal mineralocorticoid receptor antagonist. At this point of time, we have only one such molecule, at least well known. There would be a few others, which is of course not commercialized yet. So we'll talk about findranone. So this session essentially should belong to all of you. So please feel free to put your questions whenever you think, and we will have the answers from the panelists. Any questions at this point of time? If not, yes.
Sir, how you are placed finiran, because we have other proven molecule in management of CKD. In your clinical practice, how are you placing finiran over them? Like ACI, maximum tolerable dose,
Right,
ACI, and all those things.
Yeah, fine. So we will definitely come to that, but let's be very clear that this is not essentially to try and say that findranone is above everything else. We have to try and understand what is its role in overall management. Let us not be naive and expect that one particular agent will solve all the problems related to diabetic kidney disease. But would any of the panelists like to make a quick comment? Shubir or anyone? Findranone above other agents.
I believe that we are not going to place findranone above other agents. It is a complementary molecule. We still have ACE inhibitors and ARB as a first line, and we've got the SGLT2 inhibitors. Findranone addresses a few very important pathophysiological defects, so it's going to work as a very important team member where you're not achieving the target, where there is a residual defects left after using SGLT2 inhibitors and ARB. So I'll place them after these very important two molecules.
If you look at the latest KDIGO guidelines, it very clearly suggests, this is the guideline I'm talking about published in 2022, you start for the management of diabetic kidney disease in addition to glycemic control, control of blood pressure and everything else. What you do, the agents that are specifically recommended for the treatment of diabetic kidney disease, one are the RAS blockers, that is primarily I should say in type 2 diabetes, the ARBs. Next comes the SGLT2 inhibitors, and next down the line is to look at the residual disease is findranone or the mineralocorticoid receptor antagonists. Problem is that now there is always this debate which is going on, which one should come first? Is it SGLT2 inhibitors or MRAs? The answer is that it's been a bit complicated by the different studies which have been done on findranone. If you look at the two major studies, the Fidelity and the Figaro studies, they did not have more than 7% of patients who were concurrently on SGLT2 inhibitors at the same time. So it's difficult to say which one will come first, but if you look at the guidelines, it still suggests that you start with SGLT2 inhibitors after the ARBs, and only in the residual disease, the residual 30% patients who are still not controlled with the optimum dose of both the ARBs and the SGLT2 inhibitors, you add the findranone. Having said that, trials are on the way, and there are a couple of trials which we are going to show the slides later on, which will basically say that whether this combination is better than giving each one separately. In fact, there have already been a few studies which have shown that this combination of SGLT2 and findranone produces numerically a better degree of reduction of albuminuria than each of the other agents given separately. So that's the bit for the time being.
Right. Can I ask Dr. Demalo Shanal about diabetic kidney disease? anyone with diabetes and chronic kidney disease, shall we call it diabetic kidney disease, or which are the clinical pointers that a clinician can, busy practitioner even can try and pick up to decide that this is diabetic kidney disease?
First of all, kidney disease is per se defined as when there is persistent either the GFR reduction less than 60, or we have ACR which is confirmed by 2 out of 3 readings which is more than 30. So these are the basic definitions of CKD. With regards to diabetic kidney disease,
Sorry, Debalu, because JJ is dozing off. Please, can you tell me if, let's say, I find an ACR of 400, do I still have to repeat a second time, or only if it's 35, 40, then only we have to repeat?
Sir,
JJ, this is JJ's question. Yes. No. No, you can't doze off in such an important meeting.
yes, and finally, though it's very difficult to, at times, in a lot of patients, to decipher whether it is because of diabetes per se or not, but we have definite pointers. One of the issues is with regards to duration of diabetes, with regards to presence, which have been traditionally taught, presence of diabetic retinopathy, as well as, we need to look at urine routine as well, with regards to cast, whether there are sediments or not. And we also may do an ultrasound to see whether there is a vascular aspect or not, that is renal artery stenosis or not, polycystic or any cystic changes or not, adult ADPKD is there or not. So we have to do the basic level of investigations to exclude whether it is occurring because of other conditions as well. But again, if the CKD is progressing rapidly, there is a significant macroalbuminuria, then again without presence of diabetic retinopathy, then we need to be actually be careful whether we are dealing with non-diabetic CKD. That's very important to rule out, because we may have, sometimes we can actually do several studies and where we can actually pinpoint the diagnosis and we can treat. In such situations, one may require a renal biopsy as well.
Now, can we go on to Dr. Shubir Roy? We understand mineralocorticoids, essentially aldosterone, causes sodium retention, and so causes hypotension. But when we talk of this MRAs, is there any other role of the mineralocorticoid receptor that we are talking about which could contribute to kidney damage beyond hypertension?
Right. The role you just said is a genomic function of aldosterone. So if you look at a diabetic kidney disease, you've got 3 basic pathophysiological problems. One is the hemodynamic problems, which is basically arising from hypertension, increased glomerular pressure, ultimately leading to glomerular sclerosis. We've got the metabolic problem, that is hyperglycemia per se. And the third one is inflammatory or pro-fibrotic pathway. Classically, we do not categorize diabetic kidney disease as an inflammatory condition, but there is a certain and very complex interplay between this metabolic pathways and the inflammatory pathways, because in a state of chronic hyperglycemia, few things happen in the kidney itself. There is intrarenal overexpression of the whole RAS system. There is increased secretion of angiotensin II. There is increased secretion of angiotensinogen itself, increased secretion of renin, and increased secretion of aldosterone. We all know that aldosterone comes from adrenal cortex. It's not the fact. In many situations, aldosterone is secreted from other organs as well. Like, in diabetic obesity, it comes from the adipose tissue itself. So there is intrarenal overactivation of the whole RAS system. On top of that, there is overexpression of the mineralocorticoid receptors. So what happens? This non-genomic or quick pathway, not the classical aldosterone pathway, there is this triggering of the inflammation pathway. there is intracellular accumulation of calcium leading to reactive oxygen species, and it's the whole trigger, the TGF, whole cascade starts. So that ultimately leads to fibrosis of the kidney. So that's why in diabetic kidney disease, this overexpression of mineralocorticoid receptors are very, very important, because it is actually the final common pathway of all the pathophysiological defects of type 2 diabetes, and that's why it is so important to block that ultimate terminal pathway.
Right.
It's very complicated. I believe that I could explain the way I understood this.
Right, fair enough. So we are gradually sort of trying to understand why mineralocorticoid receptor antagonists could be or should be used in chronic kidney disease or diabetic kidney disease. So it's a steroid, aldosterone, that we are wanting to block, that Dr. Shubir Roy wants to block. So can we now hear from Dr. Kullan Gangobadhyay as to why not a steroidal antagonist? Why now think of a non-steroidal antagonist?
So I think steroidal bodies, it's a ubiquitous thing in our body. So a lot of organs, tissues, receptors, hormones, they have got steroid structure. So I think till now we have been using aldosterone and eplerenone. So the adverse effects is partly due to their steroid structure as well. So we know that gynecomastia is a known side effect of the aldosterone. It's quite not uncommon, I must say.
Spironolactone, you mean?
Yeah,
yes.
spironolactone, sorry.
But that's overcome by eplerenone to
yes,
a significant extent?
To a significant extent, but not entirely. But again, you lose the potency there with the eplerenone as compared to aldactone. So here, the way that spironolactone and eplerenone works is that it blocks, it may act as a partial agonist of the receptor in conjunction with the cofactor recruitment. But here, finerenone, it just sits there and blocks without having all the ill effects of the steroid moiety. So I think, you see, now this, what I'm going to say is, I cannot back it with scientific evidence, but in UK, whenever we had given aldactone to the patients, most of the adverse effects, hyperkalemia and worsening of the creatinine, is to occur with our Asian patients. And that I could never understand why it was. You see, all the trials, they said the hyperkalemia is more than 5.5, but we are scared when it goes above 5. So a lot of patients are in between 5 and 5.5 as well. So with the spironolactone, the adverse effects seem to be quite more in Asians. This is my personal experience. I cannot back it up with scientific literature. So we were always looking for another moiety, and we know that aldactone and its metabolites, they have got a very long half-life. They are all active as well. So when the patient comes with hyperkalemia, you need to really monitor them for about 72 hours. So we were looking for something which does not have the gynecomastia and other steroid-related adverse effects. At the same time, not have this hyperkalemia and worsening of the creatinine is concerned. So in that aspect, I think finerenone is a welcome change.
Kullan, I fully understand, or maybe to a large extent I understand, the issue related to gynecomastia being less with this sort of agent. But if this is a very effective blocker of the mineralocorticoid receptor, why should hyperkalemia be less with this? It should be similar. And that's actually one important area which distinguishes it even from eplerenone. Any suggestions from?
I think it's probably the half-life. I think with finerenone, your half-life is 2 to 3 hours. So even if the hyperkalemia is there, it goes away very quickly. Plus, it doesn't have any active metabolites which persist for a long period of time, like spironolactone. And third, I think the tissue distribution with the spironolactone and eplerenone, it is mainly in the kidneys as opposed to the heart. And with finerenone, it's equally divided between the heart and the kidney, and that's why you get to see both the effects.
Right. Maybe for me, maybe the last one seems the most plausible. Does Bayer medical team, are you there? So do you have any answers? You need a microphone.
I think there is the one microphone there.
Dr. Kalyan sir rightly covered all the points, sir, why this hyperkalemia incidences are very less, and you rightly mentioned that the tissue distribution is actually equally distributed between heart and kidney cells. So that is also one of the reason. And another thing, sir, that what the dose we are using, this is actually low dose of finerenone compared with preclinical studies in which we compared with the regular dose of eplerenone. So finerenone demonstrated that anti-inflammatory and anti-fibrotic benefit, and again with very less incidence of hyperkalemia at the low doses compared with the regular doses of eplerenone.
So maybe lower dose as well as the tissue distribution.
Exactly.
does it.
Exactly.
Right.
Shubhamkar, if I may
Yes,
just add
yes,
one word here.
yes.
One of the reason why, compared to the steroidal ones, the non-steroidal ones have been more beneficial in diabetic kidney disease is because of their action on preventing
have we accepted that it's more beneficial? Finerenone is more effective than, let's say, eplerenone or spironolactone? Is that established?
There is some evidence to suggest that basically if you look at the pathophysiology of the mechanism of action of finerenone, it has got some definitive protective action on reducing the inflammatory component of the tubular fibrosis. And not only the tubular fibrosis, but also on the myocardial fibrosis. We all know that in diabetic kidney disease, for example, there is often a component of a heart failure. And that heart failure often happens because of an ongoing myocardial fibrosis. Now, this is also something which is prevented.
Similar evidence is there for spironolactone and eplerenone as well. What I'm trying to drive at is, can we all of us therefore learn that finerenone is more effective? Will
It
that
is.
be a learning point? So
Well,
does Bayer claim that? Yes. So do we have a head-to-head study?
Yes, we did in phase 2 study, sir. We compared directly.
Phase 2?
Yes, which has demonstrated similar efficacy compared with spironolactone. Similar efficacy when it comes
now
to.
we are talking of superior.
Yeah.
Is it superior efficacy is what we are asking?
Sir, actually the patient population which we have included in phase 2 studies are heart failure with CKD, sir. So there we have demonstrated similar efficacy when it comes to this reduction in anti-proBNP.
So far we know it's similar.
Yeah,
Fine,
but
fine.
better safety, sir.
Better
The
safety.
significantly
Yes,
reduced safety.
Yeah.
I had just one, but this is my gut feeling rather. This MRA expression, this overexpression, I believe that it is not so much in the distal tubule where the classical pathway happens. It's mostly around the glomeruli, the resident macrophages and the podocytes, which is basically the major players in the fibrosis and the inflammatory pathway. So it blocks that pathway. It does not changes the major function in the distal tubule. That could be the reason behind not causing so much of hyperkalemia.
Yeah, basically, there has been some studies based on animal models which have shown that so far as prevention of this tubular fibrosis is concerned, there is some head-to-head, I think, correct me if I'm wrong, there has been some sort of studies which have compared with eplerenone versus finerenone, and where they've shown that this reduction potential of this fibrosis, tubular fibrosis, is much better with finerenone.
Yes.
In animal models, yes, they've shown that.
Yes, yes.
Okay, I'm enlightened. So we stay with Sujoy. So we are here to discuss the advantages and also what clinical evidence we have got. I do understand this very large study, the Fidelio Decadi study. Could you quickly summarize for us, for all of us, what this study is about, what should be the learning points from this study?
Right, this Fidelio Decadi as well as the Figaro studies, they were basically complementary studies because the primary endpoint in one was the secondary endpoint of the other. So it was a sort of we can see it as a sort of a crossover sort of study results. But the results were very similar. It showed, just to summarize in one word, I do not want to get into the details because honestly I do not remember all the points. But the summary take-home message here was that it improved significantly the albuminuria, it significantly reduced, there was a significant improvement in the EGFR fraction as well. And also at the same time, there was an improvement in the heart failure component. So these were the three things which we found out. Now we can always argue that when we all know that in any study, the secondary endpoint has got a much lesser value than the primary endpoint. But here, because the studies had a sort of a reversal, the ultimate take-home message is that compared to the other agents, and one other beauty of both this Fidelio and the Figaro studies was that the total cohort study, the cohort size, was much more than the other agents, like say the ones on ARBs or the SGLT2 inhibitors. Here the cohort size was much more. So obviously the robustness of the data was much more here with these studies.
Right. For us to use in clinical practice, can you just highlight what was the baseline study population, for example, on what agents were they, on top of which MRA was added? Can
Right.
you just have an idea?
So the baseline, I mean, the inclusion criteria here was the EGFR of more than 60. I'm sorry, EGFR of I think
maybe
around 60, and an ACR of more than 30. So, and also these people were on pre-existing, in addition to the glucose lowering therapy, almost I think more than 90% were on ARBs. I think in the Fidelity actually they had around 7% patients who were already on SGLT2 inhibitors. So that was it. And in addition, the other routine treatment for treatment of hypertension, like calcium channel blockers, those things were there. So there was not much of a difference between these two studies, between the intervention arm to start with. The only agent which was added here was the Finradon.
Right. So can we now learn from Professor?
One point. I think this question is very important because that tells us where do we start, because that's the baseline criteria is where we start. So I think it's roughly EGFR of more than 25 and more than 25, and if your albumin creatinine ratio the albumin creatinine, so if your EGFR is more than 60, then you can have a much higher albumin creatinine ratio, which will make you qualify. So what that tells us is where we can use is EGFR more than 25, where we can use is urine ACR of more than 30, up to 5 grams. Sorry, 500. So that's why I think you asked the question, because on top of. So that's crucial, because all the patients, they have to be, by definition, they have to be optimized on maximal tolerated. So each and every term is important. Maximal tolerated ARB, and with potassium of less than 4.8, if I'm not mistaken.
And as Dr. Mojumdar suggested already, that the Fidelio and the Figaro are sort of twin studies. So as I understand, maybe the Figaro looked more at cardiovascular end of the benefits, whereas Fidelio looked at the kidney benefits. So would Dr. Dimalu Shanal tell us a little bit about the Figaro study, Figaro DKD?
So basically the issue is the Fidelio study was basically in patients with stage 2 to stage 4 CKD with a GFR of more than 25 as the first qualification, potassium less than 4.8, and urine albumin, microalbumin, which is positive. Now, these were actually sicker patients with higher stages of CKD. So basically more than 25, and they generally had either below 60, those who did not have significant macroalbuminuria, and up to 75, those who had macroalbuminuria. And the primary outcome was renal outcome, because these were advanced CKD patients. And the secondary outcome was cardiovascular outcome, and there was about 18% reduction in the primary outcome CKD. Whereas, so this was basically in advanced stages, which we already have data with the SGLT2 inhibitors. Now, Figaro was a complementary study to look into the early stages of CKD. There are two populations. One group had patients who had albuminuria, which was significant, which was in the microalbuminuric range more than 300, and they had, however, early stages, stage 1 to even stage 1 CKD was used, stage 1 and stage 2 CKD. It could extend up to a GFR of 90, more than 90. So that's very important. So you could actually include all patients with CKD at all stages of CKD, and another subgroup of patients were basically having a more advanced GFR, lower GFR with any level of albuminuria, which was even microalbuminuria was included. So that's very important. So this was basically a more earlier stages of CKD. Now, both these studies actually excluded patients with heart failure as well, non-diabetic CKD, and they only included patients who had diabetes. So all these were actually risk factors not only for CKD progression, but also for cardiovascular disease. So this study actually primarily looked at cardiovascular outcome as primary outcome and renal outcomes as secondary outcome. So what they found out was there was a significant reduction of about 13%, as far as I remember correctly, in the overall cardiovascular outcome. Mind you, this cardiovascular outcome was not 3-point MACE, which we actually use in the other CVOT trial. That is, CV mortality, stroke, non-fatal MI, non-fatal stroke. That is a traditional 3-point MACE. They included 4-point MACE, which included heart failure. So that accounted for 13% reduction. And out of that, the major driver of this reduction was basically heart failure, which was about 29% reduction in heart failure. There was some data which we have to take it with a pinch of salt, that those who were on medication, they had reduction in CV mortality and CV events, and those who were on as per treatment, they also had a reduction in certain cardiac death. But these were again subgroup analysis. But overall, there was a benefit with regards to 4-point MACE, primarily driven by cardiovascular, by heart failure reduction. And again, the CKD, the benefit was persistent. And together they did the fidelity analysis, which actually pulled together both these subgroups, and they showed cardiovascular benefit as well in terms of overall cardiovascular 4-point MACE benefit, as well as heart failure benefit, and also CKD progression, which not only included reduction in albuminuria, but also in progression of CKD. And very importantly, when they did this fidelity, which included both these studies together, they added another endpoint, that is 50. They included 40% reduction in GFR. Here they included 57%. Why they included 57%? 57% is correlated with doubling of creatinine. So that was also significant. Actually, that benefit was even better. And if you look at the comparable studies with Credence, which included canagliflozin, which was similar. Why I'm mentioning Credence? Because they also included only diabetes subjects. It was almost, they had about more than 30% reduction. Here it was about 24-25% reduction, but only when they included together, and 57% reduction in GFR points.
So that sounds great. We have a molecule which can protect both the kidneys and also the heart, at least from the heart failure perspective. So I don't want to be unfair to Dr. Shubir Roy, but I don't know whether you would consider it as an unfair question. Can we compare in terms of nephroprotection the age-old ACE inhibitor ARB and Finrenone?
Well, I mean, we should not blame our parents just because they had less money than we have. Okay, so the thing is, ACE inhibitors and ARB, they're forming the base on which Finrenone is working. So if I compare, if I have to be very scientifically fair, if we look at the ARB ACE inhibitors renal outcomes trial, the RCTs, there is gross heterogeneity in the trial outcomes. Not one trial was similar looking to other trial. You take it as IDNT or renal trial or the Ramipril, DAB, HiCAT trial, whatever. So if I give you just a bottom line, there's a meta-analysis which came out a few years back of probably 20, 30 ARB ACE inhibitor studies on kidney. They said that on an average they are good. They are very impressive reduction of the renal outcomes. That includes the doubling of the serum creatinine or fall of eGFR by more than 50% or improvement of albuminuria. They did not find any gross benefit in terms of overall mortality, but the renal parameters are okay. If I zoom back to Finrenone, both Figaro and Fidelio, these two trials were on patients who are on maximum tolerated dose of ACE inhibitors or ARB, but on top of that, they showed extra 20% benefit in the renal endpoints. So they are basically doing some add-up job. And if I think about the gaps that Finrenone it might fill up, is basically one phenomena called aldosterone breakthrough phenomena, if you know about it. That if you give a person ARBs or S inhibitors after a year or so, the aldosterone level goes up and the protection by ARB and S inhibitors goes down a little bit. There are many hypotheses regarding it. I will not bore you with that, but that fizzles out the renoprotection of ARB and S inhibitors after a year or so. Whether it has got any long-term impact on the renal outcome, we do not know. We yet pinpoint on that, but probably it is due to some local aggregation of aldosterone, which happens in diabetic patients, and phenidone can probably fill up the gap. So I would rather see these two molecules or these two groups as complementary to each other, and I would like to use both of them if I can. So I will not put them against each other. I would rather put them together.
Excellent, and diplomatic as well, but that's practical actually. And can I ask a similar question to Dr. Kollan Gangopadhyay in relation to SGLT2 inhibitors? They already raised the issue of credence. So what do you think?
Okay, so maybe I'll not be diplomatic here. I think SGLT2, because it has got host of other benefits, pleiotropic benefits, reduction of HbA1c, weight loss, CVOT, and also renal as well. So I think it therefore scores over finerenone. Now, if you have to just focus on the renal aspect as well, so we don't have any head-to-head studies yet. The fidelity study has shown that whether you are on SGLT2 inhibitor or not on SGLT2 inhibitor, the efficacy of finerenone remains the same. So we don't have head-to-head data. There is a network meta-analysis, a large study, which showed that SGLT2 seemed to do better as compared to finerenone. But I think there was one question from a delegate asked once. I was a bit flummoxed by that. So he said that, why do we have to keep checking urine ACR when you can't do anything about it? So patient is on ACRB, patient is on SGLT2 inhibitor. Why you check? Also, if you have urine ACR is raised, will be more aggressive. What more aggressive? Blood pressure target will be the same. Statin target, patient is hypertensive. Statin target will be the same. So what more? So I think here now we have probably have the answer that there is a big population of patients still in need of something to prevent their renal demise or worsening of their renal function. So the big population. So I think to me, I now check the urine ACR with a bit more gusto now that yes, I can do something about it on top of SGLT2 inhibitor. So for my patients, they will have to be on RAS, and if there are no contraindications, they have to be on SGLT2 inhibitor. Still, I find a big chunk of patients need of something else, and then is where I add the finerenone.
Thank you. That's quite clear. So, Dr. Sujoy Majumdar, these mega studies, trials are on diabetic kidney disease. Is there any evidence in non-diabetic chronic kidney disease?
Answer till date is no, but can I have the slide please now? There has actually been a host of trials going on the other, so we kindly have a look at it. So this particular study, I'm sorry, you have to turn around.
Go ahead, no.
So basically this shows a host of plethora of other conditions where finerenone has been tried and been used. But as you can see, in fact, this answer to this question is this FIND-CKD trial, which is going on non-diabetic kidney disease. And the first results are expected sometimes in January 2026. It has been tried in type 1 diabetes. This is a FIND-1 study. And we have got other studies coming up right now. And this is the study that I was talking about. Which one is that?
You said FIND-CKD?
Finality. No, not that one. This finality, I think this is the one which has been using...
Heart failure.
Yeah, in heart failure patients, where they've used a combination of SGLT2 and finerenone. So basically, these are a host of studies which are going on right now at the moment. And to get the final answer, we're having a lot of discussion today. Which one do you start first? Do you start with finerenone? Do you start with SGLT2? All these answers will be coming by 2027. And only after that, we can arrive at a definitive conclusion which one to use. But till now, as I mentioned, the guidelines suggest that you start with ARBs, add the SGLT2 inhibitors, and then move on to Finrenon for that big chunk of risk.
Not without SGLT2.
No, with SGLT2.
So, ACE, ARB in diabetic kidney disease, then you would be using
SGLT2.
SGLT2,
and then to Finrenon.
Okay, fine, fair.
Yeah, and the reason is very simple, because in diabetic kidney disease, SGLT2 has got another additional benefit, that is the glucose lowering, which would not be a major factor in a non-diabetic kidney disease. And there have been some, as I mentioned, there have been some anecdotal studies which have shown that when they're used in combination, SGLT2 and Finrenon, the results are better. These are smaller studies which have been done, which have shown rather than when you're giving them sequentially.
When do we wind up, Indrajit? At 6 itself? 2 minutes from now? Okay. So, the Mallo? Yeah, so we have already said, anyone has a question, please stand up, shoot it. Otherwise, yes. I think we need other people to ask questions. You will come later. Yeah. Demallo. So, we have understood that it's relatively safe, but are there adverse effects? What should we be concerned with? And how do we start? What dose?
So, first of all, with regards to starting, as we have already discussed, with regards to if the GFR is between, we require 3 criteria with this molecule. GFR has to be more than 25, the potassium has to be less than 4.8, and the ACR has to be at least more than 30. Now, if the GFR is between 25 to 60, you start with 10 milligram, and then you can actually look at the potassium levels, and you can actually, if it is less than 5, you can actually up titrate after a month to 20. Whereas if the GFR is more than 60, you can directly start with a 20 milligram dose. I would be just explaining shortly why we do that. Secondly, with regards to the side effects, we have already heard it doesn't have a significant effect with regards to gynecomastia, which is very important, because I would talk about hyperkalemia just a little bit later, is that there is a initial drop in GFR. There is no increased incidence of AKI with these molecules, but there is an initial drop in GFR about 4 ml, 4 units of GFR early on, which occurs within the first 3 to 4 months, but that stabilizes over a year, and after a year, there is actually a reduction in GFR progression slope. So that is something we need to be careful. If the GFR, because a lot of patients come back and tell us the creatinine has gone up a little bit, so that we have to reassure them, unless it has gone up significantly more, that this occurs early on, but it is going to stabilize long term. So that's very important, but there is no increased risk of AKI. Finally, the most important thing which we are worried about as clinicians is hyperkalemia. So again, if you look at hyperkalemia, the episodes of hyperkalemia is about, what was seen in the studies was about 14% in CKD, whereas it was 7% with placebo. Hyperkalemia deaths were not there in any of the whole 2 studies. No hyperkalemia related death. Hyperkalemia related discontinuation of therapy was about 1.7%. So that's meager, very small, which was about 0.6% with placebo as well. So that's very important. So not significant, but there are some important patients where we must be careful, especially those who have significant albuminuria, those who have lower GFR, those who are on beta blockers are at a higher risk of hyperkalemia. So in those subset of patients, we need to be careful, and that's why when we are using a dose of 20 milligram, we do not start when the GFR is less than 60, because the risk of hyperkalemia is higher. We start with a lower dose. Once we have it, we need to check after 1 month, then after every 4 months. If the GFR is more than 5.5, we need to stop and recheck. Again, if it's below 5, we can start. Otherwise, we need, and whenever we start, we need to start at a lower dose. So first month, you need to do a potassium, and again after 4 months, every 4 months, we need to recheck the potassium levels.
Can I ask a question on this? So it's all very nice theoretically. Yeah? Come to clinics. I start on a patient with eGFR, let's say 35. Potassium was, it has to be below 4.8 to start. So potassium was 4.6. I started. Now you're saying repeat at 4 weeks, right? Not at 2 weeks.
No, that's the recommendation. I'm going by my recommendation.
This is again a big question.
I'm asking, what would you do? Would you do 2 weeks or 4 weeks?
Well, I generally do
You
it
said
at
2 weeks, once or 2 weeks?
The recommendation is 4 weeks. I do it at 2 weeks, but what I have seen, I don't remember the exact paper, is that to have a significant, why they recommend, that is also you wanted to know, why they recommend at 4 weeks, not at 2 weeks, because I will feel safer, because I also do it at 2 weeks. But actually the hyperkalemia, because of the tissue distribution, takes about 4 weeks, 3 to 4 weeks to stabilize. So the maximum level of hyperkalemia which you are going to get is 4 weeks. So we may, again we need to do it at 4 weeks, so we may miss that hyperkalemia.
So my question is, suppose it's 5.8, you will stop.
Yeah.
Now the guidelines say, gung-ho, repeat again and restart. In your day-to-day practice, EGFR 35, one episode of potassium 5.8 or 5.9, would you have the guts to restart it?
I have seen about 10%, not even 10, 7-8% of my patients probably will develop high potassium, but in majority I do not start. I do not start.
So that's his viewpoint.
Because hyperkalemia is something where I would not be very comfortable
especially
to start. So this is my personal preference, which is not according to guidelines. I accept it, but I do not start in majority of my patients, those who develop a significant potassium levels, which is more than 5, at least 5.2.
JJ, if I may add one word here. In my clinical practice, majority of the patients who are started on Finrenon, not majority, I should say 100% patients who are started on Finrenon have already been on SGLT2 inhibitors. And there has been data that a combination of SGLT2...
That's not my question.
Yeah.
SGLT2 can reduce hyperkalemia, I understand.
The answer...
What happens if it's 5.8? Will you have the guts to restart?
Can I just tell you
if it's 5.8, obviously you have to stop it then.
Then will you start?
It's very scary. It's very scary, to be very honest.
It's very scary, yeah.
I had a patient yesterday who was on Carendia, and the Lal Path lab potassium was, she was already 10 milligram minute. When I started, it was 4.3, so I started 10 milligram. I said, okay, fine, I'll push it up. And she came with yesterday with a Lal Path potassium lab value of 5.78. So I was sort of scared shit, to be very honest with you. So I said, you stop it, you check it today in Apollo. So she came back, it's normal. Many a times the patients, they give blood sample at home.
Hemolyzed.
It's all hemolyzed.
I understand all that, but this HAPA...
Yes, it's scary. We have to recheck it.
So this HAPA of doing this potassium is a bloody big HAPA.
I agree, but generally I would very well go with his opinion, because in a majority of my patients, I have seen the potassium actually coming back normal when we recheck.
Absolutely.
Because it's actually hemolyzed.
Panelist is easy said than done.
Obviously, if it is 20 milligram, I would later have the courage to restart at a lower dose of 10. But if the hyperkalemia occurs with a 10 milligram dose, generally I do not start.
Thank you very much. Any other questions? Quick ones. Yes.
We get diverse kind of blood pressure. Habitual hypotension is very common in our clinic. Actually, in periphery, we get very much amount of patient with kind of habitual hypotension.
Your question is?
So, is the Finrenon is the answer for organ transplant for that kind of patient, bypassing the benefit of ACI or SGLT?
So no one says that it should be without ACE-ARB on top of ACE-ARB, but the point possibly, Kollan, would you take it as to why is it not a good antihypertensive as well?
So I think we can look at it both ways. So lowering blood pressure is good, but again, a substantial proportion of patients may have quite lowish blood pressure. And here, of whatever patients I have started on, I have not seen any change in the blood pressure. So which is good in a way that you know that it does not interfere. So if a patient has got blood pressure of say 104 by 70,
90 by 58.
So that limits your use of these inhibitors, or that limits the use of spironolactone, because spironolactone can be very unpredictable. Some patients might drop blood pressure quite precipitously. So in those patients, I think this you can consider as a good effect, or lack of blood pressure lowering effect might be a good point to have.
is delaying.
So only thing is that the trial showed that there was about 3 to 4 millimeter lowering of mercury. But there are some data which suggests that most of these patients had controlled hypertension. And if you look at the trials, they had perfectly controlled hypertension. So there was no scope of further reduction, not much of a scope. But in some trials, it has been shown those who had some raised higher blood pressure, there was more significant lowering of blood pressure. So probably the jury is still out. We still need to do studies to see how far the blood pressure lowering effect is there.
Thank you. I think we had a, sorry?
Yeah, and the final thing is that Finrenon is not used as an antihypertensive. So I think BP reduction, though it's there, I agree, in the studies is there. But it's practically of no significance.
Right. So we learnt about a great molecule which has shown its mettle in diabetic kidney disease, both in terms of renal protection as well as reduction of heart failure. When used on top of ACE inhibitor or ARB, it is relatively safer compared to other mineralocorticoid receptor antagonists in relation to hyperkalemia, but the risk is there. So we need to monitor potassium even in this condition. So with these few words, I'd like to thank profusely our panelists who made it worthwhile, this session. Dr. Shubir Roy, Dr. Demallo Sannal, Dr. Sujoy Mujumdar, Dr. Kullan Gangopadhyay, and also all of you for chipping in with your interesting comments, including Bayer Medical team. Thank you for helping us out. Over to the organizers.
Thank you, sir. Sir, stay back there, sir. Only few minutes, sir. Thank you, Big Six, sir, that session. So we have our small token of love from our organization, from the organizing committee, to Professor Dr. Shubhankar Chaudhuri, to Professor Dr. Demallo Sannal, to Dr. Subir Rai, Dr. Sujoy Mujumdar, and Dr. Kullan Kumar Gangopadhyay. Thank you, sirs, from our organization, from our organizing committee, for the fantastic session. Thank you, thank you. So, thank you. We are moving forward to our next segment, the climax part, that is the slog awards. So we are inviting our two chairpersons for this session, our very own, our Vice President, Dr. Meriti Cruz, and our Assistant Secretary, Dr. Rakesh Kumar. Both are the Joint Organizing Secretary of this Daycon 2023. So, please, Didi. Now, the session over to you.
To begin this last session, I'd like to call Dr. Shomik Goswami, who will be speaking on diabetes and thyroid disease, the missing link. Doctor is a faculty at Department of Endocrinology, NRS Medical College, treasurer of the Endocrine Society of Bengal, and has more than 78 publications in peer-reviewed journals.
Thank you. So a very good evening to all of you. I have been given a task which is very difficult, if not almost impossible, because if I talk about something which is missing, the missing link, it no longer remains missing. So I am in a philosophical paradox, but jokes apart, I'll try to look at the existing links between thyroid disease and diabetes, and the look for this existing link actually began more than a century ago with Van Nooden's work, who said that diabetes and thyroid are related, metabolism rather is related in a broader sense. Thyroid sort of fires the metabolism in the human system. There were people who were more adventurous. They removed the pancreas, removed the thyroid. Removing the pancreas caused diabetes, lead to albuminuria. removing the thyroid made them hypothyroid, reducing albuminuria. And of course, therapeutic trials also started over a century ago, where administration of erstwhile thyroid extracts led to a reduction in liver glycogen. Now, if we go beyond these historical studies, if we look at the recent evidence, we know about the link between diabetes and thyroid much more intricately. We have epidemiological studies which have shown that both of them are closely related to each other. As physicians, as endocrinologists, we know that these are the diseases which give us our bread and butter. Patients with diabetes have both increased hypothyroidism as well as hyperthyroidism. And in individuals with type 1 diabetes, up to 1/3 of them might have autoimmune thyroid disease. And if you look at the prevalence compared to the normal population, it's highest in females with type 1 diabetes. Now, when type 1 diabetic individuals develop autoimmune thyroid disease, it's usually of earlier onset and of more aggressive course. We know that thyroid disease has a predominant autoimmune etiology, be it hypothyroidism, be it hyperthyroidism. Type 1 diabetes is also an autoimmune disease, and there are 4 predominant genes which sort of regulate the T cell function and are the connecting links between autoimmune thyroid disease and type 1 diabetes. Both autoimmune thyroid disease and type 1 diabetes might exist in a syndrome called autoimmune polyendocrine syndromes, type 1, type 2, as well as type 3. Both of them may coexist in patients with Down syndrome and congenital rubella, the exact reason not known why they coexist in these situations. And of course, the other part is also true. If you look at the vice versa part of the story, patients with thyroid dysfunction have an increased incidence of both type 1 diabetes as well as type 2 diabetes. Now, if you want to delve even deeper into the topic, interestingly, the HNF1 alpha gene responsible for maturity onset diabetes of young 3, MODY3, and the HNF1 beta gene responsible for MODY5 have a relationship in the pathogenesis of papillary cancer of the thyroid and anaplastic cancer of the thyroid. Again, these papers have delved deep into the topic. This is just for our general information. Now, do these diseases, the thyroid disease and diabetes, they are very common, they coexist very commonly, but do they coexist as friends side by side, or do they sort of influence each other's function? To look at whether they influence each other's function, let us look at normal physiology. What do the thyroid hormones do to metabolism? If you look at it broadly, thyroid hormones have an antagonistic role to insulin at the level of the liver. They increase the hepatic glucose output. They have a synergistic effect with insulin at the level of the muscles. They increase glucose uptake in the muscles. They increase intestinal glucose absorption, and they improve beta cell function. So there are certain functions which increase blood glucose, certain functions which decrease blood glucose. In a state of health, there is euglycemia with euthyroidism. The moment things go wrong, too much of anything is bad. Similarly, when you have too much of thyroid hormones, the hepatic glucose output increases to a very big extent, intestinal glucose absorption increases to a very big extent, and instead of helping beta cell function, it might actually lead to apoptosis of the beta cells. Yes, there is some increase in peripheral glucose uptake, but hepatic glucose output, beta cell dysfunction, intestinal glucose absorption results in a net hyperglycemia at the end of the day. And again, if you wish to delve deeper into the topic, too much of thyroid hormones interfere with proper synthesis of insulin, lead to increased degradation of insulin, upregulate the GLUT2 receptors in the liver, which throw out glucose from the liver into the circulation. They increase the counter-regulatory hormones. There is too much of glucose in the periphery, undergoes non-oxidative metabolism to form lactate, which again acts as a substrate for gluconeogenesis. All in all, the net result being that hyperthyroidism leads to increased blood glucose levels and might even precipitate ketoacidosis in patients with type 1 diabetes. However, if you did not have diabetes to begin with, hyperthyroidism might lead to a dysglycemia only in 2 to 3% of population, not more than that. If you look at the symptoms of hyperthyroidism, they might mimic both hypoglycemia and hyperglycemia. You think of palpitation, tremors, anxiety, sweating, it looks like hypoglycemia. You think of weight loss, fatigability, increased appetite, it looks like uncontrolled hyperglycemia. The result being that often the diagnosis of diabetes might be delayed if you don't have a high index of suspicion. You might attribute the symptoms to hyperthyroidism per se. We know that hyperthyroidism leads to atrial fibrillation, leads to heart failure. Again, these conditions are common in diabetes as well, so if they coexist, the risk of having a sudden cardiac death or hospitalization for heart failure might actually go up. Now, if you look at the other side of the story, the metabolic effects will just be the reverse. Hypothyroidism, you have decreased intestinal glucose absorption, decreased hepatic glucose output, you have decreased uptake of glucose in the peripheral tissue. The net result here again is sort of a glucose lowering effect. So hypothyroid individuals actually have increased insulin secretion in response to a given amount of glucose. They have decreased insulin degradation. So if you have type 1 diabetes or if you have panhypopituitarism, where the risk of hypoglycemia is somewhat higher, particularly if you are very elderly or if you are a small child, hypothyroidism might precipitate hypoglycemia in these situations. Hypothyroidism is associated with diastolic hypertension, dyslipidemia, which in turn increases the risk of cardiovascular disease. Patients with hypothyroidism and diabetes have early onset of diabetic kidney disease, quicker progression of diabetic kidney disease, increased mortality from diabetic kidney disease, as well as increased frequency and severity of retinopathy as well. Interestingly, if you have deiodinase 2 polymorphism, in the present days we are talking of the role of liothyronine LT3 and deiodinase polymorphisms. Now the deiodinase 2 converts T4 to T3 in the periphery, and T3 is necessary for upregulation of glucose transporters in the skeletal muscle. So if you have a deiodinase polymorphism, you have less glucose transporters, you have peripheral insulin resistance, and you have worse blood glucose levels. Now it's not only that these two diseases interfere with each other in terms of the metabolic effects, even in terms of monitoring there could be a change. And about a decade or more back, our team at SSKM Hospital, we were students learning endocrinology at that time, we did a research where we tried to look at the effects of hypothyroidism and hyperthyroidism on HbA1c. What we found was that individuals with hypothyroidism had elevated HbA1c levels compared to euthyroid individuals or hyperthyroid individuals. If you corrected hypothyroidism, the HbA1c level came back to euthyroid levels. However, correcting hyperthyroidism had no significant effect on the HbA1c level. So the take-home message is that if you have untreated hypothyroidism, it could lead to a false elevation of HbA1c. It could lead to misdiagnosis or overdiagnosis of prediabetes or diabetes, or it could lead to a wrong intensification of glycemic control, wrong intensification of therapy in a patient who is at good glycemic control. If you look deeper into the effects of diabetes on thyroid dysfunction, uncontrolled diabetes, uncontrolled hyperglycemia causes a sick euthyroid syndrome-like state where the T3 levels are low. In severe cases, the TSH levels could be low as well. Individuals with uncontrolled diabetes have an increased risk of thyroid-associated ophthalmopathy and a worse prognosis from the condition. Insulin resistance, obesity leads to increased size of the thyroid gland, increased number and size of thyroid nodules. And we know that if you have pre-existing diabetes, particularly if you have diabetic retinopathy, that's a strict contraindication to external radiotherapy to the orbit in patients with Graves' ophthalmopathy or thyroid-associated ophthalmopathy. Looking at the other side of the coin, we know that untreated hypothyroid individuals have dyslipidemia. So if you have coexistent thyroid dysfunction, hypothyroid disease, hypothyroidism, and dyslipidemia, you correct with levothyroxine and repeat the lipid profile before deciding on the dose of statin. As we said earlier, hypothyroid individuals have reduction in insulin requirement because insulin degradation is lowered. The moment you treat hypothyroidism, insulin requirement might go up. Treating uncontrolled hyperthyroidism might require a reduction in the insulin dose, and there's a rare but interesting phenomena called Hirata disease, where when you treat a hyperthyroid individual with methimazole or carbimazole, it might precipitate the formation of antibodies to insulin and lead to spontaneous hypoglycemia. It's rare, but it's something which is pretty interesting and should be taken note of. The effect of diabetes treatment on coexisting on thyroid disease is much more, I would say, prominent. Most importantly, if you have uncontrolled diabetes, levothyroxine supplementation is not going to give you good symptomatic benefit, so you need to control diabetes well. Metformin has a big effect on the thyroid. Use of metformin has shown to reduce the size of thyroid nodules by up to 50%. Use of metformin in hypothyroid individuals reduces the TSH level without any effect on the T3 and the T4 level, and it's reversible. The moment you stop metformin, the TSH level goes up a bit. It shows that metformin, by crossing the blood-brain barrier, directly acts at the level of the hypothalamus pituitary to reduce the TSH levels rather than acting through the T3 or the T4 levels. Metformin, interestingly, has also shown pro-apoptotic and anti-proliferative effect in papillary thyroid cancer and medullary thyroid cancer, but these have been done mostly in preclinical models. Pioglitazone is something which can significantly increase and worsen thyroid-associated ophthalmopathy. Pioglitazone increases the expression of TSH receptors in the orbit. It converts the orbital fibroblasts to adipocytes and leads to worsening of thyroid-associated ophthalmopathy. And the bad news is that this worsening might be irreversible. Stopping pioglitazone might not reverse the problem. So if you have coexisting thyroid-associated ophthalmopathy, try to avoid pioglitazone as far as possible. We know that individuals with hypothyroidism often have myopathy when statins are used. Hypothyroidism leads to mitochondrial dysfunction. Diabetes leads to mitochondrial dysfunction, increases the risk of statin-associated myopathy. So correct hypothyroidism before starting statins with coexistent diabetes. Now, GLP-1 receptor agonists and the risk of MCT, I think in humans and in primates in general, this risk is clinically non-existent. A brief word on screening for thyroid dysfunction in type 1 and type 2 diabetes. In type 1 diabetes, we do have some guidelines which suggest that test for thyroid function as quickly as possible after the diagnosis of type 1 diabetes, with the caveat that the blood glucose should be reasonably controlled, because if the blood glucose is very high, it might lead to a false lowering of the T3 and the TSH level, like a sick euthyroid syndrome-like state. Screen at diagnosis, screen every 1 to 2 years, 1 year, every 1 year if anti-TPO antibodies are elevated. You can screen at even more frequent intervals when you suspect that there is something wrong with thyroid function. For example, there's a thyromegaly, there's a change in the growth rate, the patient develops symptoms suggestive of thyroid dysfunction, or there's an unexplained glycemic variation. In type 2 diabetes, we don't have very specific guidelines telling us when to check. The American Thyroid Association tells that if you develop type 2 diabetes, you need to check it immediately after diagnosis and controlling the blood glucose, and every 5 years thereafter. The American Diabetes Association earlier used to say that if you are over 50 years of age and have diabetes, you need to check at baseline and every 5 years. If you have dyslipidemia with diabetes, you need to check for thyroid function, but over the last couple of years, the guidelines have been silent about testing for thyroid dysfunction in diabetes. My personal take would be, given the common association between these conditions, immediately after diagnosis, every 5 years, particularly if you have dyslipidemia or a goiter, I would suggest testing for at least a TSH level. So my final message after spending the last 20 minutes looking at the existing links instead of the missing links would be that yes, they do coexist with each other, particularly if you have type 1 diabetes. Up to 1/3 of individuals might have coexistent autoimmune thyroid disease. The net effect of hyperthyroidism is to increase blood glucose. The net effect of hypothyroidism is to decrease blood glucose. Clinically relevant fact is that if you have untreated hypothyroidism, you have a false elevation of HbA1c levels. So treat hypothyroidism and repeat the HbA1c before jumping to a conclusion. Metformin reduces the size of thyroid nodule. Pioglitazone leads to worsening of thyroid-associated ophthalmopathy. So you have to be careful on that count. And of course, screening should be individualized. You should have a very low threshold in type 1 diabetes and sort of a medium threshold in type 2 diabetes to look for thyroid dysfunction. So with that, I put an end to my part of the lecture and hand it over to the chairpersons. Thank you.
Thank you so much, Dr. Shomik. It was really interesting to see all the links that you have provided to us. We'll have the question answer after the speakers have all spoken. I'd now like to call Dr. J.J. Mukherjee, who will be speaking on beyond glucocentric diabetes management. Are all GLP-1 RAs similar? Dr. J.J. Mukherjee is a senior consultant in the Department of Medicine, Diabetes and Endocrinology at Apollo Multispeciality Hospital and has more than 64 publications in high-impact peer-reviewed journals, 20 chapters in various textbooks, including Thyroid Homeostasis in the Oxford Desk Reference, editor of Handbook of Managing Diabetes and Endocrine Conditions, a case-based comprehensive approach, an associate editor of Diapedia, associate editor of Journal of Neuroendocrinology. Yes.
Thank you. Thanks to Dr. Suja Majumdar for giving me this opportunity. The topic is a bit esoteric, I think. Beyond glucocentric diabetes management, are all GLP-1 receptor agonists similar? So before we talk about that, we don't have many people around here, but this is what we do in real life. We only get glycemic control in 1/3 of our type 2 diabetic patients. So giving a GLP-1 is not going to make a huge difference. So this is a cornerstone of managing type 2 diabetes. Drugs come quite late actually, and we are always talk about glycemic control. This always has to happen. We're talking today about glycemic control, but please remember blood pressure, lipids, weight management, getting them off smoking, focusing on prevention of complications, and the doctor is only 1/4 in the management of type 2 diabetes, and GLP-1 probably would be 1/20th in the management of type 2 diabetes. No matter you give how much expensive GLP-1 receptor molecule you want, if the patient doesn't control diet, doesn't exercise, doesn't monitor blood sugars, and it's all a waste. Now, there are a lot of GLP-1 receptor agonists available. There are two basically backbones. One is the exenatide backbone, the other one is the human GLP-1 backbone. We have exenatide, which is available in India, but I don't know which company is marketing. Exenatide once weekly is not available to us. F-exenatide is not even approved in US or UK. Lixasenatide came to India. I met reps for a while, but I don't know where they've now disappeared. I don't think any of us are using lixasenatide. On this side, you have liraglutide, which many of us used in the beginning, and we still have a couple of patients who are continuing on liraglutide, those who are die-hard fans of liraglutide. And then albiglutide is not even available anywhere else in the world because it was withdrawn in 2017. Dulaglutide is available, and semaglutide oral is available in India. The green tick is what's available in India. And subcut semaglutide, which is a big seller in the Western world, is not available to us. GLP-1 has got multitude of functions. It's not only acting on the pancreas and helping you manage diabetes, has an action on gastrointestinal tract. It's got a huge bit of action on the heart. It reduces blood pressure, increases myocardial contractility, but this was the very interesting point, and still an interesting point. It increases the heart rate. All of them increase the heart rate by 2 to 5 beats per minute. It acts on the brain, decreases appetite, increases satiety, muscle, and of course the kidney. The kidney aspects of GLP-1 receptor agonists are quite a big topic of interest as of now. What are the currently marketed GLP-1 receptor agonists? This is the whole list. As you can see, Tirzepatide you can forget, that's a twin incretin. This is the latest what's available in October 2023. And if you see the green ticks, those are the ones what's available in India. Oh, the arrow doesn't come there, so no point working so hard on the arrow. So exenatide once weekly, liraglutide, dulaglutide, lixisenatide, albiglutide, semaglutide, and semaglutide oral. I have not added F-pliclinatide here because that's not approved as yet for use in clinical practice. And these are the 5, which is it's an irony. Then in India, patients can't afford GLP-1 receptor agonists, but we have most of them approved in our country. Exenatide, liraglutide, dulaglutide, lixisenatide, and semaglutide oral, they're all approved, they're all available. In fact, you'll be surprised to know that semaglutide 2.4 milligrams is also approved by DCGI, but it's not available for use in our country. Now, they can be divided as short-acting and long-acting. Short-actings are basically exenatide and lixisenatide, both available in India. The longer-acting, liraglutide, dulaglutide, and semaglutide oral. So these 5 are available to us. Now, if you take the glycemic efficacy, most probably, leaving the shorter-acting GLP-1 receptor agonists, exenatide and lixisenatide, the medium or longer-acting GLP-1 receptor agonists, most of them almost have similar glycemic efficacy, except maybe semaglutide 1.0 milligram subcut, which is not available to us. So this was the brief beyond glucocentric management, weight loss. Now this is the weight loss seen by all the GLP-1 receptor agonists. You don't need to see this slide in great detail, just to show that you can get as little as 0.6 kilograms to as much as 6.5 kilograms. So I've picked out the ones which are not available to us. So what's available to us on the left side, if you see, liraglutide being compared with exenatide, and if you see the weight loss is statistically significantly slightly better with liraglutide. If you take the next one, Award 1 trial, dulaglutide plus exenatide, weight loss is slightly more with dulaglutide. Dula and lira, I think they're almost same, even though statistically liraglutide, even that 700 gram excess weight loss was statistically significantly better. What stands out here is semaglutide. Semaglutide definitely, if you use in a type 2 diabetic patient, it not only gives you slightly better glycemic control, the weight loss also is more as compared to the other GLP-1 receptor agonists. What about the cardiovascular outcomes? Again, don't need to focus on this slide in too much detail. This is the latest publication, which has come in Lancet Diabetes and Endocrinology. I think you can take a picture slide and go home and read this paper in great detail. The amount of material in this paper is equivalent to 2 hours of discussion and talk, so we won't focus too much on that. Suffice to say that if you take 3-point MACE, that is not the positive effect. If you see the confidence interval, both, not 4 of them, leader, which is liraglutide, sustain 6, which is injectable semaglutide, and rewind, which is dulaglutide. And amplitude O I will not discuss much, that is the F-pliclinatide, which is not available. If you come to cardiovascular death, only 2 of them give cardiovascular death benefit. One is liraglutide, the other one is semaglutide oral. Both are available to us. If you come to myocardial infarction, only 1 molecule gives myocardial infarction benefit, which is again not marketed, not available. Coming to stroke, the only GLP-1 receptor agonist which provides benefit with regards to stroke is dulaglutide. What about renal outcomes? Now, as opposed to SGLT2 inhibitors, the renal outcomes with GLP-1 receptor agonist is not that strong. Not much evidence is available. If you take the leader trial, if you take leader is liraglutide, sustain 6 is semaglutide 1.0 injectable, rewind, which is dulaglutide. I won't again discuss amplitude O. All of them had an effect on the composite kidney outcome, including macroalbuminuria. All of them are basically secondary analysis. Primary outcome, renal, with GLP-1 receptor agonist, trials are still awaited. If you see worsening of renal function, that data is not available with semaglutide. Only dulaglutide showed the benefit with regards to worsening of renal outcome. Next comes to adherence to therapy. Now, I think all of you know that when you prescribe a drug, you'll be surprised to know that only 35% of your patients are taking the drug for more than 1 year. So next time when you write a huge prescription, which I have written today for many patients, of 10 to 12 drugs, I'm 100% sure that of those 12 drugs, they will be only taking 5 or 6. So on top of that, you give a very expensive molecule like GLP-1. Not all of them are taking it. Why? Because there are so many other issues, like as to what is the ease of administration of the molecule, what is the frequency of administration, and changes to current lifestyle. So if you take dulaglutide is once weekly injection. So that disrupts my lifestyle the least, and it has got nothing to do with before food, after food, etc. So there's not much change to my current lifestyle. It's patient friendly, except that it's a injectable. Liraglutide is a daily injectable, and liraglutide, the needle is visible. Coming to oral semaglutide, yes, certainly, frequency of, it's not an injectable, so that's a big plus point, but the minus point is you have to take it almost daily, and there are particular ways of taking it. So if you come to adherence, which I think is very important, the reason why most of our type 2 diabetic patients don't achieve glycemic goal is probably, one of the reasons is they're not adherent, not persistent with their therapy. So this is a real world study from US comparing Dula versus Lira and Dula versus exenatide once weekly, and you don't need to see the numbers in detail. Basically, the adherence was better with dulaglutide. This is a very nice study. This, thanks to Sujoy, I read up. I didn't know this study existed. It's called a revised study. Revised study was basically the two molecules, dulaglutide versus oral semaglutide. These patients, I think there were 300 or 400 odd people. Before starting, they were given the option that would you choose a weekly injectable or would you choose a daily oral one? And if you see on the left-hand side, the initial preference, 3/4 said we'll take an oral medication. Then they were shown the videos of how to take semaglutide. First thing in the morning, empty stomach, have to take it with 120 ml of water, have to remain empty stomach for 30 minutes. And then they showed the video of taking dulaglutide, which is once a week injection. And we all know the pen, those of who have used dulaglutide. And then the preference changed. It almost became 50-50, whether they want to take dulaglutide or semaglutide. So weight loss, as I said, sema-injectable does better. Sema-oral also does better than dulaglutide. Cardiovascular outcomes, subcut sema has data. Oral sema still does not have a 3P MACE data. The STAT trial is still ongoing. Renal outcomes, dulaglutide has got better data than semaglutide. Adherence to therapy, Dula has got better data than semaglutide. So coming to administration, these are the various pen devices. And as you all know, the pen for dulaglutide is much more user-friendly than the other pens. Coming to adverse events are the same. No matter whichever GLP-1 receptor agonist you are using, whether using dulaglutide or oral semaglutide or subcut semaglutide, the side effects are primarily GI. The same, except one molecule which is not available, albiglutide. Albiglutide is a weaker GLP-1 receptor agonist, and that had lesser adverse events, but it's a moot point because I don't think any company is going to market that drug anymore. So in conclusion, GLP-1 receptors available in India. I'm not talking about the shorter actings. I'm not talking about exenatide or lixisenatide. Though they are available, they are not used. I don't think any of us in this room are using those. So I think we are using liraglutide, dulaglutide, and oral semaglutide, of which I think the use of liraglutide has gone down. I don't know how many of you have patients on liraglutide still, a substantial chunk of patients. So basically, most of us are left with the choice of choosing either dulaglutide or oral semaglutide in the very few patients who agree to take a GLP-1 receptor agonist because of cost constraints. Having said that, we have some patients who are agreeable to take. Then you need to decide whether you're going to prescribe dulaglutide and oral semaglutide. One thing which I think as doctors we should do, which we don't do, is we prescribe. We shouldn't. We should give the choice to the patient. We should show them both the options. That's the reason I talked about the revised study. When we think about GLP-1, depending on who's pressurizing, you write the molecule. But I think that's unfair to the patient. I'll share my experience. I offer them both. And what the revised study showed, it's a 50-50 pickup. I mean, half would say I will take weekly dulaglutide, and half would say I will take an oral GLP-1 receptor agonist. So this is the difference, Dula, Lira, and Sema. I think Lira we can stop discussing. So Dula is injectable, oral, Sema is oral. So for a patient for whom injectable versus oral is the big issue, he or she will choose semaglutide. Those with semaglutide, you have to bring it up slowly over 3 months, which at times is a problem. You may lose the patient. I have lost a few patients when I was titrating from 3 to 7 to 14 because probably there are GI side effects and they disappeared. With dulaglutide, it's easy. Now, time required to escalate the dose, as you said, as you see, it's almost 2 months with oral semaglutide, whereas with dulaglutide, only within 2 weeks, you can go up to 1.5 milligrams. Glucose lowering, as I said, is almost similar. Body weight lowering, sema-oral is slightly better than dulaglutide. GI side effects are almost same. So if you take the weight effects in people with type 2 diabetes, this I've already discussed. As I said, the weight loss probably will be slightly better with oral semaglutide as opposed to dulaglutide. So expectations while initiating a GLP-1 receptor agonist. Efficacy-wise, we're not talking because I'm supposed to talk beyond efficacy. So look at the weight loss column. All three which we normally use, dula, oral, sema, and lira, they all cause weight loss. Oral sema probably slightly better than dulaglutide. Cardiovascular benefits with oral semaglutide you still don't have. You don't have a positive 3P MACE outcome with oral semaglutide. What the company has done is they've combined oral sema and injectable 1 milligram semaglutide, and they've come up with a meta-analysis, which probably is okay, probably not, it's not okay. We need to wait for the proper randomized controlled trial of cardiovascular outcome trial with oral semaglutide. Frequency, dulaglutide wins here, it's once a week, whereas oral semaglutide you have to take daily. Ease of use, now I don't know which is easier, once weekly dulaglutide with that injectable pen device, or an oral medication which you have to take first thing in the morning, empty stomach, they have to be empty stomach for 30 minutes and with a measured amount of water. Oral semaglutide scores, and no need to be taken fasting, which is dulaglutide, you can take any time, whereas semaglutide has got all its issues. So with that, I'm going to stop. DCGI has approved all three, dulaglutide, liraglutide, and oral semaglutide. Oral semaglutide, still the cardiovascular label is missing because, as I said, the trials are not there. Liraglutide, if you see in adults with type 2 diabetes mellitus, an established cardiovascular disease. That's what the leader trial was. Whereas if you take dulaglutide, it's adults with type 2 diabetes who have established cardiovascular disease or with multiple cardiovascular risks, because that's what the REWIND study was. 40% of them had type 2 diabetes with risk factors, whereas in leader trial, all of them had established cardiovascular disease. So in summary, you have 3 molecules to choose from: dulaglutide, liraglutide, or oral semaglutide. Liraglutide, I think most of our patients would now probably not take because it's injectable daily, the needle is long, needle is visible. So choice is between dula and sema. If you want to go by cardiovascular outcome trial data, dula has that, sema injectable has, but sema oral does not have that. Probably they will get it sometime this year or next year when the trial results come out. If you come to ease of administration, it's entirely up to the patient to decide whether he or she wants a weekly injection or he or she wants to avoid an injection and take oral. So I think that was the brief given to me, so I'll stop. Any questions I'll take. Thank you.
Thank you, Dr. J.J. Mukherjee. And that was a very lucid description of the GLP-1 RAs, both oral and injectable. I think we'll take the questions after the...
Ma'am, I will be running off, so
okay.
Any questions?
So if there's any question?
Thank you.
I'd now like to call Dr. Ghanshyam Goyal to speak on nutrition in diabetic foot. Dr. Ghanshyam Goyal does not need an introduction to the audience. He's an expert on foot care problems in diabetes. Slide to the. Doctor is at ILS hospitals and has done pioneering work in foot care in diabetics.
Thank you. Thank you, Sujay and team Day for inviting. And today I'm going to discuss a bit unusual topic. Probably it is not discussed in our in all the CMEs. Nutrition in diabetic foot. Yes, lifestyle modification. So we discuss nutrition in detail, but not in the diabetic foot. So to simply ignore the role of nutrition in wound healing would be to neglect a powerful tool that can be used for our advantage. That is the message I want to just give you. And we all know out of 3, 1 patient is going to develop a diabetic foot lifetime. That is one. As many as half of people with diabetic foot ulcers experience moderate to severe malnutrition, and that malnutrition is tied to a higher risk for amputation in people with foot ulcers, and nutrition intervention could potentially dramatically reduce the risk of amputations. So this is the statement by the David Armstrong. Nutrition is the first thing we think about when visiting a limb preservation program or a wound healing unit, but yes, it is really a crucial one. So what are the challenges? And as I have already mentioned, moderate to severe malnutrition is identified in over half of the patients with DFU. There is no internationally agreed upon standardized definition of malnutrition, neither for protein energy malnutrition nor for micronutrient deficiency in the context of chronic wounds in diabetic foot. So care team, we all know it includes, so all in that foot care team, you also involve one nutritionist or dietitian. That is very important. So nutritional screening and assessment tools. One is the nutritional risk index, and another is the malnutrition universal screening tool, that is MUST, or mini nutritional assessment, MNA. So out of these, you do just simply, one is nutritional risk index, how you will calculate. This is a fixed formula, this is the fixed denominators, 1.519 into serum albumin plus 41.7, these are the fixed denominator, and into present weight divided by usual weight, and if it is more than 100, NRI is more than 100, nutritional risk index, not as the non-resident Indian like the Professor Sujay Majumdar. So it is the NRI, nutritional risk index. So if it is less than 83.5, then it is a severe risk group. Then how you will assess? Initial screening suggests an increased risk for malnutrition, and thorough nutritional assessment should be done after that. So how you will use that? So use multidisciplinary team to identify 6 characteristics of malnutrition. One is declining functional status, fluid accumulation, muscle loss, subcutaneous fat loss, unintentional weight loss, and insufficient energy intakes. About the lab evaluation, A1C, of course, we all know, so I am not going to take that. On the complete blood count, CBC may identify a nutritional anemia. It's microcytic or macrocytic, whatever there. And total lymphocyte count may be a useful index of overall nutritional health, as we all know about this. And if the lymphopenia, it suggests that the nutritional status is bad. And in the microcytic hypochromic anemia or macrocytic anemia, B12 folate deficiency, or albumin albumin levels to be measured. Because albumin's half-life is very long, it's around 3 weeks. So it will take time to decline. But pre-albumin, which is having a short half-life, around 3 days, 2 to 3 days, it will go down very fast. If a patient who is nutritionally deficient, in that situation, if you will measure the pre-albumin, in that situation, you are going to guide earlier and you will start the protein replacement earlier. Then, how to develop and implement a personalized nutritional care plan? So first is focus on the patient, calorie, protein, hydration, micronutrient needs, and then the need for diet modifications, and how then wound healing can be delayed, worsens, or even come to a halt. Factors involved in the healing, proper nutrition is fundamental to healing, and one very important thing which we all miss, and in my practice, whenever a patient of diabetic foot ulcer comes, I usually, to all, without measuring even the vitamin C, the vitamin C levels are not available, I start with 1 gram of vitamin C to all of them, because deficiency of a single nutrient of vitamin C are well known to cause poor wound healing. There are a lot of studies, but of course, these are not validated, and more studies are required to have this importance of vitamin C. Then about the hydration. So hydration is very important in these patients. Try to manage around 1 ml per kilocalorie or around 30 to 35 ml per kilogram of body weight for the healthy individual. Suppose it's 60 kg, then you will require around 2000 ml of water or liquids per day. But we have to be cautious. If it is a heart failure, we have to reduce. If it is a hepatic cirrhosis, we have to reduce. If a renal function is altered or CKD stage 3 or 4, then in that situation, 4 or 5, then you have to reduce the intake of the water. Then about the calories. About the calories, the recommended daily calorie intake is around 2000 for women and 2500 for the men. So always conduct a 24-hour recall, and food frequency questionnaire should be practiced at every visit, and recommended energy take for wound healing is estimated to be 35 kilocalories, not 20 or 25, it's 35 kilocalories in patient with elevated BMI, then it should be 20 to 25 kilocalories. So kilocalorie recommendations are, if BMI less than 30, go for 25 to 3 kilocalorie of actual body weight. And then about the ideal body weight and actual body weight, if it is BMI is more, then you have to reduce the calorie intake. About the macronutrients, we all know carbohydrate, protein and fats, these are the essential food groups, and specific macronutrient needs are high when a patient has a diabetic foot ulcer, especially if the patient is malnourished or is at risk of malnutrition, because the body may be at or close of catabolic risk. Protein intake is essential to provide amino acids for optimized wound healing. Protein requirement, no risk of malnutrition, then it's around 1 gram per kilogram per day, and if at the risk of malnutrition, it is around 1.5 gram of actual body weight or ideal body weight if the patient is obese. During stress or illness, you can go up to the 2 grams per day. In my patient, what I do, I ask them to take the 2 eggs, egg whites, morning, afternoon and at dinner, 6 egg whites a day, because 1 egg white provides around 6 grams of protein. So it's around 36 grams, so like that. So by that, because highly exudating wounds, they exude or like anything, so protein loss is huge in that situation. So about the carbohydrate and fats, both fats and carbohydrates help. I would like to have water. Thank you very much. Sorry. So both fats and carbohydrates help support inflammatory response, cellular activity, angiogenesis and collagen deposition in the proliferative phase of wound healing. Glycemic targets, I think everybody knows since morning we are discussing, so I'm not going to discuss regarding this particular issue. So about the hydroxymethyl butyrate, what is it? It is a metabolite of leucine, an essential amino acid, and can be acquired through both plant and animal foods, decrease the proteolysis, increase the protein synthesis, decrease the apoptosis and increase the cell proliferation. And dose is around 1.5 gram twice a day, it can be used. Then about the arginine, it's a conditional essential amino acid that can be synthesized by the body from the glutamine. And supplemental arginine improve markers of wound healing such as greater protein and hydroxyprolation in the wound bed, enhance T lymphocyte function and promotion of positive nitrogen balance, and dose is around 4.5 gram per day. Then comes the glutamine. So there are 3 amino acids. One is the HMB, hydroxymethyl butyrate, then arginine, and then the glutamine. But the dose of glutamine is around 20 to 40 grams per day, and is also essential for the wound repair, used by intestinal cells within wounds for cell proliferation and inflammatory cells, including lymphocytes and macrophages. About the micronutrients. So micronutrients, about the zinc, around 40 milligram per day, then vitamin C, 2 gram, but we are using around 1 gram in each and every patient of diabetic foot or ulcers, then vitamin D, and then vitamin E and B12. So how it helps, what are the sources, and what are the benefits, which I have already shown, and I think this August Godin knows each and everything about this. About this is a paper on vitamin C improves healing of foot ulcers, a randomized double-blind placebo-controlled trial, and what this Jenny have shown, vitamin C improved healing of foot ulcers. Further studies are needed to determine whether there is a threshold effect for serum vitamin C above which therapy is ineffective, and whether there are better or lesser responding subgroups. Because of low cost, ease of access and administration, we recommend offering vitamin C therapy to all people who have chronic foot ulcer and potentially suboptimal vitamin C intake. So in my clinical practice, and this is I want to give a message that you give each and every patient who is having diabetic foot ulcer, is a chronic diabetic foot ulcer, 1 gram of vitamin C, if there is no contraindication, of course. If you are having renal failure, then acidosis, so in that situation you should avoid that. Then second is vitamin C and the management of diabetes, a literature review by the Khan And what they have shown, there is a need for additional human clinical trials on vitamin supplementation in individuals with DFU to fill the knowledge gap and guide clinical practice. Because they have taken 71 studies, out of that only 7 was in the human beings, 3 were on the human beings. Then there was a retrospective analysis of relationship between 25 hydroxy vitamin D and diabetic foot ulcers, and it was found that 25 hydroxy vitamin D is closely correlated with the DFU, and in the patients who are having diabetic foot ulcer, their vitamin D levels were low or very low, while in the patients who are not having diabetic foot ulcer, their vitamin D levels were higher. So that was also suggestive of that. And this is again another study where they have shown if vitamin D level was significantly associated with higher prevalence of diabetic foot ulcers among the Chinese population. It's a Chinese study where if you are having low vitamin levels and diabetic patient, the risk of having diabetic foot ulcer is more than the patients who are having a normal level of diabetic foot, the vitamin D levels. And this was a meta-analysis again in the Chinese population between vitamin D and diabetic foot ulcer wound in subjective meta-analysis, and where what they have shown, diabetic subjects with foot ulcer wounds had significantly lower vitamin D levels, higher prevalence of vitamin D deficiency, and higher prevalence of severe vitamin D deficiency compared with non-ulcerated diabetic subject. Again here, further studies are required to validate these findings. So again, vitamin C and vitamin D, these are shown the important. So what are the nutritional checklist for the DFU? One is validated malnutrition screening tool. You can use a MNA or you can use the nutritional risk index, anything you can use by that. Then the glycemic control, nutritional recommendation, energy 30 to 35 kilocalories, protein around 1.5 grams, and fluid around 30 ml per kilogram body weight. Key micronutrients, vitamin D, B12, iron, vitamin C, zinc, and what are the patient-driven care, which is important, chewing, swallowing safety, adopt diet for cultural reasons, all that. Then interventions are recommended for all patients who could benefit or now in the future from nutritional care. This is one of the study where they have shown nutritional treatment diabetic foot ulcer a key to success. And what they found, glutamine, what I have shown you 3 things. One is arginine, glutamine, and hydroxymethylbutyrate. So if a combination of these 3 have given, and they found a positive effect on wound healing and stimulus immune function. So a combination, and we have used in few patients. This is our personal experience, and you find this causes there is accelerated healing in these patients. So what are the new guidelines emphasizing nutrition for foot ulcer healing? New guidelines from the American Limb Preservation Society, they emphasize the role of nutrition in healing of foot ulcers in people with diabetes, including the importance of getting enough total calories, water, protein, and micronutrients like vitamin C. So again, to simply ignore the rule of nutrition in wound healing would be to neglect a powerful tool that can be used to our advantage to avoid the amputation and faster healing. And malnutrition, its relation with diabetic foot ulcers, severity and outcome, a review article where what they have shown, despite a large heterogeneity, all paper indicate that malnutrition is highly prevalent among the diabetic foot ulcer. And mind it is more than half or 2/3 of the patients who are in diabetic foot ulcer are malnourished. And lack of malnutrition might have a negative influence on DFU outcome, as we see in our clinical practice. So therefore, clinicians should pay attention to the nutritional status of people with a diabetic foot ulcer. This is again broader. So dear friends, to summarize, oral nutrition is a critical component in healing diabetic foot ulcer because it relates directly to immune function, glycemic control, and weight management. Healing begins to the inside, and pure nutrition can hinder the wound healing process. Therefore, a proper diet and controlled daily intake of protein, carbohydrate, and healthy fats must be a priority. So both, not only the protein, fat, and carbohydrate, but the micronutrients also plays the important role. Replacement of glutamine, arginine, and HMB that come essential in the catabolic process and cause malnutrition should be remembered. And there is a lack of high quality randomized control trials to evaluate the benefit of nutrition supplementation, DFU, and existing study use a wide range of outcome variables. especially on vitamin D and vitamin C. A lot of studies are going on, trials are going on, and then healthy eating can impact glycemic control, wound healing, and ultimately limb preservation. So I think it's a very important role in the management of diabetic foot. So nutritional plan should be done, and each and every patient should have a NRI done, nutritional risk index, and according to that, it can be supplemented. So thank you very much for giving me patience hearing.
Thank you so much, Dr. Goel, for that excellent talk and on a new dimension of nutrition and impaired healing in the foot. So we can improve and get patient better care. Thank you so much. I'd now like to give my coach.
Now I would like to invite Dr. Rana Bhattacharjee for talk on the HbA1c's uses and pitfalls. So Dr. Rana Bhattacharjee is MD Medicine and MRCP DM in Endocrinology, and is Associate Professor Department in Endocrinology, Medical College, Kolkata. So without wasting much time, I would like to hand over the podium to the Dr. Rana Bhattacharjee. Sir, please continue.
A very good evening. Thank you, Shriyada, and the day for this invitation. So today, I will just deal with a very important and practical topic, I feel, HbA1c, which is quite a commonly used test by physicians, how to use it, and what are the pitfalls that you need to know to have a proper utilization of this test. HbA1c plays a very, very important role in the management of diabetes, and its use is actually backed by various large multi-center studies, and therefore most of the world bodies recommend its use. I won't go into detail of its history, but as you can see, the history dates back to early 1960s, from where this test has gradually been developed, but it has been standardized and continued to be as a very important tool since 1993 after the publication of DCCT trial. Now, what is A1C? A1C is nothing but the hemoglobin, which spontaneously reacts with glucose to form a glycated derivative, and this reaction occurs in a non-glycated manner by formation of an intermediate sheep base. And there are different parts of adult hemoglobin. This is not needed to know in detail, but the important thing is that the major glycated portion is HbA1, and among this, HbA1c is the most important. Now, what is HbA1c basically? It is the glycated valine residue of beta chain of in the hemoglobin. Now, HbA1c assays can be based on their charges or their specific structure. Among the charge-based methods, HPLC is the most commonly used method, and electrospray mass spectrometry is a method which is used for standardization of this assay by IFCC. And among the structure-based assays, immunoassay is the most common one that is in use, and Born affinity chromatography is also used in some labs. It's very important to know the alignments of assays for A1C. What is alignment? Alignment is nothing but a kind of standardization where all over the world, if you get a report of A1C, it will have a same connotation. So after 1993, as I've said, after publication of DCCT trial, which was done on type 1 diabetes, there was a standardization of A1C. That effort is made, and worldwide, whatever A1C has been done, they refer to this particular method which was employed in this particular trial. Relatively recently, IFCC, or International Federation of Clinical Chemistry, they actually said that the specific residue of A1C that I was talking about, the N-terminal valine residue which is glycated, and this particular molecule has been used for reference standard. And there is a very complicated kind of conversion formula which no one should remember. To get an idea that between conversion of between these two kinds of units, there is a very simple rule of thumb called Kilpatrick's clutch. What is that? You get a value of HbA1c in percentage point with which you are familiar with, and you just apply a -2 formula. What is that? Say the HbA1c of 7, and you just apply this formula, that is -2 means 5, another -2 from 5, that is 3. So it's 53 millimole per mole. So that's the IFCC unit of HbA1c. Likewise, for any value, you can convert it easily. Another parameter that you have noticed in your HbA1c report is EAG. It is nothing but an estimated average glucose. This particular parameter has been derived from a study known as ADAG study, which is mostly validated in Caucasians. So you will also get this particular value in the HbA1c report that you can come across. Now, back in 2007, various world bodies like ADA, IDF, EASD, as well as IFCC, they formed a consensus, and they said that HbA1c should be reported in both NGSP and IFCC units. So not all lab follow this particular guideline yet in our country, but most of the good lab does. And the EAG, as I was talking about, the estimated average glucose, which was derived from the A1C value, should also be reported to get an idea, and patient rather will get an idea that what's his or her blood sugar level is on an average. Now let's quickly move over to a few of the interesting patients. A 48-year-old lady, known diabetic for 12 years, on basal bolus insulin and metformin, admitted for hysterectomy. HbA1c was found to be 10.6. And the patient is very meticulous regarding her blood glucose measurement by capillary blood glucose. And now you have tools, the various apps, where you can calculate the average glucose from there, which is much lower than what is reflected in HbA1c report. And fructosamine, which is another measure for average blood glucose over the last 3 to 4 weeks, showed a relatively better control. So what's happening here? Why this discrepancy between HbA1c and glucose? Anyone among physicians, anyone, can you volunteer? Why was this disparity? Why the A1C is relatively higher than the actual blood glucose that has been recorded? Well, the patient... Yeah, absolutely, because of anemia. Now, what does anemia do? I will discuss that part later on. It's specific to iron deficiency anemia. Actually, depending on kind of anemia, HbA1c report can be falsely low, can be falsely high. And it depends on multiple factors, okay? So that's the reason for disparity, and her hemoglobin was 7.5, iron was 12, and as you can see, the TIBC and ferritin also indicates iron deficiency anemia. A second case, a 63-year-old man, type 2 diabetes for 12 years, on limipiride and metformin, the compliance was poor, but A1C was just 3.8. Now what's happening here? You can see the fasting and postprandial is so high. So this is the report. So can you see the report properly? What's happening here? Why the hemoglobin is 3.8%? Any idea? If you look closely to this report, you can see it's not working. Okay, yeah. So you can see it's also not working. Anyway, there is a variant window there. So variant window that should not actually appear within this report unless there is some hemoglobinopathies. So after getting this report, the patient underwent the hemoglobin variant assay, and patient was found to have HBD homozygous variant, and that's the reason for particular interference and falsely low HbA1c value. So there are many factors which can interfere with HbA1c result. So this is the second part of my talk. Among these interferences, those can be method specific Because, by one method there can be inconsistency or interference, by another method there may not be any. And it can be due to inconsistent or different glycation, which can vary between one individual to another due to multiple factors and various changes in life cycle of RBC. So just to give an example, altered erythropoiesis, like when there is erythropoiesis, when it is slowed down, then A1C can increase. Deficiency anemias, it can be anything, iron deficiency, B12 deficiency, folate deficiency. Conditions like hypothyroidism, in fact we reported one in the journal that in a patient with untreated hypothyroidism, the HbA1c level was falsely high, even in the diabetic range in a patient, individuals without diabetes. But after treatment, the level came down. The similar interferences was not seen with hyperthyroidism. So among deficiency anemias, as I said, iron deficiency is one of the cause, and our patient that I discussed, the patient number 1, the first patient, she had iron deficiency anemia. So this is one of the cause of increased A1C in iron deficiency. Decreased A1C can be seen with administration of erythropoietin, iron, B12, and in presence of chronic liver disease, where essentially erythropoiesis is increased. Increased RBC destruction can actually lead to lowering of HbA1c, because the RBC lifespan is reduced, so there is less time for glycation. Whereas condition like splenectomy, where the lifespan is increased, the A1C can be falsely high. Alteration of glycation can also occur, like increased HbA1c can be seen in presence of alcoholism, some patients with chronic kidney disease, as well as iron deficiency anemia. This is the second reason why iron deficiency anemia patient can have falsely high HbA1c, because in presence of iron deficiency there is increase in glycation of hemoglobin by the glucose level. Decreased A1C can be seen in presence of high dose of aspirin, high dose of vitamin C and vitamin E. Plus there is some genetic influence. In fact, there has been a study that in Asians possibly, we are relatively less susceptible to glycation. So our HbA1c is slightly lower than the Western counterpart. But it's not only ethnic, it varies between one person to another. So with a similar degree of blood glucose level, A1C level may vary from one person to another based on the genetics. The assay factors are multiple, I won't go into detail, but conditions like hyperbilirubinemia or presence of carbohydrate hemoglobin, particularly if it is more than 4%, or hyperbilirubinemia where the bilirubin is more than 20, there is increase in A1C. On the contrary, hypertriglyceridemia can lead to falsely low HbA1c, and this effect is mainly seen in HPLC reports. And with hemoglobinopathies, the result can be variable. So you can go to NGSP website, you can get a huge, the big list is there. Depending on assay, you will know that which particular hemoglobinopathy is affecting your result of a particular A1C value. So I'll end my talk by saying that glycemic monitoring is a very, very important part in the management of type 2 diabetes mellitus. HbA1c is the most validated parameter for long-term glycemic control, and HPLC is most validated methods, but there are many problems as I've discussed, and there are some assay-specific problems, particularly with some hemoglobin variant, although many of the recent assays, they actually do not show any interference with those hemoglobin variants. And always consider potential interference that I discussed, particularly given when your report is not matching with that of the blood glucose level of a patient or clinical status. Always take a history and background, get a background information to unearth the cause of this discrepancy. Thank you for your patient hearing.
Thank you, Dr. Bhattacharya, for a fantastic talk. So I would request you to take your seats so that we can take questions after the last talk. So now to play the last over of our cricket match, we would like to invite our opening batsman, none other than Dr. K.K. Ganguly sir, who needs no introduction in this auditorium. Sir, please take your podium.
Thank you, Chairperson, sir. So if I can have the slides, yeah. Okay, so clearing the mist of myths. There aren't too many in way of myths here in this presentation, really. And just the last 5 or 6 slides, I've tried to put in absolutely new data so that this is not just company slides. So the first bit is company slides. The last 4 or 5, I've put some new data, which I'm definitely interested in. I'm sure you all are as well. So this is the financial disclosure. So now, if I start with the background, so I think this is a given. There are multiple drugs which have come up now. Diabetes management remains a challenge. So these are the starter slides. This is common for most of our presentations. GLP-1 receptor agonist, it targets many of the core defects in type 2 diabetes. So not just the glycemic bit, but also the glucagon, the incretins, the neurotransmitter dysfunction, stomach, intestine, everything. Now, I think this is a very important step forward, making injectable into oral. So I think this is a very, very crucial step, because that will open the gates for other products to make it from injectable to oral. So there are a few things which we should know about making it into oral. I'm sure in future more and more research will make it even better. I think research is ongoing actually, and I will briefly allude to it. Now this is the oral semaglutide and the HbA1c reductions in the Pioneer program. Now if you see here, I hope my mic is on. Yep, okay. So if you see here, as compared in monotherapy, I always want to know what is the HbA1c drop of 7 milligrams, because we start with 3 milligrams, then 7, then 14. And JJ was alluding to the fact that initially we don't get that much of a reduction with 3 milligrams, and the reduction begins to manifest only at 7 milligrams. So if you look at 3 milligrams, you will roughly get the effect of a DPP-4 inhibitor. So of say sitagliptin, so 0.5, 0.6. But here 7 milligram is when it begins to kick in. So you can see here in the placebo trials, it crosses 1%. So not many drugs do it. Not many drugs do cross 1% HbA1c drop. But here with 7 milligrams, we're able to drop by 1%. And the maximum we can say with 14 milligrams is 1.5. Now, if you look at the change in baseline, I think this slide perhaps is more important than the previous slide. Why? Because when we start an expensive drug like oral semaglutide, it's usually when the patients are beginning to fail on multiple drugs. And usually the HbA1c is more than 8.5 or 9% or more, or at least 2% above target. So what is the data of HbA1c more than 9%? How much HbA1c drop does it cause? And you can see here, across the data, it is 2% drop. So if we got an HbA1c of more than 9%, 9.5 can get it down to 7.5. This I think is more important than the previous slide, because majority of the patients, when we start at HbA1c of 9, and this is the drop that you will get. So you get a maximum of 2.6%. One drug causing 2.6% is a big thing. Now weight loss, we can see here, it beats almost all the competitors which were there. You can get up to 5 kilograms of weight loss with 14 milligrams. Now the multiple risk factors are there. So not only the HbA1c drop, GLP-1 receptor as a class,
I think they are far superior to the other agents as far as HbA1c drop is concerned and weight loss is concerned. Not many of us know that GLP-1 receptor agonists also drop the blood pressure. The blood pressure drop of GLP-1 and SGLT2 are almost comparable, except for the fact that the SGLT2 inhibitors perhaps cause a bit more of diastolic blood pressure drop as opposed to systolic. Waist circumference is about 4.5 centimeters. Now the mist. So I think is the dosing of the oral semaglutide complex. I think when we first started to prescribe, I would say yes. Let's not beat around the bush about it. I think yes. But now when we are into it, I don't find it that difficult. And I'll tell you practically কি কি অসুবিধা হয়েছে কয়েকটা পেশেন্ট নিয়ে। Just give me a second. So this is the company recommendation that you start with 3 milligrams to begin with. Now instruction is important, taken in an empty stomach in the morning. আমি সারাদিন না খেয়ে দুপুরবেলা নেব না, ওরকম নয়, সকালে উঠেই খালি পেটে নিতে হবে। You take with 120 ml of water, which is roughly equivalent to half glass of water. আমার কনস্টিপেশনের জন্য অনেকটা জল খাই সকালে উঠে, সেটা করা যাবে না। Half glass of water. More water you take, the absorption varies. Less water, more water, it varies. So half a glass of water, first thing in the morning, after 30 minutes, you do what you want. That's the guideline which I give. Now, it's very important to be very clear about this. Why? I learned it the hard way. তো আমার একটা পেশেন্ট দেখলাম 3 মিলিগ্রাম, 7 মিলিগ্রাম, 14 মিলিগ্রাম কিছু হচ্ছে না। কেন? না কোনো নশিয়া, না কোনো জিআই ইফেক্ট, না কোনো HbA1c কিছুই হচ্ছে না। কেন? ও কি করেছে? আপনি তো বলেছেন সকালে হাফ গ্লাস জলে, তো আমি ট্যাবলেটটাকে গুঁড়ো করে জলের মধ্যে গুলিয়ে দিয়ে খেয়ে নিয়েছি। So that will destroy everything. It will be of no use. Mind you, the absorption is only 1%. You have to be careful. তো কিছুই হয়নি। So now I have corrected my statement. ওষুধটা গোটা খাবেন, না চিবিয়ে গোটা খাবেন, মুখে দেবেন, জল দিয়ে গিলে দেবেন, হাফ গ্লাস ওয়াটার। সিম্পল। এটা উইথ প্র্যাকটিস ওয়ান্স ইউ বিগিন টু ডু ইট, দেন তারপরে এটা কোনো বড় হ্যাসেলই নয় এটা। সো টেক ইট উইথ হাফ গ্লাস অফ ওয়াটার ইন দ্য মর্নিং, আফটার হাফ অ্যান আওয়ার যা করার করুন। নাও এইখানে একটা জিনিস আছে, there it says 1 month. Now I am going to deviate from what is the recommendation. Recommendation হলো 3 মিলিগ্রাম দেবেন, 1 মাস পরে 7 মিলিগ্রাম, আরও HbA1c ড্রপ চাই, ওয়েট লস চাই, 1 মাস পরে 14 milligram. The question is 3 milligram is equivalent to efficacy wise roughly DPP4 inhibitor এর মতন। 7 milligram it crosses 1% HbA1c drop. তো প্রথমে কস্টলি ড্রাগ দিয়ে বলবে যে 1 মাস ধরে গেলাম কিছুই তো হলো না। So what I do is use common sense. First, do no harm. তা আমি কি কোনো ক্ষতি করছি যদি আমি 30 দিন না ওয়েট করি? So this is what I do. I cannot say that you should do it. This is not the recommendation. This is what I do, and vast majority of the KOLs around the country do it. কি করে? একটা পাতায় 10টা আছে, and this I must give credit to Novo. কারণ প্রথমে বিলেতে in the Western world, all the tablets come in strips of 30. So you, whether you like it or not, you have to take it for 1 month. But here, thanks to Novo, they have managed to say that no, we need to have strips of 10. So that's good thing. So what I tell the patients is, একটা স্ট্রিপে 10টা আছে, আপনি 10টা 3 মিলিগ্রাম খাবেন, this is what I do. তারপরে I go to straight to 7. And I might wait for 1 month for 14 milligram. So that way, when I ask the patients to come for follow-up in 1.5 months time, I see, the patients see for themselves the big drop. নাহলে কি পেশেন্ট বাড়িতে বসে বসে চেক করবে, 1 মাসে কিছুই ড্রপ হলো না। But when you go from 3 to 7, then the real drop begins to happen. So this is what I do. So this is the instruction which I give. Wake up, half glass of water, 30 minutes, then you have whatever you want. So injectable ki better than oral semaglutide? তাহলে এটা আমাদের দেখতে হবে যে দুটো লেভেল কি এক? This slide which I am going to show you is a bit misleading. আগে বলে দিলাম। কেন misleading? Now see, exposure response relationship is similar to oral and subcutaneous semaglutide. এই স্লাইডটা কিরকম মনে হচ্ছে যে ওরাল দিলে যা লেভেল আসবে সেমাগ্লুটাইডের ইনজেক্টেবল দিলেও তাই লেভেল আসবে। This is what is this graph, what does it show? That the level is seems to be the same, the HbA1c drop and the semaglutide level. But that is not. So I went into the website. This is not published. This was presented as an abstract somewhere. So I went into the website, it's a key. So what I found was this. Look at the top. This is population PK, pharmacokinetic and exposure response analysis based on average semaglutide concentration. তো সাস্টেইন আর পায়োনিয়ার দুটো ট্রায়াল আলাদা করে মডেলিং করে তারপরে এটা বলেছে। ইট ইজ নট যে আমি একটা পেশেন্টকে সাবকাট দিলাম আর ওই সেম পেশেন্টকে ওরাল দিলাম তারপরে দেখলাম semaglutide level সেম আছে। So that is not the case. This is a model data to suggest that possibly, mind words, suggest that possibly the levels are the same. If you tell me with a gun on my head, bolun, subcut better নাকি ওরালটা বেটার, I would say subcut, কারণ এই অ্যাবজর্পশনের গন্ডগোলটা থাকে না if you put a gun to my head. But এটা একটা আছে obvious একটা ডেটা দেখিয়েছিল ড্যানিয়েল ড্রাকারের, it suggested that they have similar levels. But I really need good data for patients who were given injectable and oral, same patient on a separate days to show the semaglutide level, to say that the subcut and the oral levels are the same. So what do patients prefer? So patients prefer non-injectable therapy. I think Dr. J.J. Mukherjee showed you that before they showed the patient the injection of dulaglutide, 75% opted for oral. After showing it, still 55% opted for oral and 45% for injectable. But here, I think the patients, the cardiologists, everybody wants oral. So again, is the efficacy of, or I think these slides are quite relevant, is the efficacy of oral sema in Asian population comparable to the Western world? So if you look at the data here, the pioneer, now look carefully. This is white, this is black or African American, and this is Asian. So look carefully, white, African American, Asian, white, African American, Asian. So if you look at the data, and I'll take out the comparators, so you see here, Asians seem to do much better than the whites or the African Americans, all throughout. So that's the data you can see. So weight loss, what myths are there? So I think the one thing, I think this I can tell you from my personal experience, and I'm sure a lot of you who have used it will also echo my thoughts. So these two mechanisms, basically, it reduces the food cravings and increases the satiety. So what I asked my patients, ki hocche, actually what is happening? With SGLT2 inhibitors, there is no changing appetite, probably there is some increase in appetite. But with oral semaglutide, আচ্ছা আপনার খাবারটা কি চেঞ্জ হয়েছে? You will find many of the patients, metformin যারা নিচ্ছে, they go off non-veg food. বলে আর আমার মাংস খেতে ভালো লাগে না, মাছ আগে খুব ভালো লাগতো সেটা খাই না. You might have noticed this. Why does that happens? I don't know. But with the oral semaglutide, বলে আগে আমি 5-6 পিস মাংস খেয়ে নিতাম, এখন 2 পিস খেয়ে আমার বেশ। So আমি যদি এমন নশিয়া করে নিলাম, মেটফরমিনে যারা মাছ খেতে পারছে না তাদের দুঃখ লাগে, মাছটাকে ভালো লাগতো এখন আমি খেতেই পাচ্ছি না, তো কিছুই খেতে পাচ্ছি না মাছটা। তো এখানে তা নয়, এখানে হোয়াট ইউ লাইক ইউ উইল বি ইটিং, বাট লেস অ্যামাউন্ট গিভস ইউ স্যাটিসফ্যাকশন। দ্যাট ইজ দি কি আই থিঙ্ক। দিস মাল্টিপল পেশেন্টস হ্যাভ টোল্ড মি যে আমি যা খেতাম অল্প অ্যামাউন্টে সেটা আমার সন্তুষ্ট লাগছে। দিস ইজ দি দিস আই ফিল ফ্রম মাই পার্সোনাল এক্সপিরিয়েন্স। অ্যান্ড দি আদার থিং ইজ the body composition, the body fat mass goes more than the lean mass. So if you see here, this is one, I've gone through this data, this was with 15 patients, and what they found was that if you look, the body fat mass was much more
as compared to loss of body lean mass. There is emerging data with the, see, there is, I will not be belittling SGLT2 inhibitors at any time point. It's a marvelous drug. Kintu, কয়েকটা patients you may have noticed, they say that খুব weakness লাগছে. So I went through data about sarcopenia with SGLT2 inhibitors. There are indeed a lot of studies, muscle strength studies, which suggest that there might be some reduction in some subgroup of patients. In ekhane, it is only the body fat mass which goes down, not the lean mass. I'm yet to see any comparative data of GLP-1 with SGLT2, a muscle mass strength কম হচ্ছে কিনা. But none of my patients so far on oral GLP-1 receptor agonists or injectable liraglutide or dulaglutide, none of them have complained of weakness হচ্ছে. That none of them have complained. So other medications, I think we all know this. I think the most important is the L-troxin. So L-troxin সকালে উঠে খেতে হয়. এটাও instruction আমরা দিই. অনেক patients, Shomik had presented data about hypothyroidism and diabetes. So what to do? So there can be two options. One, you take the semaglutide first. After half an hour, then you take the thyroid, or after 1 hour you take the thyroid tablet. After half an hour you have the food. আমি ঘুম থেকে উঠে 5 মিনিটের মধ্যেই চা খেতে চাই, তা হবে না তাহলে 1 ঘন্টা ওয়েট করতে হবে. That is too much to ask from a Bengali. So the other alternative is you ask the patient যে আপনার দুটো খাবারের মধ্যে গ্যাপ 4 ঘন্টার বেশি কখন হচ্ছে, সিম্পল. বলে হ্যাঁ আমি সকালবেলা ভাত খেয়ে বেরোই 8:30টায় আর দুপুরবেলা আমি 1:30টা নাগাদ খাই. That's it. 5-hour gap is there. So you take it at 1 o'clock, have your lunch, take the L-troxin at 1 o'clock, have your lunch at 1:30. If you look at the Western data, and you see here, now this is not applicable to us. এই স্লাইডগুলো দেখানো হয় ঠিকই, not applicable to us. Why? Because in the Western world, they might take their dinner at 7 p.m., go to bed at 11 p.m. ওখানে you can say take the thyroid tablet bedtime. If you look at Davidson's book of medicine, Davidson's কিন্তু thyroid dose not morning, ওখানে লেখা আছে bedtime for this reason. কিন্তু আমরা তো রাত্রি 10টা 10:30 খেয়ে 11টা ঘুমিয়ে পড়ি. So it is not applicable for us. So practically speaking, find out 4 ঘন্টার বেশি গ্যাপ কোন জায়গাটা হচ্ছে. যদি গ্যাপটা সন্ধ্যেবেলা হয় যে আমি একটার সময় খেলাম, তারপরে আমি স্ন্যাক্স খাই, দুপুর একটা লাঞ্চ খেলাম, স্ন্যাক্স খাই 6টায়, তাহলে আপনি 6টা থেকে 5:30টার সময় আপনি থাইরয়েডটা নিয়ে নেবেন. That's the simple thing. How much difference will there be if you take thyroid in empty stomach as opposed to in a full stomach? So about 80% absorption in empty stomach with thyroid tablet, and 60% absorption if taken in full stomach. So I think this is the, so I've got very little time, so I wanted to show you the last few slides. Comorbid conditions, elderly, no dose change, hepatic and renal impairment. You've got studies now down to about EGFR of 25. Studies have been done with upper GI tract disease showing that there was no difference in the PK/PD data. So that's commonly asked question. Elderly, chronic liver disease, stage A, B, C te ami debo na, kono oshudhi debo na, only insulin. And in renal impairment. Is there increases to retinopathy? A very pertinent question. Trials se dekha gachhe je otota high noy, but you have to take it with a pinch of salt because patients with active site-threatening retinopathy might not be included in the trial. So that might not give you the full picture. But what it has shown is that majority of the time, sudden HbA1c drop is what begets worsening of the retinopathy. So I think this is the summary, but just give me, Chairperson sir, madam, just give me 2-3 minutes. I'll just show you the latest which is happening in the world with oral semaglutide. Now this is the SELECT study. It has not come out yet. The SELECT study is the largest cardiovascular outcome trial. Now I'm going to read it. This is one of the largest CV outcome studies in the field of obesity. This enrolled individuals with overweight or obesity, as BMI more than 25, without diabetes, mind you, no diabetes,
with cardiovascular disease. So, non-diabetic patients, overweight or obese. And this is 17,000 patients were there. And you can see here, about 76% of patients had an MI in the past. An average BMI was 33. So we are really looking forward to the outcome of this study. And actually, this is the top line result, which suggested that there was a positive benefit, reduction of MACE of about 20% of patients in this group where there was no diabetes, just obese. The last one is the flow study, because you see, with the GLP-1 receptor agonist, if you see here liraglutide, glutaglutide, oral sema, exenatide, and in the amplitude O study, composite renal endpoint, all of them showed benefit. Well, what was the driving factor? What caused the benefit? If you look, it's macroalbuminuria only. If you look at the worsening EGFR or renal replacement therapy, all of them crossed the midline. So this unanswered question remained that therefore GLP-1 receptor agonists কিডনির উপরে অতটা ভালো কাজ করে না, খালি অ্যালবুমিন কমানো তো সব কিছুই কমিয়ে দেয় অ্যালবুমিন, পায়োগ্লিটোসনও কমিয়ে দেয় অ্যালবুমিন, DPP4 ইনহিবিটরও কমিয়ে দেয় অ্যালবুমিন। তা কী লাভ হলো যদি আমি এই জিনিসগুলো না কমাতে পারি, the worsening EGFR or RRT. So therefore this trial is very, very significant. This is the FLOW trial, patients with type 2 diabetes. You can see there, EGFR more than 25, second line, plus albuminuria. Okay? So starting from urine ACR more than 100, with EGFR of more than 25. Primary endpoint, this is the only GLP-1 trial with kidney outcome as the primary endpoint. বাকিগুলো exploratory ছিল. Primary endpoint, kidney failure, persistent more than 50% reduction in EGFR and death from kidney or CV disease. So এখানে you can see there, they are given 1 milligram of subcut semaglutide weekly. In this group, about 15% of patients were also receiving SGLT2 inhibitors. Now, this is the group. So this follow-up period was about 5 years. So এইটা is what we were looking forward to. যে এই ট্রায়ালে যদি semaglutide দেখাতে পারে যে প্রাইমারি আউটকামটা আটকে দিয়েছে, then that will be a game changer for the GLP-1 receptor agonist. So the top line result, I cannot show it on the slide, for some reason it hasn't got downloaded here. So top line result is that there is benefit and the trial had to be stopped because there was benefit. এখন আমাকে এটা দেখতে হবে, mind you have to be careful. You see the primary endpoint is time to occurrence of kidney failure, persistent more than 50% reduction in EGFR, death from kidney or CV causes. What if death from CV cause-ই মেইন হয়ে গেল, এগুলো কমালো না, তাহলেও তো primary outcome ভালো হলো. So I have to see that. So we have to see, wait for the results. But that is good news at least. So I think with that I end. Thank you very much.
Again, our opening batsman played well the last over of the cricket match. So now this session is open for the discussion. So we would like to have some questions from the audience for our August speakers. So audience. Sir.
Yeah, my first question is addressed. Yeah, please. I think you can join up on the stage. I think that will make it easier because quite a few empty chairs there. And with JJ having left, so we have got enough chairs for everybody. So basically, my first question, I think because we have got some spare time left,
Yes,
we
sir.
finished before time. Honestly speaking, this is an opinion I would like to have from Kullan. We all know that please sit down. I mean, there's no need to stand up. It's not a punishment session. So basically, my question is, we all know that GLP-1 receptors produce they've got an excellent results on the weight reduction on diabetic as well as non-diabetic patients. But nowadays we're getting a newer class of molecules. They have not hit the market as yet. GLP plus GIP combinations, tirzepatide and the others. So honestly, based on the available results so far, because in ADA there was an excellent session on the obesity and weight reduction. And there are some other new classes of drugs like orforgliplosin. I'm sorry, I cannot spell the name properly. So what do you think is the effect, or what do you think is the reason behind a superior weight reduction with these classes, the GLP plus GIP, compared to the simple GLP alone? What do you think is the reason?
So I think here the glucagon comes into play. So glucagon, you see, GLP-1 mainly it's the appetite suppression or satiety. I was forever looking for a drug যেটা আমি যা খাচ্ছি খাবো কিন্তু ওজন কমাবে সব বাঙালি তাই চায় so whether it increases the basal metabolic rate thermogenesis so here glucagon based therapy comes into play.
But does it really increase the thermogenesis?
It does increase. Animal studies have shown it does increase the thermogenesis. So I think this is part of it. I think, and there is a combination. Glucagon on its own will also cause weight loss. Will also cause appetite suppression and thermogenesis both. But GLP-1 doesn't.
Yeah, but again, this is the thing that with the GIP, how much do you expect the ambient glucagon level to go up?
Ambient?
I mean, the baseline glucagon level.
I cannot, I have to go through data to really suggest that how much it goes up. But it just goes up significantly. The important thing is, it is also glucose dependent. So when your blood sugar drops below 105, then the glucagon rise is not that much. So therefore, there is protection against hypoglycemia. So if you have hypoglycemia, glucagon has to go up to protect you. So these drugs are good in a way that if it drops below 90, it shuts off the glucagon increasing ability. Below 100, and I think 101.
But that thing happens with the GLP also. With the GLP also.
But this group of as well. So I think I cannot exactly tell you the figure is 101 and 102. Below that, the glucagon increasing ability drops markedly, and it drops to 0 up if it's below 90.
Yeah, but how do they explain the weight loss?
No, weight loss, the blood sugars are always high. I'm trying to tell you that they are safe
no, but
as well.
A lot of these studies were done on, say, obese patients, non-diabetic patients.
But the blood sugar might be more than 90. It's not necessarily it is less than 90.
Do you really seriously think that a difference between 100 and 90 is going to make a substantial difference?
Difficult to say. I think if I look at the SELECT trial, even when they tried to select patients who had not had type 2 diabetes, majority of them had impaired glucose tolerance. There has to be. Majority of them had impaired glucose tolerance. So there has to be. So whether you are saying that somebody having an average glucose of 90 as opposed to somebody having an average glucose of 105, whether there is any differential effect, I cannot say that. I don't know.
The other issue, I mean, I have not read it anywhere, that's why I'm asking you. Is this class of agents, like the GLP, GIP combination together, or some of these newer ones that are coming up, are they associated with an increased risk of pancreatitis?
Well, I think the GLP-1, funnily enough, if you look at the meta-analysis of DPP-4 inhibitors causing pancreatitis versus GLP-1 causing pancreatitis, one would think that GLP-1 would cause probably more pancreatitis, but that is not the case. It is the DPP-4 which causes more pancreatitis than the GLP-1 receptor agonist. If you look at the meta-analysis of the pancreatitis data, there is. Why? I've asked several places, no answer.
There is no answer. There is no
answer. So combination of these, so far, I don't think it has raised any adverse signal for markedly increasing pancreatitis, so far.
Okay, the next question, no, I should not say it's a question, it's a comment mainly meant for Rana. We all know that this is, I think, one issue which we should always emphasize to the audience, is that we use HbA1c right, left and center for assessing the glycemic control of any patient. But for example, when the patient has got a CKD, there's a significant component of this carbamylation of hemoglobin.
I mentioned 4%, more than 4% carbamylated hemoglobin
takes place in EA. But the practical problem that we face when we're dealing with an anemia patient or say somebody with a CKD is exactly how do you corroborate it into real terms?
Right. The thing is that in CKD, again, just like iron deficiency anemia, there are multiple factors which is influencing HbA1c levels. It's not only carbamylated hemoglobin, but again, altered RBC lifespan is also
pH
there.
And all these things.
And associated, like a patient undergoing hemodialysis, that also contributes. So there are many factors, many drugs that has been used in patients with CKD. But
there is no better marker as of now of long-term glycemic control, which performs better than HbA1c.
And
so still, we do HbA1c plus multiple time CBG monitoring. So that's the possibly standard of care as of now.
And
can be replacement for in those case scenario?
Again, EGFR for what? I mean,
via CGM, estimated A1C via CGM.
Okay, by CGM. Again, that's not a very standardized parameter, and it has not been studied, but it should work because, as I said, that blood glucose level per se, so it's based on the blood glucose level or interstitial glucose level, that is not that altered in presence of CKD, so that should work better, but it's not yet validated as far as I know.
Dr. Rana, in gestational diabetics, would you use fructosamine levels more frequently, or?
Again, fructosamine is a theoretically very interesting test, but problem is that unlike HbA1c, where we have NGSP or IFCC standards, in fructosamine there is no such standardization worldwide, and there are many variabilities among different assays. The assay is relatively easy, but as standardization is not there, the actual level is problematic. Personally, I do rely most on SMBG, then possibly HbA1c, mainly to see the trends rather than have a particular target in a woman who is pregnant.
Just a relevant question taking on the same line. How reliable do you think SMBG is actually in the monitoring of gestational diabetes?
Yeah, it's quite reliable. In fact, it's the most reliable test that we have in our hand. So SMBG is
the reason why I'm asking
one.
this question because this is based on a particular case study which I came across when I was working in UK. This was a 30-year-old nurse, second gravida, with gestational diabetes. She was a nurse in the hospital that I was working in. And her HbA1c was done at that time because my boss at the time would insist on doing an HbA1c every 2 to 3 weeks. That is again a non-validated way of looking at the things. But as we all know that HbA1c has got the highest weightage in the last 1 month. Now, what we found out in that patient was that the HbA1c was not at all tallying with the SMBG results. So we decided to put this patient on a CGM. And what we came across was that she was monitoring the SMBG, say pre-breakfast, post-breakfast, pre-lunch, post-lunch, like that. And the dinner she was taking at around, say, 7:30 or 8 because she was finishing a shift and going back and having the dinner. So it was a late dinner. We found out that around 5 or 6 p.m., or maybe a little early, I don't remember the exact time, she was getting a huge surge because she was getting a lot of snacks. And that was one of the reasons for the discrepancy of the HbA1c with this sort of thing.
Yeah, that's why in pregnancy you always insist for multiple time testing. That's always preferred because we know the post-lunch surge is expected, or I mean post-meal surge is expected. So whenever a patient takes a large snacks, it's better to check a blood glucose after that.
Yeah, but this was not a post-meal lunch surge. This was more of a, I should say, a post-meal, pre-dinner,
Pre-dinner.
evening
Actually,
snack
pre-dinner high blood glucose is the most difficult thing to control in a clinical practice. That's true not only in pregnant women, but also in other patients who are on SMBG, I mean MSI. Still, pre-dinner is the most difficult component what I think all of us face. So it's not specific to pregnancy even. It's there.
Sir, I have a question for you. Sir, we have a very large population which belongs to the tribal community. Even in West Bengal, especially the southern part of West Bengal, large population of having tribal origin. And the prevalence of hemoglobin, different hemoglobinopathies among tribal across India is anything between 3% to up to 16%. So shall we take HbA1c as a diagnostic threshold among these population with a pinch of salt? Or we mandatory go for screening of the hemoglobin erythropoiesis along with the HbA1c?
I think there are 2 points. Number one, as a diagnostic threshold, as you have said, I think I'm a bit skeptical about using A1C in diabetes, diagnostic threshold in non-tribal or the person without hemoglobinopathy as well, because of the standards of various labs that vary quite widely. But again, if it's done from good lab, it can be used. That's number one. Number two, you can get a clue about hemoglobinopathy from the graph of, if you do it by HPLC, not by immunoturbidometry or not by other immune-based methods or by proton affinity. If you do it by HPLC, I would suggest everyone to please look carefully to the graph and the various retention time and area under curve of various components of hemoglobin. There we will get a clue. So if there is a clue that a particular, say, variant window is more and others, hemolysis can be picked up by PP3 fragments. So if those are relatively higher, then always advise for conventional HPLC study for hemoglobin variant. And once the variant is found, then depending on what variant it is, you can choose a particular assay. So as I've said, like the most common one in our part of the world is HBE, and that's the most common, followed by HBC possibly. And those are usually, they do not interfere with the standard which we commonly use, the Biorad, Retain or Transasia usually assays, and few of the Tosho assay, maybe there is interference, and you can get this updated information from the NGSP website. So you can do it accordingly.
Thank you, sir. And one last question from the Ganguly sir. Sir, what are the percentage of your patients who are tolerating 40 milligram of, say, oral semaglutide?
In my practice?
Yes, sir.
I would say about 20%, not more.
So that's why I wanted to ask. Same is happening with us also. Most of the patients, we are going to the 14, now coming back to the 7. So his gastric upset is very common and cumbersome with the 14 milligram.
Yeah, so I think so warning the patient beforehand does help, because patients then begin to think that the doctor has warned যে এগুলো হতে পারে, তার মানে ভালো কাজ করছে, তাহলে একটু খেয়ে যাই. And you have to tell them that if you keep on it, then probably the GI effects will begin to wane after a while. But yes, majority of my patients are on 7. And about 20 to 25, quarter of them are on 14%, 14 milligram.
Rakesh,
but with the 7 milligram it works, so kaaj hoye jay.
I fully agree with Kollan. In fact, more than 80% of my patients, first of all, they could not tolerate more than 7. Yes. And majority of them had a very good response with even 7. Yes. So for the large majority, I don't need to up titrate to 14.
That's what we are also getting the results. So that's why I asked. So thank you, sir.
I have a
last question from the audience, because now we are running late by 5 minutes.
Somik sir, totally untouched. I have a question for Somik sir. Sir, as a topic on sensitive issue, pregnancy and thyroid. In case of viral thyroiditis or newly diagnosed Hashimoto's, there is transient elevation of thyroid hormones. In normal case, we have time, we can wait and watch. But how we can handle those cases in our primary care setting? Considering the anxiety issue from patient side.
So you're talking of pregnancy with T3, T4 elevation and a TSH suppression.
Yeah.
So again, we go by the usual standards, the good old method, history examination. So if there is a history of a preceding upper respiratory tract infection, neck pain, fever, tenderness on palpation, often the pain is referred to the jaw, to the ears. If there's an elevation of ESR, if the T4 is more elevated compared to the T3, they go in favor of a thyroiditis. You cannot usually do a scan in pregnancy, you can do the TSH receptor antibody test. The TSH receptor antibody test would be positive in most cases of Graves' disease. So these are the ways to separate, and of course wait and watch, because hypothyroidism hurts more in pregnancy compared to hyperthyroidism. So unless it's a overt hyperthyroidism, placing the patient at a risk of a thyroid storm, you can always wait and watch, or give a low dose of beta blocker, wait and watch. So the usual methods.
Okay. Thank you, sir.
Fortunately, it is very, very rare to have
thyroiditis.
Usually either Graves or gestational thyroiditis.
In normal cases, we can wait, we can do many investigation, but problem is that anxiety is from patient side, where myth is there. Oh, I have, yeah, thank you, sir.
So thank you all speakers, thank you all audience. So here comes the end of the scientific session, and now we are handing mic to the organizers for the Thanksgiving ceremony.
From our end, to Dr. Somik Goswami, to Dr. Rana Bhattacharya and to Dr. Kollan Kumar Ganguly. Thank you to all. Now I am invite Dr. Mary D. Cruz, our Vice President, as well as the Joint Organizing Secretary of the Daycon 2023, to give the Thanksgiving.
So just a short Thanksgiving. I'd like to thank all the delegates who have stayed back till the end. Particularly our thanks to our chief guest, Professor Dr. Azad Khan, who came all the way from Bangladesh. He has been very encouraging to us and has been our mentor. In fact, for those of you who didn't attend the inaugural program, he spoke about a program that he's doing in Bangladesh where the imams and the priests and church leaders are taking the message of diabetes awareness to the grassroots level and to everybody irrespective of their status. I'd like to thank our delegates and of course all the esteemed speakers for their excellent talks and thought-provoking ones, and also the patience with which they answered all the questions. I'd like to thank Mr. Indrajit Majumdar, the backbone of the Day organization, our president, Dr. Apurva Mukherjee, our scientific chair, Dr. Sujay, who has put together such a fantastic scientific program and got such lovely speakers. I'd like to thank our secretary, Dr. Rakesh Kumar, acting president, Mr. Amlan, particularly Madhumati for all the background work that she has been doing. I'd like to thank the hotel staff, our industry partners for their academic grants, and our partner, Holos Healthcare Foundation, for their support, the National Executive Committee, the Organizing Committee, and the AV team, which has helped to keep us heard and seen. If there have been any inadequacies, I'd like you to forgive the Organizing Committee, but if we have reached out to you in terms of academic program, I'd like you to give us your feedback and let us know what you would like planned next time. With that, I'd like to thank you, and dinner's ready.